Chalo, that's fine. Well, a very good morning to all my the colleagues, the audience, and the chairpersons. I'm just going to start the meeting.
Dr. Verma, just a request, you open Zoom as well as WebNext platform also. I request you to kindly close or mute the WebNext platform because the sound at WebNext platform reaches after 10-15 seconds, sir.
Just a minute.
So, is there a separate link for that? Because
sir, for the
just a minute. Hello.
Yes, sir, you're audible, sir.
Is it okay now?
Yes, sir, absolutely.
Okay, the very good morning to all the audience and my fellow colleagues, the chairpersons. First of all, I must thank Dr. Atya and his organizing team for giving me this opportunity to moderate this very important sessions. And I must compliment the organizers for having picked up such an important topics which are really important for the people who are interested in the gastrointestinal surgery, especially the solid organ. Most of the development and technological advancement have taken place in the solid organ technology HD. Maybe the robotics and maybe the advanced laparoscopic surgery. So I think that without wasting time, because we are already late, I think we have got the galaxy of speakers, right from Dr. Anil Agarwal and to Dr. Senthil. And we have really very important topics to cover. And I'll request all the speakers to kindly stick to the time. And if we can save few minutes so that we can complete this session well in time, because we are already late by say 15-20 minutes. So may I request my fellow chairpersons to kindly introduce Dr. Anil Agarwal actually.
It is a proud privilege at my end to present to you Dr. Anil Agarwal, who is a leading surgical gastroenterologist and a liver transplant surgeon, and is a director of two major teaching institutes in Delhi, GB Pant Hospital and Ambedkar Hospital. Dr. Anil Agarwal, please, you may start with the deliberation on cancer gallbladder.
Good morning. Thank you, chairpersons, and thank you, Dr. Atya and the team for giving this opportunity. And I'll mainly talk about the laparoscopic or minimal invasive approach to the management of gallbladder cancer. But before that, probably I can take you through a little bit overview of the surgical management of gallbladder cancer. And we know that gallbladder cancer comes in these various categories. And of course, we want to rule out metastatic gallbladder cancer, which you can see at the bottom. And the other ones, we have to see whether they are resectable. And the first two which are clubbed together is incidental gallbladder cancer and gallbladder cancer limited to gallbladder, which most centers would offer surgery. And it is this middle group in which, as the surgical advancements have occurred, and so has the post-operative care and adjuvant treatment and neoadjuvant, more of these can now be brought into a resectable range. So I think we all know about this Alfred Lelock's article in 1924. I mean, it still is quoted very often in the literature, but that is because some of the people still believe in a realistic approach while the world has moved on. And I think we have improved since that time because now we can more accurately stage the disease. And there's improvement in cross-sectional imaging, EUS, PET. And as you can see that if you scan the literature, earlier there was a high percentage of patients in which you could find metastatic disease when you went in. Whereas now with very good cross-sectional imaging, that is more restricted now to surface liver metastasis or peritoneal metastasis, which may be a surprise when you go in. And now we have been able to also, as we went along, that identify patients who would or would not benefit from surgery. So that means you can more accurately detect metastatic disease and avoid any kind of surgery in these patients. Or you can also do an intra-aortic lymph node sampling, which nowadays we do with the endoscopic ultrasound, and determine the locoregional advanced disease so that you can decide whether it is resectable with adjuvant treatment or do you want to do a neoadjuvant and go ahead for surgery? And avoiding non-therapeutic laparotomy, the surface liver metastasis or peritoneal metastasis, or at times the intervertebral lymph nodes can be assessed by a staging laparoscopy. And so to set the tone, let us talk about that. What is an adequate resection? I've put it into two categories. One is when it is limited to the gallbladder. That means what is the standard radical cholecystectomy, and for loco-regionally advanced disease, which needs more aggressive resection. And we all know about this, that in radical cholecystectomy, there may need two components, liver resection and also the lymphadenectomy. And lymphadenectomy, if not more, it is as important as liver resection, because even though liver resection thrills us, but it's the lymphadenectomy which determines the overall prognosis. So this is just pictorially showing you segment 4B5 resection, and that is extrapolating from the right hepatic vein, which is brought onto the surface. This is marked by the intraoperative ultrasound, and so segment 4B5. And all these categories of lymph nodes along the hepatoduodenal, along the hepatic artery to the right of celiac, and also the behind, that is the retropancreatic lymph node. Now, bile duct excision, some people talk about the T2 and beyond, you should do a bile duct excision because it may lead to better neural clearance. However, if you look at the literature, it doesn't add to survival advantage. And so we, similar to a lot of other centers, would do it as a selective rather than routine, which could be direct involvement, that is a neck tumor, positive cystic duct margin, or like as you can see, choledochal cyst as in this picture, or this one you can see a papillary tumor in which there is a tumor inside the CBD. And in some cases, you may not be able to distinguish, especially in incidental gallbladder cancer, whether it is fibrosis or tumor. So you may resect the bile duct, and it's a post-op histology which will, or frozen section histology which will help. Now, the more advanced is the T3, T4, and this is the AJCC 8th edition. And as we are all aware that they have divided into 2A, 2B, based on whether it is on the peritoneal side or on the liver side, or T2 stage, and T3, T4 is when it goes beyond. So apart from a standard radical cholecystectomy, which includes either a wedge or a segment 4B5 resection plus lymphadenectomy, adjacent viscera, depending on how far you can go, is required. And when you have adjacent viscera involvement, the question that you need to ask is this R0 resection feasible? And feasibility is not just based on the disease or the stage based on cross-sectional imaging. It is whether the patient is in a stage to withstand that, because some of these may need a hepatopancreatic duodenectomy. And can we optimize the patient? And then you have to have an eye on, based on your personal skills, your center infrastructure, and whether you're able to deal with any problems, whether you can do it within a reasonable morbidity mortality to justify the survival advantage in these patients. And just to take you through some of the things which have happened over the last 2 or 3 decades, is that the surgical procedure has been standardized to tell us that what to do and what not to do. We, as surgeons, have realized more and more that it's the lymph node clearance which is very important, and extent of surgical resection is tailored to the disease stage. And in this regard, I would like to highlight some of the important things which has happened. One of the things we also published long ago is that when there's a limited gastroduodenal involvement, you do not need a pancreatoduodenectomy, and you can get away with doing a distal gastrectomy and proximal duodenectomy, and which leads to a prolonged survival. And most surgeons would be afraid, we know that the results of pancreatoduodenectomy are not so good in gallbladder cancer. And the other thing is, when you needed an extended right hepatectomy, you can preserve a segment 4A if oncologically you don't need to remove that, because even when the hepatic hilar vessels are involved of the right side. And now we have techniques to improve the future liver remnant and thereby reduce the risk of liver failure. And the latest kid on the block is ALPS, though very few case reports are there in which people have used ALPS for gallbladder cancer, but that is also an option, more for probably a portal vein embolization or failure, or you would call it a rescue ALPS. And so resection loco-regionally advanced can be done now with reasonable morbidity mortality. And there has been improvement in perioperative care, there has been improvement in neoadjuvant and adjuvant chemotherapy, and so safer aggressive resection without compromising radicality and adequacy of the surgical procedure has evolved. And just to take you through, normally most of the time a wedge or a segment 4B5 is good enough. But when we have more extensive involvement, like as on the right side of the slide, you need to do an extended right hepatectomy. And when you needed an extended right hepatectomy, especially in gallbladder cancer with jaundice, you can actually preserve the segment 4A, because oncologically that may not be required. You can see that PTBD catheter. And this gives that additional liver tissue which can reduce the risk of liver failure. And just to try to highlight that even in gallbladder cancer with jaundice, you do not always need to do a extended right hepatectomy. You can do a parenchyma preserving segment 4A, 4B. As you can see in this slide that we have come from both sides, segment 4B and 5, and that's the hilum. And you can see that this is the right duct and this is the left duct, and hepatic artery, right hepatic artery is there. Just one of the cases in which you can see the anterior posterior sectoral duct, and this is the left duct. And you can see that even with 4B5, you have a reasonable resection margin over the tumor area. So even with segment, even though there is skepticism in the literature, and some centers believe that all gallbladder cancer with neck involvement should undergo an extended right hepatectomy, but that is not the case. And we have some reasonably good survivors even with segment 4B5 resection. And also another thing, this is what we presented and published in the IHPBA Korea meeting, that even when right hepatic artery is involved and you are not able to reconstruct it, you can ligate it and still go for a parenchyma preserving resection, that is segment 4B5. And when there is adjacent visceral involvement like duodenal involvement or gastroduodenal involvement, where there's minimal involvement, you can do a sleeve resection. Where there's more than that, you can do a distal gastrectomy and proximal duodenectomy, as you can see in this case. Same is with colon. You can do a sleeve resection or a segmental colectomy or sometimes right hemicolectomy. And not all cases have transmural involvement. This case had a transmural involvement. And in some of the cases, you may need to do both. In this, the bile duct could be preserved, and we had to take out a segment of colon and the distal gastrectomy duodenal resection. Now, this is a case in which adjacent diaphragm, colon, and duodenum resection was done. You can see this is the piece of diaphragm which has been removed. And this lady presented with polycystic cutaneous fistula, and this was a spontaneous one. Some of the patients have come out to be benign, but some of them have been malignant, like in this one, in which a radical polycystectomy of the excision of fistula tract, including lower right costal margin and diaphragmatic repair and only mesh repair of the defect. You can see this is the specimen. So this is just to highlight that, yes, that is possible. Just to give you an idea, one of our papers in which when we, over 6-7 years experience, we analyzed out of 327 patients which were resected, out of 569, 113 had extrahepatic adjacent organ, and single was in 49 and dual in 64. And when we tried to analyze, we saw that had we not gone in for the adjacent visceral resection, the resectability rate would have been 37.6%. But since we went ahead with extensive resection, the resectability in our series was close to 58%. Now, just to give you an idea that any of these resections is worthwhile, I've quoted this from Japanese literature because this is very nicely put into T stage. And as you can see, that as the T stage increases, the survival does decrease, but you can see that even 5-year survival in PT4 is 14.1%. And similarly, lymph node also positivity does decrease the survival, but you can see there are still long-term 3 years and 5-year survival. I put it as PT and PN stage because there have been, a lot of changes in the AJCC classification, and so this can give you a better idea. And this is again based on stage disease. I think what I'll do is that now I'll go to the laparoscopic management, if that's okay. Just one minute. Are the slides visible? Okay, so the laparoscopic management, because I think as Dr. Verma initially talked about, there have been advancement and now people are talking about the laparoscopic management for most cases in various malignancies and also the robotic. So let's look at that. Minimal invasive surgery, staging laparoscopy, there's no doubt. Palliative, there's no doubt. It's a laparoscopic radical cholecystectomy which is an issue. And this is about the staging laparoscopy. This is our series of 409 patients in which we did that. But summary of the literature talks about that in a large percentage of patients, you can avoid a non-therapeutic laparotomy by using a staging laparoscopy, because the surface liver metastasis and peritoneal metastasis can be missed on even good quality imaging. So this was an analysis. 773 were as assessed and operable 507. We excluded incidental gallbladder cancer because of adhesions, etc. We thought we'll restrict it to primary gallbladder cancer, which was 409, and out of these 239 were resectable. And we divided them into detectable lesions like the surface liver metastasis, peritoneal metastasis. And at that time, we labeled it as undetectable were the one in which needed more dissection, like this interaortic lymph node, and which now becomes a part of our standard staging laparoscopy. Or it's the loco-regional, which is the most difficult to decipher as a reason for not resecting, because you may need an intraoperative ultrasound and still you may not be able to assess that there's a vascular involvement or something. And it will also depend on the philosophy of your center, whether how far do you go for resecting these patients. So this is our paper, and 10.7%, even though you see that in T1, T2 stage, the yield was less. However, and it was higher in the T3, T4, which is 25.21%. But if you will see, the accuracy to detect unresectable disease was comparable. And you could actually obviate in about 55% non-therapeutic laparotomy. And what we realized was that some detectable lesions were also missed at that time because these were in the hidden areas. So after that, what we started doing as a later part of our study, that we started using 2 ports so that we could do visualize the hidden areas and take a biopsy whenever required. And also we added an interaortical lymph node biopsy as part of staging laparoscopy. This is pictorially just trying to show you that this below the left renal vein, this is the area, that's the aorta, that's the cava. This is the area from the 16B1 lymph node is taken out. And sometimes when there's no lymph node, we'll take out a tissue sheath which is there. And often that would yield some small lymph nodes. Laparoscopic radical cholecystectomy, which is a key issue, whether that should be done and can be done. And I think it has traditionally been contraindicated because early series talked about tumor implantation after a laparoscopic cholecystectomy for unsuspected gallbladder cancer. So I think the 2 questions that we need to answer is it feasible? One, and then the second is, within the light of metastatic in the ports, should it be done? Now, early feasibility studies, as you can see, from Gooms et al. And from Professor Hahn group and Bailey. And so I think the 3 major questions were that can it be done with the same radicality? That is, as far as liver resection, lymphadenectomy feasibility studies were there. What is the risk of port side metastasis? Will laparoscopic approach lead to early spread recurrence? In other words, is it a myth or a reality? And does it compromise on the long-term results? But if you look at the literature, and all along people have been extrapolating that incidental gallbladder cancer data to say that there is a risk of port side metastasis. But is it fair? Because you never knew that there was a malignancy. So what you were doing was you were holding the gallbladder from wherever you could. There could be bile spillage. And whereas when you talk about laparoscopic radical cholecystectomy, when you knew that it's a gallbladder cancer, you are going through a virgin area, not from the malignant tissue, and you go from the, as you can see in this liver, and you are not breaching the cystic plate. And so the risk of gallbladder perforation is also much less. And we all know that is a negative prognostic feature. So I think this is just in a tabular form talking about the plane of transaction is between gallbladder and liver bed, breaching the cystic plate in a cholecystectomy, which is otherwise done for an unsuspected gallbladder cancer. And whereas in this, it is in a segment 4B5 area. Tumor manipulation doesn't occur in the laparoscopic radical cholecystectomy, and you tend to do a double clipping of the cystic duct. And because you're not going through the cystic plate, the risk of gallbladder perforation is less. And also another thing which is more relevant for our country is that most of the cholecystectomy specimens are not removed in a protective bag, which is the case even when you look at the earlier literature of incidental gallbladder cancer leading to port side metastasis. And I think just this is the series from Polocki in which they talked about that in IGBC cases, the recurrence rate in the was in the ports as well as on the scar. So it is more a function of inadequate surgery which has been done and which is getting implanted in the raw surface area. And because we know that for tumor cell dissemination, there are mechanical factors, and role of pneumoperitoneum is very negligible. And this is the landmark study from Professor Hahn group with Cho as the first author, in which they took, I think, 30 patients, underwent a laparoscopic procedure, and those in which there was a doubt. So they did a wedge resection of the liver and sent it for frozen section analysis. And 18 of these patients turned out to be gallbladder cancer, in which they went ahead and did a lymphadenectomy. But median follow-up was 27 months and no port site recurrence. So this is the paper which convinced the world, and including we also started doing, because this paper came in 2010. In 2011, we started doing laparoscopic radical cholecystectomy after being convinced by this paper that all along it was doable, but there is a case for it to be done. Because as you can see, the medial lymph node yield was also 8. And also you can see port site recurrence was nil after 27 months. And we all know that if there was port site recurrence to occur, it would have occurred within a few months and maybe a year maximum. So this 27 months is a reasonable period. And then the second issue is, can it be done with the same radicality once we have realized that it's a myth that port site metastasis? Now, if you do an adequate resection, doing the same thing as you do in open, that is interaortic lymph node sampling, adequate liver resection, cystic duct margin for frozen, all lymph node group removed, and besides no tumor handling, no bile spillage, proper instrumentation and removal in a bladder, you can do it. And I think, again, the same thing happens, lymphadenectomy, hepatic resection, and adjacent visceral resection. Similar to this in open segment 4B5, as you can see this, I've taken a picture because after you take it out, it gets a bit more mutilated. So this is the segment 4B5 in a laparoscopic radical cholecystectomy. And you take out all these group of lymph nodes as you do in open. This is a picture of an open incidental gallbladder cancer. And similarly, you do it in a laparoscopic. As you can see that the vessels are bared, and that is the left gastric, the hepatic, and the gastroduodenal artery. And that you can see at the back is the portal vein. So you can do as good a lymphadenectomy as you would do in open, and that is what is required. This is just a label diagram of the same. And now, does it compromise the long-term results? In this, there are two issues that, of course, we have proven that technical feasibility is there, no port site recurrence. Now, let us look at the lymph node yield and the short-term and the long-term results. These are some of the papers talking about the lymph nodes yield, and we published this study. That time it was 24 cases versus 46 patients. Now we are presenting our paper of 180 laparoscopic radical cholecystectomy in this ILLS conference later this year. And in this, we talked about that the overall lymph node yield was comparable, 10 versus 11. And it was lesser in IGBC, because true IGBC would be earlier stage disease, and whereas in primary GBC, but in both the categories, the lymph node yield in laparoscopic or open was comparable. Sorry, I think it's not moving. Yeah. And if you see, there are some papers in this, like Shirobe et al., 2015 they published, and if you see, they have a follow-up of 152 months. So which means that they had been doing this laparoscopic radical cholecystectomy long before it surfaced in the literature as regards, the fresh cases, because the 152 would mean how many, more years than, more than 10 years, or 10 years would make it 120 months. Yeah. And this was a paper which was the updated series of Professor Hahn group, in which they had 45 patients, median follow-up 60 months, and T1A and T1B was 100% and T2 90.2. I was happy to see that now they have gone beyond even T2, and they have also been taking T3 tumors, and which is what we have also been doing. This was a consensus meeting that Professor Hahn organized in Seoul in September 2016. At that time, this is a slide from my presentation. At that time, we had 63 cases in which we had done a laparoscopic radical cholecystectomy with comparable results. And subsequently, as part of the consensus, there were two papers which came out. That is, one is a survey result of expert meeting on laparoscopic surgery. And this is in a tabular form talking about the outcome in these series. And they summarized to say that our survey results reveal that laparoscopic surgery for gallbladder cancer is currently being performed in highly selected cases, and the indication and details of the surgical technique vary among experienced surgeons, and it is very likely that in the near future it will increase. And similar was the laparoscopic, an expert consensus statement in which they said that with preoperative recognition of gallbladder cancer and careful manipulation to avoid bile spillage, laparoscopic surgery does not worsen the prognosis of patients with early stage gallbladder cancer if definitive resection during after laparoscopic cholecystectomy is conducted. And of course, they said that it is results are limited from the world literature. Then there were these review articles in which talked about various studies with a significant number of patients. But at that time, the number of patients in different series were less than 50. This is again talking about the lymph node yield in these. But now, very heartening to see that over the last 2-3 years, there have been several series containing more than 30 to 70 or 80 patients, which reasonable result, including one from our Mahesh Goyal from Tata Memorial about robotic gallbladder cancer surgery, and various from the literature from Japan, Korea, and this is one of our cases of the first case of a robotic radical cholecystectomy, in which we did, you do the same thing, bearing the vessels, taking the lymphadenectomy, doing the liver resection, and MCS is very good for this. And so equivalence showed, oncological equivalence showed with respect to R0 resection, lymph node yield, port site recurrence, overall survival, overall recurrence and survival. And just to take you through some of our patients, this is our longest survivor in this category, who's now 9 years plus. This is the patient who was 21 years when we operated in November 2011. And especially in obese patients, it's a lot of advantage. This was a mentally retarded, mentally challenged person who was a short height. And in this, we did a laparoscopic radical cholecystectomy. This is when at one point we had 170 cases and we compared it and put it in a chart, comparing it with other series. And Yoon et al. Series, that is the Professor Hahn series, now the updated series of 83 patients. And so initially cases were limited liver infiltration, now with gallbladder cancer with limited gastroduodenal infiltration, limited colonic infiltration, and those requiring CBD excision we are taking up. And very recently we have started taking up very selected patients of hilar involvement. Also, robotic radical cholecystectomy, we have done 5 cases till now. And now we are, the world literature, they are trying to push the envelope to also the adjacent viscera involvement. There have been some series, like Grooms et al. In the early series had a bile duct excision in this. Shirobe et al. Had 2 patients, Navarro has 1 patient. And this is our experience when we analyzed 170 cases. 11 out of these underwent adjacent viscera resection, and these are the results which were reasonable outcome. And of course, not all of them were gallbladder cancer. One of them was XGC, xanthogranulomatous cholecystitis, but you can see the blood loss and all the results were comparable and reasonably good. This is just trying to show that single organ resection in 7, dual organ in 2, and 3 organ resection in 2, if you counted CBD also as part of that. This is pictorially taking you through. I'll just finish in 5 minutes. And this is taking the segmental duodenal or the bile duct excision or the colonic. This is one of the cases of gallbladder cancer with hilar block, and you can see the multiple ducts that one has to anastomose. That was a video, I'm not running that. And so it has gone through surgical innovation, various stages, and now I think more and more adaptability is there in the world literature for the laparoscopic approach. And so laparoscopic radical cholecystectomy is feasible with adequate oncological outcomes in early gallbladder cancer and selected locally advanced patients, which are comparable to open radical cholecystectomy. And it has the potential to be adapted in the surgical management of gallbladder cancer, fear of early and port site recurrence notwithstanding, and for tumor needing addition to liver resection, lymphadenectomy, or adjacent viscera with reconstruction, minimal excess approach can be safely and effectively performed. This is, I think, I had a talk in the ASI last month. And so the one day before that, we had done this lap radical cholecystectomy in a lady who was 38.5, and our resident sent the picture from the morning. And it was very heartening to see. I don't think after an open radical cholecystectomy in a BMI of 38.5, you will have a patient has standing the next day morning after the surgery finished in the afternoon the previous day. So I think it has a lot of advantages of minimal access approach if we can have a comparable outcome, which now the world literature is talking about. Future At the moment, we are not taking patients which would need a right hepatectomy for gallbladder cancer, but because we are doing extended right hepatectomy in other indication, so probably soon in a selected patient, we may start doing that. And pancreatic duodenectomy, we are doing a Whipple separately, so maybe in near future, we may also take up this. But it is very heartening to see in the world literature, this Raja Kalayarasan, who was our colleague earlier at GB Pant, who is in JIPMER as a faculty, and he published one paper of laparoscopic hepatopancreatic duodenectomy for locally advanced gallbladder cancer. So soon we are realizing, as Dr. Verma initially talked about, that what is doable by open approach, most things can be done laparoscopically. Yes, of course, we have to keep it in mind that we should assess our not only personal, experience, but also the institutional thing. And one should not be wary of converting because the patient safety and oncological outcome is of paramount importance. So thank you very much for for the patient listening to this. Sorry, I hope I have not exceeded time.
No, it was a pleasure listening to you, Professor Anil.
Thank you.
I would conclude by saying that he has highlighted two very important points, that cancer gallbladder may not be considered with a nihilistic approach in today's state with good outcomes in the hands of surgical gastroenterologists. And second thing is that in safe hands, laparoscopic radical cholecystectomy is feasible, so should be considered. I think in the interest of time, I would ask you maybe one question. And that is, supposing you take up in the hands of a general surgeon only, once the patient is opened up for cholecystectomy, and on the table you find that there is a tumor which has reached up to the serosa, what kind of approach would you expect this general surgeon to adopt? Would you want him to close the abdomen and refer to a surgical gastroenterologist, or go ahead with a radical cholecystectomy?
See, I think the issue is that if you have to take stock of that whether he is in a position to complete a radical cholecystectomy, whether the center has got the backup to do that.
No, what I mean to say is that now this person would not have all those images that you have prior to a pre-prepared case of radical cholecystectomy.
That is fine. But if he has detected a gallbladder cancer or a suspected cancer during either laparoscopy or open, so the advice would be that you take a stock whether you are in a position to do a wedge resection, gallbladder with wedge resection, or you are in a position to do a complete radical cholecystectomy. If you can do that, please go ahead. But if you can't, then it is advisable not to go ahead only for cholecystectomy when the index of suspicion is high. And so I think any suspected cases, it would not be justified to...
Sure. Would you agree with me, Dr. Anil, if I say that if a patient is taken up for completion cholecystectomy, radical cholecystectomy after incidental gallbladder cancer was detected, it should be done only in those centers where frozen section is available?
No, but you talked about completion radical cholecystectomy.
Completion, yes, completion after incidental.
You may not need a frozen section because in most of the times, if you have it, certainly an advantage. But in the suspected gallbladder cancer, it is better to have a frozen section analysis when you wanted to decide, like we talked about when you remove with a wedge of the liver, when you subject to frozen. And depending on that, you decide whether you have to go and do a lymphadenectomy or not. And let me also add one more thing, that many centers may not have a frozen section facility. In those cases, even an imprint cytology can be helpful in some of those cases, because once you send the specimen, because sometimes you might have done a cholecystectomy, opened the specimen on the back table, and you realize that there is a suspected gallbladder cancer. So these are the cases in which you can, if you have frozen, that is the best. If you don't have frozen, you can send it for imprint cytology, because I think 70% kind of accuracy seems to have been talked about in the literature of even imprint cytology. So it may be worthwhile to do that. But I think if you are, completion radical cholecystectomy, as we all know, with T1B and beyond, or cystic lymph node being positive, or cystic duct margin being positive, you go ahead for a completion radical cholecystectomy.
I would hand over the podium to Professor Verma to take the talk further. So you're muted, sir.
I'm sorry. Thank you, Dr. Anil, for excellent presentation. I'm sure that has really give quite an insight into what's happening actually into minimally invasive surgery. It's a common knowledge that this actually technique has really virtually invaded in almost all the organs of the body. Less, and I think especially the solid organ. And the kinds of strides it has made in the recent past is really only to see to believe actually. The way I think that the latest case which has been done, the laparoscopic hepatopancreatic duodenectomy, speaks volumes of the kind of skills that the people have acquired with the passage of time. I'll just supplement the question what she was asking actually in case if it is in the patient with the carcinoma of the gallbladder where you are doing the completion cholecystectomy actually. Right. So I think in most of the cases with the completion cholecystectomy, if you see in early cases, it's very difficult to find even the tumor actually at the gallbladder bed. Actually. So invariably, you end up actually doing either the negative thing, the negative histopathology or the kind of imprint cytology or the frozen section, especially at this remote area, is not really available. So in these cases, as a matter of routine, actually, in all these cases, we know in general what was the stage of the disease when the cholecystectomy was done. If you have these stage, then I think if it is more than 1B, it is always recommended to go ahead and do the radical surgery rather than expecting any to find out some positive on the imprint cytology, which perhaps may not be available at the remote center or even in the frozen section.
So I may want to share a small case. Yeah. In which we took up a patient for completion cholecystectomy after lap cholecystectomy. We excised the port also, and when we opened the abdomen, we found that there were multiple deposits and huge number of deposits on the uterus. So we thought it's disseminated, and we closed the patient after excising the port. Now, unfortunately, the report that came was port site came to be positive for malignancy, and the deposits on the uterus were endometriosis. So we regretted having not done a completion cholecystectomy. So that's why I felt that frozen section or some kind of, imprint cytology, like you said, would have been worth it.
Right. I think Dr. Verma, I think maybe one of the things is that the answer to that question, which I had given, was for when you suspect, when you have gone in, not for a completion radical cholecystectomy.
Yeah,
I think we were talking about that when you suspect a gallbladder cancer, either during surgery or after removing the gallbladder specimen, then that is the utility of the frozen section. And the second thing, as Dr. Ratna said, that yes, we have been wronged at times. What appears to be a metastatic disease have, in our scenario, some of them actually come out to be tubercular, including interaortic lymph node have come out to be tubercular. So I think before we discard, yes, it would be worthwhile to have the facility of frozen section analysis. But as Dr. Verma said, that because in our huge country, a lot of centers may not have those facilities. So we have to look at that how we can make the best out of it. And as Dr. Ratna, you said that in those, the frozen section is more to look at these disseminated disease in the peritoneum rather than looking at in the GB fossa or in the lymph node, because that, as Dr. Verma is saying, that will only determine the adjuvant treatment later on. So you are okay with even the final pathology coming as like that.
Yes.
So may I enter?
I think
Hello.
Yes,
Yeah.
Dr. Vasif.
Yeah, sir. Good morning, sir.
Good morning.
Good morning, please go ahead.
Yeah. Actually, there are a lot of students here who are on this presentation. Sir, we are seeing that the day by day the approaches they are improving. Initially, it was like open, what you have just explained, and then laparoscopic, and then robotic. For the student point of view, can you please elaborate at what point do you think that it is an inoperable and you are not going to operate it? Because I have seen the various surgeons having various means aggression. Some are doing PD also, some are just restricting before that. So what are your endpoints like when you think that it is an inoperable case?
I think that's a good question. And, I think I did touch upon that because unlike a definition of borderline resectable in pancreatic cancer, in gallbladder cancer, it varies because it will depend on your philosophy. We know from the world literature that if adjacent viscera can be resected together with adjuvant treatment, or in some cases neoadjuvant, you can have reasonable results. So you have to have an eye on one, resectability. Second is the morbidity, mortality, which will be involved in doing those cases. So you have to assess. And what I would say that our approach has been that if there is a limited gastroduodenal involvement, we would go ahead and do a limited resection of the distal gastrectomy and proximal duodenectomy. If there is a pancreatic involvement, is often the upper outer part of the wedge. So we have done also wedge resection of the pancreas in these cases rather than hepatopancreatoduodenectomy. And some of the other ones, when there's colonic involvement or there's more than one viscera involvement, you can resect those. Bile duct, you can resect those. And it is the HPD, you have to take a conscious decision based on what is the patient condition, and whether, like hepatopancreatoduodenectomy is a broad term which contains a lot of other cases. If you're needing a segmentectomy 4B5 with a PD, you are not so much scared. It is usually the other spectrum would be a cholestatic liver, in which you are doing, even after drainage, an extended right hepatectomy with a PD. You would be wary of, and the world literature talks about not very good results. So now we would be very, very wary of doing an HPD in such a situation. So I think those are the things. Then the last category which remains is the vascular involvement. So hepatic artery, I'm just telling you what our approach has been. So hepatic artery, right hepatic artery, which is there, then we would either reconstruct or ligate and go ahead with the parenchyma preservative resection or extended right hepatectomy. If there is a right-sided structure, that is the right-sided portal vein and the right artery is involved, it will need an extended right hepatectomy. And if it is a main portal vein involved, you can do a main to the left. Some Japanese literature talks about main hepatic artery and the main vein also involved. They have gone ahead and resected, but at the moment in our center, we would take it as a contraindication, and we would not take up both portal vein and hepatic artery. So it varies from center to center, and it depends on, and also as the center experience evolves, like some of the cases which we are now taking up for resection, 10 years or 15 or 20 years ago, we were not resecting those. And we were also taking them as unresectable disease. And I think that was partly because based on our experience, and partly because as the world literature evolved, the ICU care improved, and neoadjuvant and adjuvant treatments improved. Yes.
Maybe, Anil, for the benefit of students, we must tell them, do we need to have a feeding jejunostomy in place, especially when you do those multiple resections?
Yeah, that is there depending on, as we do that, we still follow that after pancreatoduodenectomy, we put that. And I think that is more of, at least in the government hospitals, because if the patient was to need a TPN, the costs go up. Yes. So I think we have been using it as a, still using a feeding jejunostomy, which many centers tend to have given up. But yeah.
Thank you so much.
Thanks. Absolutely fantastic. I think the feeding jejunostomy is a lifeline for such patient, especially in our country where not many can afford the TPN. It's really a lifeline. So if we are really indulging in such a major undertaking, then it's always advised.
Sir, thank you. Hello. Yeah, we are running short of the time. Can we move on to the next speaker, sir?
Yeah, I think that.
I can see Professor Atia who is logged in. So thank you very much, Professor Atia. And thank you, Dr. Verma, Ratna, and all the others for the opportunity. Thank you very much.
Thank you, Dr. Agarwal, for excellent presentation. I think we'll move on to the second presentation today. And I think that's going to have, I think it's Dr. Yadav, I think, sir. Is all our speakers are there? Can you hear me?
Yeah, hello.
Yeah, I was just wondering whether all our speakers are there.
Let me ask from the Yadav, sir.
Yeah, because I can't see his this thing. Dr. Yadav, can you hear me? Hello.
I think he's not.
Okay, so I think that we can move on, and who will be the next speaker if he's around? I think I'll request the chairpersons to address the next the speaker. I don't know whether because of the 5 speakers, some of them might be missing. can I ask the organizers who amongst the 5 are there?
Yes, sir.
So maybe we can ask Dr. Saha to invite the next speaker. Dr. Bhojwani should be presenting.
I don't. Okay, Dr. Saha.
1 minute, sir. I think I've got a call from Yadav, sir. Let me ask whether what is happening.
Okay.
Dr. Jaswant is also there. If Dr. Yadav is not available, we can move on to Dr. Jaswant's talk.
Yeah, I think let's move ahead. We can request Dr. Yadav to join after this presentation. So can I ask Dr. Saha to introduce Dr. Jaswant, please, so that we can start the next talk? Dr. Saha.
Actually, hello.
Yeah.
Yeah, Dr. Verma.
Yes.
Actually, hello. Yeah, Yadav sir is on the is there. Actually, is unable to enter. So Ashish, are you here? Ashish. Ashish.
We are there. Yes, sir. We are there.
Can you please help Yadav sir to come on the screen? He is telling that he is trying to enter, but he is unable to do so.
I will do, sir. For the time being, you please have one more the Dr. Jaswant's presentation. I'll call the Dr. Yadav and make them join, sir.
Hello.
Yes, sir.
Ashish.
जब तक सर डॉक्टर जसवंत की कॉल प्रेजेंटेशन करा लीजिए.
Actually, he is already there. Actually.
So you may ask him to log in through Zoom directly.
I think what I would suggest, let's the technical snack we can take care of. And in the meantime, since the speakers are already there, can I suggest Dr. Vasif?
Yeah, I am sending him a new link. Can we wait for 2 minutes, sir? Okay, I am sending him a new link.
Okay. In the meantime, if any student want to ask any questions on the carcinoma gallbladder, I hope Dr. Agarwal is there. He can answer the question. Any students in the meantime can ask the question.
Hello. हो गया सर कनेक्ट? I think he's there.
You can see Dr. T.D. Yadav.
Yeah, he's already there.
Yeah. Okay, now can I request Dr. Saha to introduce Dr. Yadav, please?
Okay, sir, connect.
Yes. He's here on the screen. So am I audible now?
I think he's there.
Dr. T.D. Yadav.
Yeah, he's already there.
Okay, now can I request Dr. Saha to introduce Dr. Yadav, please?
Yes. He's here on the screen. So am I audible now?
I think he's there.
Dr. T.D. Yadav.
Yeah, he's already there.
Okay, now can I request Dr. Saha to introduce Dr. Yadav, please?
Yes. He's here on the screen. So am I audible now?
I think he's there.
Dr. T.D. Yadav.
There's a lot of echo. There's a lot of echo.
तो कुछ आ ही नहीं था यही
So maybe we can ask him to join directly through the Zoom platform.
Can you see my screen? I am already joined.
The screen, yeah, we can see the screen.
I don't think Dr. Verma. Good morning to everybody. And introduction is okay.
Actually, unfortunately, there appears to be some delay. Actually, I requested. If not, I can introduce. There is no issue. Dr. T.D. Yadav, a colleague of mine, is a colleague of mine, a very excellent GI surgeon, has been working in PGI for a couple of years, and his main interest is in the carcinoma of the gallbladder and the solid liver extrahepatic biliary system. Today, he is going to talk on the management of liver secondaries. What the surgical approach in these patients? Dr. Yadav, please go ahead.
So am I audible?
Yes, sir.
Okay. So
Good
morning to everybody, and I thank Dr. Atia and team to give me this opportunity. And I'm sorry for a little bit of pitch. I was listening to Dr. Anil Agarwal talk. So in the beginning, let me say that it is a difficult task because it is surgical management of liver secondaries, and this is one operation which is not very often done in our country, as we don't know the reason, but secondaries colorectal metastasis, which is the major chunk in the abroad, is surgery is not that common in our country, and probably we don't see so much of secondaries liver. So that's why, and this is my perception. So I will go case by case to cover the areas, and then in the last I will try to summarize. So there is the first case. This is a 46 years female. It was triple negative breast cancer, received complete chemotherapy, and already this proper appropriate surgery was done. Presented with solitary metastasis in the liver. So in our department, all other things were done as a second line of chemotherapy, and then this is the picture. And this picture suggests that there is a lesion here in the segment 4B, part of segment 4A, and involvement 2 and 3. So as you see, PET scan was done. There is no other site of metastasis.
Slides are not
obviously. Dr. Yadav, we can't see your slide.
You can't see my slide. Why? I don't understand.
Just see, because we are not seeing except that it is stuck on the disclaimer.
I don't know. Your screen is sharing is paused. Who has paused? I don't know. Resume. Okay. So can we see now?
No.
We can see the first slide. You need to click on the slide and then move on.
No, I just clicked on the slide only. I don't know what is happening. Now it is it okay now?
Yeah, we can see the disclaimer now. Can you just move forward?
Yes.
Yeah. Now can see. Yeah, now we can see your case capsule.
I'm sorry. So this is the 46 years female triple negative breast cancer patient, and received a complete chemoradiation and mastectomy as appropriate surgery done, and then she have presented later on with the solitary metastasis in the liver. In the follow-up workup, it was found. So in PGI, we have a very robust breast surgeons team, and they went ahead with the second line of chemotherapy. And this is the picture after completion of second line of chemotherapy. This is the lesion which is involving, you could see here is part of little bit of segment this portal vein branch. Here is the lesion which is involving segment 4B, part of A, and then 2 and 3. And though no other metastasis was found. So this was planned for surgical resection. After second line of chemotherapy, there was no response, but it was a stable disease. So we were asked to see this patient, and we planned for surgical resection. So this is a non-anatomical wedge resection of the liver was done, which is recommended for this type of for the patient. So what is the evidence? What is the evidence? So first thing which is done, I'm talking about liver metastasis. I will cover colorectal at the last. So this is the systemic review has shown that about 19 studies, this number of patient and major hepatectomy was about 50%, but most of the patient had UVG resection, segment 1 or 2 resection, major hepatectomy from the resident point of view. Usually more than 3 segments are involved. And concomitant hepatic, extrahepatic control disease. This group also had 6% of the patient who had extrahepatic disease, but it was also stabilized. And so what this study has found, this is a retrospective review and meta-analysis, this found that there was no impact of the primary tumor state at that time, nodal involvement, I'm talking of primary disease, extent of hepatectomy, only our aim should be R0 resection, number and size of metastasis if you can achieve the R0 resection. There was a clear-cut impact of the surgical margin on the survival. So how much is this margin is a question of debate. 4 millimeter, 5 millimeter, or 1 centimeter, as we know about hepatocellular carcinoma, but for here it is a difficult thing. One more surprising thing was found in this study that R0 and R1 had equivalent survival. But our aim should be R0 resection if it is possible. R1 is in not our hand if it comes later on. So this is the whole another study where it has been found that different people have shown different prognostic markers for the breast cancer metastasis. So if you see that somebody has an younger age group, we all know most of the cancers are very aggressive in younger age group, then advanced primary tumor, node positivity, which was not found in that particular meta-analysis, and then this previous metastasis, if it already there and you are going for second hepatectomy. So major hepatectomy also has been found to be a worse prognostic marker. So large tumor size. So these are the reports which are different reports published in the literature. But our aim, I think, if it is, but caveat is that chemotherapy is the first treatment, and if stable disease or it is responding, then surgical metastatectomy can be done. And it can be done with the R0 resection or even R1 margin if it comes positive later on. Probably survival is not going to be affected, but obviously it is better than not doing anything. So to conclude for the carcinoma breast, the non-randomized evidence. So there is no comparison between people where nothing was done vis-a-vis where this surgery was done. The systemic chemotherapy with surgical resection may be used as a standard of care for the breast metastasis like CRLM, colorectal liver metastasis. Incidence of liver resection is quite low, please remember. More close to 1.8 liver resection per year in US study. R0 resection combined with ablation can be tried if there are multiple mets, and chemotherapy should always precede liver resection. So second case, it is 40 years female. And you see the chief complaints of pain abdomen and lump abdomen, and taken to the another hospital in local in Punjab, and they did exploratory laparotomy, and they found a swell in the liver. So they went based on the liver ultrasound. So what they did, CT and other things were done subsequently. So on examination, these were the findings. I'm not going into the details, and this was the huge lump in the liver on CT scan, which they thought that it is probably abscess. I don't know how come, but this is what it was outside. So you see peripheral enhancement with necrosis. So there are multiple ways to look at this type of CT scan, like somebody might think of hemangioma, somebody might think of a neuroendocrine tumor. So this was the patient we did CT volumetry. I will tell later why did we do it. And this is tumor involvement was about 38.608%, and right and left lobe separately was done. Not done. PET scan is always recommended. We have to exclude any extrahepatic metastasis. So if you see the huge tumor in the liver, now no other metastasis. And then surgical procedure was done. It was a little bit of tricky and difficult. So central bisegment sectionectomy, and you see this is the bisectionectomy. 4 complete and 5 and 8, and intraoperative blood loss was about close to 1 liter, and patient had 5 units, 5 units, surgery time of 5 hours. So this is the intraoperative picture. You could see this is going into this is the diaphragm area, and this is area from lifted from the diaphragm, and then this is the huge tumor, and this is the after resection. So this is another patient where we were confused whether it is where is the primary, because commonest cause is secondary. Another patient having this small lesion here at a alveolar stricture, and this was the huge secondary. So in a final histopathology report was carcinoma neuroendocrine, poorly differentiated, not a good tumor at all. Lymph node were one by one metastatic, and this was the 4x4 preperiodic lymph node. They were also found to be metastatic. So actually not a good tumor. Gallbladder, I'm not a tumor. So what is our aim for the neuroendocrine carcinoma? So as I said, for the resident point of view, I have just put this slide that this is the classification in 2010, and we should follow it. So poorly differentiated, usually earlier it was called as small cell carcinoma, has a poorer prognosis than the earlier. But what should be done? So treatment is hepatectomy. So this is you can say that survival is not that good, but treatment is hepatectomy, most effective. Survival rate is satisfactory in spite of recurrence, and even recurrence, if can be resected, is resected. So recurrence of all tumor leads to the highest survival than not doing anything. So what is the management part? These both cases are advanced neuroendocrine carcinoma. And what is the treatment? So you see the gamut of the this thing, and now it is lutetium therapy also had come in nuclear medicine department. But no chemotherapy or drug regimen has shown progression-free survival and overall survival benefit. So it can be used as adjunct to the surgical resection, but please mind it, surgical resection should be R0 at least, probably R1, not beyond that. So this is another patient, 44 years male, and you see follow-up case of RCC, renal cell carcinoma, operated by our friend, and he was on interferon therapy for 2 years. And then he had pain abdomen, and it was in the follow-up, it was found that there was a hypervascular lesion in the as well in the liver. So we were thinking whether it is recurrence or something, and our ultrasound guided FNAC was refused by the patient. So PET scan is done. PET scan was done. I don't have the picture, but it was again localized disease to segment 6 and involving part of the 5. And this is the area where a tumor is there, huge tumor, about 5 to 6 centimeter. And this tumor was also resected. So please mind it, before resection, we have to ensure that there is no other metastasis, extrahepatic. So
Dr. Yadav, can you hear me? Unmute yourself.
Yes.
He's audible, sir. You're audible, sir.
Yeah.
Audible.
So, okay. So I go ahead. So liver metastasis in a renal cell carcinoma, is there a role? We should see the literature. Technical success is not everything. So there is a very limited patient. We have done 4-5 resections, but this patient had a recurrence within 1 year. But 2 to 4% of patients have hepatic disease amenable to the resection surgery, and 5-year survival is 13%. If you don't do, there is no survival, and repeat resection is associated with again improved survival. Disease-free survival is less than 4 months if tumor is like as we resected. So I am going one by one just to say that these are the patients where secondary metastatic liver resection has a role. So another 40 years female, ovarian carcinoma, treated in the Department of Gynae and Obs, and then received the surgery and chemoradiation as done by further ovarian carcinoma. And then in the follow-up, one single isolated metastasis was found in the liver. So our friend in the department, Dr. Saha, said, can you do this resection? So we did it. So again, there is no other tumor. So this is again very important to understand that these are the patients where we should exclude any other metastasis. So PET scan is every patient we are doing nowadays, and this is the post-resection specimen or the picture. So for the ovarian carcinoma, if there is an isolated metastasis, surgery, metastatectomy can be done. Another patient, 55 years, female, pain abdomen, melena, and hematemesis, and ultrasound suggested this large tumor. CT scan, we did it. This is, you could see where tumor is at a very dangerous place. It was involving at close to the porta and involving part of the segment 5, 4B, and hanging toward the porta, and lots of vessels you could see in the periphery. So this was the tumor, little bit of necrosis in between, and this is colon going around it. So this patient, in the retrospect history, we found that about 5 years back, he had a laparotomy for a small bowel resection, but he was not told what was the diagnosis. So we thought that this may be because of there may be some primary in the small bowel, but this patient had malignant cyst. So just to say summary that in a patient, if there is isolated metastasis, even malignant cyst, surgical resection can be done. I am not individually going in the intricacies of each and every patient, but these are the patients where another important role of surgical resection. So if you see, just I am talking about non-colorectal resection and non-neuroendocrine tumor, because these are the two areas where surgical resection is standard of care. But other tumors, when it is amenable to surgery, when biologically we think that it's better, surgical metastaectomy can be done. And this is the way how metastaectomy has improved with the time because of the evolution of the anesthesia and the surgery. And you could see that breast is leading. If you are excluding non-colorectal and non-neuroendocrine tumor, breast is the leader, followed by sarcoma, genitourinary, melanoma, and others. So I try to cover all this, whatever I had and whatever I read in the literature. These are the patients where chemotherapy is a major component in most of them. So chemotherapy is the component. Surgical resection comes later on. Stable disease. If a patient is having progressive disease on chemotherapy, most probably surgical resection is not meant for that. So we have to have a caveat. So this is very important to understand. And you could see this very nice picture where you could see that breast. See the survival, 200, this and patient breast carcinoma, sarcoma, genitourinary, taken from the same article. So this is the months, time since months. So overall survival and disease-free survival has been achieved by appropriate selection of the patient. So as I said, these were the variables described. So size of the metastasis, synchronous, metacoronous, and all those variables have been described. So going to another patient, now coming to the colorectal metastasis. So I have covered ovarian, I have covered neuroendocrine carcinoma, I have covered genitourinary carcinoma, I have covered malignant cyst. These are the major indications. So if you go into literature, you will find even for pancreatic report, but that is not the standard of the care. So here you see this is the history of the patient, and this patient had a synchronous colorectal metastasis. So for the resident point of view, synchronous is for the first time when you are diagnosing colorectal cancer, you are finding the liver metastasis, and biologically these are the worst tumor. So PET scan done, as I said, we routinely do when we are planning for things. So we could see that this is at a liver mets is at a favorable place. So unfavorable I will discuss. And then it was a plan that we'll do a simultaneous liver and colorectal resection. So this is the specific. So there are simultaneous resection, there are stage resection, and there are liver first approach. There are three main ways to approach a secondary liver depending upon how they are present, at what site in the liver it is present, and what is the amount of the liver resection we are requiring. So this was, I said, favorable because it was segment 2 and 3 mainly. So it is a favorable tumor, and there are evidence in the literature. So you could see the synchronous or metacoronous lesion. They are usually, people try to stage the disease because stage tells you the biology of the tumor. So how it is responding to the chemotherapy. But as I said, in this patient, preoperative chemo was not given because this patient has a bleeding and obstruction both. Unusual for the left-sided tumor to have anemia as a presentation. But this is the recurrence-free survival in an appropriate selected patient. So synchronous, this is about 20 to 30% at initial diagnosis. Resectable is about 25%. And optimum stage is simultaneous R stage. It is a controversial area, but most of the people are nowadays in advancement going for the simultaneous. Liver first approach, just for the resident point of view, just they should know, I'm not going into details. So what are the strategy we have to make? Simultaneous stage or liver first approach. There are three approaches, meaning thereby, but again, even in the liver first, chemotherapy is the first treatment. So even one should not get confused that liver first means go and resect the liver first. Liver first means primary colorectal part, it is not pressing you to operate and you are doing the liver first. Then after giving chemotherapy, liver first, then you are going for the second primary disease. So this synchronous liver metastasis, if you compare simultaneous versus stage, then we are finding that the stage procedure have more complications. The most important point is this: dropout rates in the different literature has been found to be in the tune of 30% because of the chemo complication or because of it. So just coming back for the history, as I said, natural history of colorectal metastasis. In the absence of treatment, median survival is only 9 months. But if you treat it by chemo and appropriate selection of the patient by doing different maneuver, you are going to have this survival. So there is a disease-free survival, there is a overall survival benefit. Survival benefit and the type of resection. So as I said, R0 resection is our aim. And if you have a R0 resection, actually you have a better survival. If you can achieve by doing wedge resection, multiple resection, then multiple resection at different places, but the aim is intraoperative ultrasound should not be showing any other disease left over in the tummy and in the liver, and one can combine. There is a report of combining the ablation therapy available on the table and the liver resection. So these are the different things. So influence of number and distribution. So if you see even multiple metastasis, survival is not different. If you are able to achieve R0, so multiple unilateral, multiple bilateral and solitary, there is no much different in the survival if you are able to achieve R0 resection. So hardly any different. Survival after according to the margin of the clearance. So as I was talking in the beginning, 4 millimeter, 5 to 9, 10 to 20, and again, not much difference. So this is very important to try for the R0 resection. So how can we increase number of the patients eligible for the liver resection? Because it's not only going and technology. So these are the reducing the tumor size by appropriate chemotherapy. Increase the hepatic reserve. As I said, Dr. Anil was talking something. So reserve how to increase? By doing different maneuver. I will just take one slide for this. So portal vein embolization is the way, and ALPS as discussed is the way to improve the liver reserve if you are going for the resection, which is much more than what is liver can tolerate. And then synchronous liver metastasis, whether we should go simultaneous or reverse strategy, meaning thereby you are going liver first. But again, I am emphasizing liver first doesn't mean. Why we are worried for this? Because if you see this liver, recently we operated. Please look at the liver. If you can see it in the talk, I don't know how it is looking like. It is a chemo liver, blue liver, chemo liver, and cholestatic liver needs at least 40% of the liver in the tummy, in the abdomen. Liver after chemotherapy 40%, CLD liver about 40 to 40%, 50%, depending upon the condition. So this is the reason why we are talking about portal vein embolization. So this is the way you see. Here is a patient, our patient. This is not for the colorectal metastasis or hilar cholangiocarcinoma, but you see the liver is 2-3 is small. It was right extended was required, and after doing portal vein embolization here, you could see that this is the segment 2-3, which has significantly raised, and this is segment segment right lobe. So if you see, this is the right hepatic, this is the IVC, right hepatic vein, and what is a significant increase in the size of the liver, remnant liver. That also suggests that your liver is good. It is ready to regenerate. So this is again, then what is the survival benefit? So initially, resectable patient have better survival than initially not resectable patient. This is very, very important when patient has come to you. So this is important to know. And this is the stage resection as I was talking about. Very important way. So many slides you have to go like this, and you could remove this wedge resection like this by doing appropriate intraoperative ultrasound and avoiding injury. And then this type of ligating the portal vein here. So this tumor, this will be left over. Then you go later on and resect this one, and this will be the hypertrophy of the liver from where you have taken the wedge. So this is the way you should go. So biliver metastasis, as I said, initially resectable, one can go for the therapy as we discussed and have a survival benefit. So result of hepatic resection in different series is this. So you can see the 5-year survival. It's such a wonderful thing to have a 33% 5-year survival. So about 25 to 33, 40% in different series depending upon the different type of the patient. So our moderator and chairperson and all other friends listening to me, though it was a very general topic, but I have tried to cover. And management of liver metastasis, I can summarize. I don't have lots of things to suggest. Management of liver metastasis needs multidisciplinary approach. One surgeon is not enough, that I am the big boss. So there is a MDT is required. Every case has to be discussed, and then radiologists, gastroenterologists all have to combine, and oncologists, radiotherapy. So all these things have to achieve the appropriate this thing. In a selected group of patients, survival benefit could be achieved. So it's not something very disparate in, as I discussed. And secondary, which progress in spite of NSCT, very important line, is not a good candidate for the surgical resection. Maybe for the resection, but not for the outcome. At the end, I take permission from Dr. Athiya to just invite you all the 13th annual conference of Indian chapter, though I don't know what is going to happen. We are organizing 6 to 8 August 2021 and PGI. So this is our website, and this is mine and Dr. Haji Singh's mail. So you all are invited, and please encourage your resident to join. Thank you all for your very kind attention. I will be happy to answer any query if it all it is.
May I say one thing? Sir, it was a wonderful presentation. I think 20, 30 years down the line, nobody could imagine that patients with liver mets could actually be treated. Everybody was labeled as good, having a bad prognosis, and now the end is near. But now with the multidisciplinary approach, as you have rightly pointed out, a multidisciplinary approach has changed the entire scenario, and in cases in which liver resection is possible, feasible, these type of surgeries can be done. You are doing a wonderful job at PGI Chandigarh. Hope to learn from you. Otherwise also, would like to join your IHPPA business, provided COVID doesn't play a spot.
Yeah, that is the biggest fear going on. So that's why we shifted the date about 6 months more with the consent of our this thing. But Dr. Athiya, it's as you said, the dogma of the surgeon has to go. So we have to sit together with the radiologists. See, the resident has to be taught to go to the radiology department and see the CT scan on the console if you want to be a good hepatobiliary surgeon. Don't believe in the plates and report. So, and then you can see all the vessels. They will show you what is the distance between that metastasis and the particular major vessel. Each and everything you go, make a picture in your mind, and then probably this type of resection. As I said, I was very much worried that how should I present, though I thought this is the way, from the resident point of view, simple, that these are the patients where it has been resected. So as I said in the beginning also, that chemotherapy is adjuvant therapy, means chemo and radiation, ablation therapies are the simultaneously going component. And chemo is, I think, most important in these tumors. The tumors which have been resected, most of them, they are chemo responsive, except this neuroendocrine carcinoma.
Good. I think nice presentation, Dr. Yadav. I think we all know that. I think can you hear me, everybody?
Yes.
Yeah.
Yes, sir. Yes.
I think about a few decades ago, it was basically a taboo. The moment the patient used to have a metastatic liver disease, he was always consigned to that. Now this is enough. He is gone. I think he hardly has any survival. Basically, I think the technical advancement which has been made, the multidisciplinary approach, the effectiveness of the chemotherapy, which have really made the surgeons the more and more bolder in order to attempt major resection, which really come out in a big way for the benefit of the patient. See, as far as the colorectal liver metastasis is concerned, the things were clear even then that they do have a good, but it's a non-colorectal liver metastasis. I mean, nobody used to touch. But today, I think, as you rightly pointed out, in a selective cases which are responsive to chemotherapy, patients is optimized, and the timing of onset of tumor, suppose if it is more after the primary resection, patients. These are the patients who can selected for.
TD sir, good morning. TD sir.
Good morning.
TD sir, good morning from Kanpur,
Good morning.
Dr. GD Yadav. Sir, very newer approach for the management of hepatic metastasis. One query, sir.
So we are already
yes.
short of time. We are markedly delayed. Please discuss it on the chat box.
Yeah.
Whatever decision. I think we should
Questions in the last if time permits.
Yeah, I think so. We will. I think it's a very excellent, good presentation. I think we will come to the next presentation. Hello. Okay. Do I know that who is our next presentation? Who is because now? Hello.
Yeah, hello.
Can I request my chairpersons to introduce the next speaker, please?
Dr. Rajesh Bhojwani, sir.
Okay. Dr. Rajesh, are you there?
Yeah, very good morning. I'm here.
Oh, very good morning.
Good
Rajesh, I think, I don't know whether Dr. Rajesh, I think is a good friend of mine, an excellent GI surgeon in Jaipur. I think he has done almost all kinds of major and the complicated GI resections. We have seen laparoscopic, he has done even the laparoscopic Whipple and all kinds of surgery. Today he is going to present on the esophagectomy. I think he is going to present today the laparoscopic esophagectomy and carcinoma esophagus.
Yeah, my topic is thoracoscopic esophageal resection.
Okay.
I'll just start sharing my screen. So is my screen visible?
Not now. Yeah, it is about to come.
It is like.
Okay.
Yes, sir.
Yeah, please go ahead.
Thank you so much. And a very good morning, sir, Dr. Verma, sir, Dr. Atya, and all the colleagues and friends who are there. My topic is, I bring greetings to you from our institute at Jaipur. And the topic was thoracoscopic esophageal resections. And as per my personal conversation with Dr. Atya, this was more inclined towards the general surgeons and of course the trainees. So I have kept my topic largely limited to a concept building rather than going into the intricate details, which might actually confuse the beginners. As we all understand, the esophageal resection in the last 2 decades has largely transformed from an open thoracotomy to a thoracoscopic approach or some kind of minimal invasive approach, which has various combinations of laparoscopy and thoracoscopy. At our unit, we have been actually doing the thoracoscopic esophageal resections for the last almost 14 years now, and there has been perhaps not even one thoracotomy for esophageal resection as far as I remember, unless in few early cases where it was converted. Electively, we do not use thoracotomy. And I can tell you with my experience, and one must always try and get hands into this because this is one surgery which is absolutely rewarding, not only for the patients, but it brings about much more confidence in the surgeon because the anatomy is more clearer, better seen, and one can go through standardized steps, although of course the learning curve stays steep. There are 3 positions in which thoracoscopic esophageal resections has been accomplished by various units across the world. Our preferred approach is the prone position. And of course, we tend to do the anastomosis in the neck. However, in very favorable GE junction small tumors, we tend to do thoracoscopic ivor levis. I'll show you some videos as we go along with our presentation. When it comes to the theater setting and ports, these are the port positions which you can see in the picture on the right-hand side down below. And 90% of thoracoscopic esophageal resections or mobilizations can be accomplished with these 3 ports, where in the camera port, you can see at the tip of the scapula, it comes almost in the mid-axillary line at the tip of a scapula, which is usually the 6th or the 7th intercostal space. Remember that the arm has been abducted, and this is the position or the theater setting which is used. Now, we always use a 30-degree, and almost for the last 8 or 9 years, I've been using a 3D camera system because 3D is something which is immensely helpful when it comes to thoracoscopic esophageal and nodal dissection. I also tend to use, and most authors use, the pneumopleura and keep the pressure at about 8 or 10. And when you do this in the camera in the prone position with that kind of pressure setting of carbon dioxide, the field is absolutely clear. There is no intervention or interference with any other viscera which can prevent a good vision. The potential advantages and limitations of the prone esophageal resection thoracoscopically include. The advantages include it is a shortened, let's say, learning curve. There is a group at Pittsburgh which does primarily lateral decubitus esophageal resections, but those are the resections wherein you need an assistant who tends to retract the entire lung. It is slightly more cumbersome in terms of technique, particularly the learning curve. Of course, after the learning curve has been achieved, I'm sure that procedure also becomes easy in the hand of experts. The prone position and the picture that I showed you, it is a very ergonomic position of hands. It is easy to maneuver your movements. Only one assistant is required for the camera. Theoretically, it improves oxygenation in prone position, and one lung ventilation is not required. So we have realized, and almost all the esophageal surgeons have realized, initially in the first, I think, 20 cases, we used a double lumen endotracheal tube because we were always concerned about the hypoxia that could happen. But it is not required. A single lung ventilation is not required. And with this double lung ventilation in the prone position, the lungs tend to fall down. And with the pneumopleura of about 8 to 10 mm, it does not hamper your vision. The lungs are never in the field, and you can accomplish a good esophageal mobilization. Potential disadvantages are there. There's a longer setup time to position, and in our unit, even with the OT technicians now very much used to this procedure, they still take about 30 to 35 minutes to position the patient because the patient is first anesthetized on a stretcher, which is by the side of the table. The tube is inserted, the lines are inserted, the catheter is inserted, and then this patient is now laid on the operation table in the prone position. So induction is actually done on the stretcher, which is by the side of the tube, by the side of the table. And in this procedure, it takes about 30 to 35 minutes. There is an unfamiliar anatomical orientation to surgeons, and it takes about 3-4 procedures for the surgeons and the assistants to understand. And therefore, it is always advisable to have a proctor to begin with who can help you with the esophageal anatomy in the prone position. If the anesthetist has to be aware that if there is a tube dislodgement, or not actually dislodgement, but a displacement, it might be a difficult airway management because the patient is lying prone, and therefore the anesthetic arrangement and the preparation has to be absolutely immaculate, and everything has to be fixed in position before the patient is turned upside down. And important to know is that emergency conversion to open procedure is difficult in prone positions, and I've faced this problem in one of my patients earlier on. Now, technical advantages. There is a less steep learning curve. It is easier to learn as compared to the lateral decubitus position. The lungs do not obscure the field. The blood gets pulled down into the diaphragmatic recesses or the pleural recesses, and therefore it does not hamper your vision. It does not become black. It is further aided by the 30-degree telescope, and all those who have the 3D camera or the robotic system, it is like a magnificent field to operate upon and dissect into. I'm sure all the surgeons who are into it, they enjoy doing that dissection because it is a kind of a little bit of surgical challenge, which always excites the surgeons to indulge into. It is advisable to keep the height of the table at the elbow position so as to facilitate the movements at the elbow of the position, which is parallel to the operation table. And that makes the operation easier. No assistant is required except only one. A camera person is required. It allows a good dissection around the left recurrent laryngeal nerve nodes, which may have a proposed oncological significance. That depends on the philosophy of a particular unit, whether you want to indulge into the supracranial nodal dissection or not. The prone position also provides a good view of the carina and the left bronchus and may help in reducing the incidence of tracheobronchial complications. The diaphragmatic retraction is not at all required since the hiatus is adequately visible in all the cases in the prone position. And I'm going to show all of these things to you as we go ahead with the presentation with the help of some videos. Now, as far as the nodal dissection is concerned, there used to be a lot of confusion regarding what should be the ideal nodal dissection. However, there are some important statements that I would like to mention here. For adenocarcinomas, if it is Stewart 1, which means more in the chest, and adenocarcinoma is located in the thoracic esophagus, an extended or total lymphadenectomy, 3-field, should be the rule, whereas for type 2, which is exactly at GE junction, only a mediastinal lymphadenectomy up to the subcarinial lymph nodes might be sufficient. That's a kind of an understanding. This is not a consensus, but this is an understanding amongst all the esophageal surgeons across the world. For esophageal carcinoma at or above the level of carina, transthoracic esophagectomy with 2 or 3-field lymphadenectomy is mandatory, and this is accompanied by a cervical anastomosis. The results of a meta-analysis which compared 2-field versus 3-field lymph node dissection, including 2 randomized controlled trials and 18 observational studies with over 7,000 patients, showed that 3-field lymphadenectomy improved the overall survival rate, but it is accompanied by more recurrent nerve palsy and anastomotic leakages. So, in overall, this is important to have. It is important to have a kind of a consensus within the unit, which is taking up thoracoscopic esophageal resections, to have the set pattern of nodal dissection within their unit, because it makes a difference to the learning curve. And those who are doing the 2-field lymph node dissection with infracranial mediastinal nodal dissection, they will find the thoracoscopic esophageal resections easier to deal with earlier on in the learning curve. So there are 2 types of nodal dissections which are acceptable, and these are the consensus guidelines, either standard or extended. Japanese surgeons do believe in the extended en bloc nodal dissections, and they've identified all the nodal stations. But most important is to know that when you are doing an esophagectomy, you must have to have at least 15 lymph nodes with your specimen and block to be able to say that you have achieved an adequate nodal dissection. And this is in the patients who have not received the neoadjuvant chemotherapy or chemoradiation. However, when it comes to there's no consensus on post-neoadjuvant treatment patients undergoing surgery. However, a similar number, which would mean 15 nodes along with the resected specimen, are important to label your resection as adequate, oncologically adequate. When it comes to the learning curve, the thoracoscopic esophageal resection is one of the most challenging procedures, and mediastinal dissection, in fact, requires more of learning. The normal learning curve has been shown to be in excess of 30 cases. So it will be always good to have at least 30 cases experience along with the surgeon who has been doing it as an assistant, and then get into it. And even then, the surgeon will take about 30 cases to master the technique. And Osugi et al. From Japan, they reported that basic skills seem to be acquired during the first 17 cases, but the most remarkable difference was observed when the first 36 cases had been done by a particular surgeon. And the primary education of the regular surgical team by post-accreditation supervision is essential for safe and rapid start to minimal invasive esophagectomy. And I'm repeatedly emphasizing on this particular fact because it makes a difference to the outcome. I'm just trying to show, is the video moving?
No, video is not working actually. We are getting a image on the screen.
Yeah, same here. Actually, it was not moving. So let me just give me 1 minute. So I was actually wanting to show the thoracoscopic anatomy in prone position so that the surgeons could understand, but I think this particular video is not moving, and if you may please allow, I can probably take you out of the presentation to give you an understanding of how it looks like. Just give me a few seconds and hopefully I should be able to show this to you. Another presentation, so let's get going with the same. So these are some pictures. So the initial dissection in the prone position starts with the division of the inferior pulmonary ligament, which is kind of avascular and free, and which gives you a leverage to put the esophagus and the nodes away from the right lung, and that marks the kind of interface between the two viscera. And maybe this video can help you understand. So you can see the patient is prone, and that's the supracarinal. That's the azygous vein. This is the azygous vein. That's the infraazygous dissection. That's the supraazygous part. The white protrusion is basically the trachea. So you can see that's the infracarinal dissection which has been done, and you can see the entire window. There was a time when I was preserving the azygous vein because there was a notion that I hope the video is visible. And
yeah, it is visible.
The left hand is actually retracting the aorta up. Remember, the patient is upside down, and there's this bulky growth, which is in the lower third of esophagus. The aorta, which is pulsating in the background, that is being bared, and the surgeon will now start going towards the hiatus. And in front here is the vertebra and the vertebral vessels there. This is the advantage of the prone position, because with only one hand of the surgeon can retract and use the energy source in the other hand to complete the entire procedure. No other assistant is required. That's the bronchial artery. I tend to not preserve the bronchial artery, although some surgeons do, because they believe that dividing the bronchial artery probably contributes to pulmonary complications. We don't believe that. We have been doing that ever since we started the procedure. Like in this particular procedure, we have preserved the azygous vein. There was a time when there were some papers which mentioned that if you preserve the azygous vein, that keeps the gastric conduit, which will be taken up into the neck, in place and prevent complications of the conduit. However, that concept does not stand the test of time, and most surgeons who believe in radical dissections now, they tend to do away with the azygous vein. We routinely ligate and divide the azygous vein now. So that's how the dissection is completed. You can see, and I will show you that's the left side, that's the supracranial part, which is being seen from under the azygous vein. And that dissection is done around the left recurrent laryngeal nerve, because all these nodes have to be taken along with the esophagus. And you can see that's the right bronchus, that's the carina, that's the left bronchus. Sorry. You can see the same picture there, and that's the pericardium, which is all bare, all intracranial nodes which have been bare. The esophagus is lying separately. Those are the hiatal nodes which will be taken. The entire aorta is bare. The thoracic duct has been clipped. And that's the azygous vein which has been preserved, and the supracranial esophagus that's been mobilized, and the trachea also that is bare, and the dissection is taken to almost half of the neck, and then the neck dissection becomes very, very easy, and it takes just about 15 minutes for the surgeon to reach that plane once the neck dissection, neck incision has been given. That's the right pulmonary vein, that's the pericardium, and that's the kind of anatomical orientation at the end of the thoracoscopic dissection. In most patients, this thoracoscopic esophageal mobilization will take not more than 40 minutes to 1 hour in an experienced unit. So that's the anatomy that you will get to see in prone position. You can see the entire pericardium, which is bare. The left pulmonary vein in picture, the mobilized esophagus comes to one side, carina, and both the bronchi are also seen there. I think this video is also not moving. Now sometimes please allow me a minute. I will try to see why the video is. I believe it is because of the low bandwidth, because everything else is seen, but the videos are not seen. Do we have time of about 5-10 minutes? Do we have enough time? Or?
Hello.
Verma, we take a call. We are enjoying your presentation, sir.
So just
Hello.
yeah. So if you have time, please give me 1 extra minute. I will try to organize right and open it up from the source, perhaps.
Dr. Rajesh.
I think I'll skip it because...
Yeah, can I just request you to just fast forward or skip a couple of videos in order to just make up for the time, please?
Yeah, actually, in fact, the videos are not playing, so I don't have a choice.
Okay.
Yeah.
Okay.
They're not playing in the presentation somehow. So anyway, so I will, unfortunately, the videos are not playing. So that's the depiction of combining the laparoscopic gastric mobilization, the conduit fashioning. And we have given it up by and large, unless the patient is insisting on a good cosmetic outcome. The standard of care in our unit is now a hybrid MIE, wherein we do the entire esophageal and mediastinal dissection thoracoscopically and then change the position and then do the gastric conduit formation and the abdominal nodal dissection with the open upper abdominal midline incision and take the conduit into the chest and do an anastomosis in the neck. That's the standard of care for most of the patients that we do. However, there can be some certain specific circumstances wherein we change our practice, and that's the kind of outcome that you can expect. So this is the laparoscopic assisted MIE, wherein we do the entire abdominal dissection also laparoscopically and make the gastric conduit also gastric conduit is fashioned outside after the entire specimen has been taken out. And this is basically to prevent cost or kind of minimize cost. That's the lap assisted MIE. This is a totally minimal invasive MIE wherein the entire procedure has been done thoracoscopically and laparoscopically, and you'll get to see only one incision on the neck. And this is the hybrid MIE, which is the standard of care these days we have, and that saves not only time but a lot of money that we tend to otherwise spend upon when doing any esophageal dissection. And for those who are interested in going through the techniques of minimal invasive esophagectomy and are also technique also, may I please refer them to the textbook of surgical gastroenterology published by Sir Dr. P.K. Mishra, wherein we have written a chapter on this particular subject. So thank you all very much from our team at Jaipur, and I sincerely apologize for some videos not playing.
Thank you, Dr. Rajesh. Your video are already self-explanatory. Unfortunately, due to paucity of time, I think I'll not invite any make comments or questions, and we'll move ahead with the next presentation. Can I request the Dr. Jaswant, actually, who is the professor and head Department of Government Stanley Medical College, Chennai, to start his presentation on liver transplantation. Thank you, Dr. Rajesh. Thank you very much.
Thank you, sir.
Good afternoon. Can you hear me?
Yeah. Very good afternoon, doctor.
Yes, we can hear you.
First, let me thank AMU Organizing Committee for giving me this opportunity. And I'll be talking to you about liver transplant overview. It's not me. So I'll be covering the topic along the history, indications, contraindications, listing of the patient, and little about DDLT and LDLT, and importance of immunosuppression and long-term follow-up. Going to history, 1960, initial liver transplant was done using dogs, and Starzl attempted first human liver transplant in 1963, and he could succeed only in 1967. And 1983, it became the definitive therapy for end-stage liver disease. So all these things were done when there was no proper anesthesia, no proper blood components, and there was no atraumatic needle, no proper gadgets, and blood used to flow like waterfalls. Now we are in a much comfortable state. In 1988, development of universal viscosity solution made the liver storage much easier. And tractomys was introduced in 1989, which made immunosuppression more convenient. And first LDLT was done in 1989. And first in situ split liver transplantation was done in 1995. And MELD score was introduced in 2002. Why is liver transplant unique? Because it does more than 400 functions, and which fails, there is nothing to support a failing liver. And because of a large size, dual blood supply, and orthotopic positioning, and liver transplant is a permanent procedure. So coming to the indications, liver transplant is indicated when there is end-stage liver disease, whether it is acute or chronic, when no other therapeutic option is available. It's a malignancy like HCC, metabolic causes, and rarely trauma. So indications in adults, cirrhosis is the commonest indication, constituting 68%, and in children, it is biliary atresia, about 58%. What are the contraindications? The absolute contraindications are active infection, untreated spontaneous active peritonitis, advanced cardiopulmonary disease, extrahepatic malignancy, active alcoholism, substance abuse, and non-compliance. The relative contraindications are chronic renal failure, advanced cachexia, large HCC, and age is not an absolute contraindication. HIV, portal and mesenteric vein thrombosis. So while listing, does the patient need liver transplant? You have to consider all the following questions. Have the indications and contraindications have been properly assessed, and what is the surgical risk? Whether the patient will survive after transplant, and what are the chances of recurrent disease like hepatitis C, malignancy, autoimmune hepatitis, and so on. So selection of the patient with end-stage liver disease based on chronic liver disease based on MELD score. The MELD score consists of creatinine, serum bilirubin, and INR. The cutoff is kept as 15 because the risk of death while waiting for transplantation is less than the risk of death after transplantation. Of course, there are many MELD exceptions. I will come to that later. In case of acute liver failure, the King's College criteria is being followed widely that in case of paracetamol toxicity, either pH is less than 7.3 or all the following three is taken into account. That is presence of grade 3 or 4 hepatic encephalopathy, INR 6.5 more than, and serum creatinine more than 3.4 milligram. When liver failure is due to other etiologies, either INR more than 6.5 or any three of the following criteria taken into account. Age less than 10 or more than 40 years, jaundice more than 7 days before development of encephalopathy, INR more than 3.5, serum bilirubin more than 7.5 milligram per deciliter, or unfavorable etiologies like seronegative hepatitis, Wilson's disease, or drug actions. What are MELD exceptions? Of course, we are aware that hepatocellular carcinoma, initially Milan's criteria was taken into account, later into the UCSF criteria. All these are for cadaver transplant. Now with the availability of liver transplant, even within the criteria says so there is no the size and numbers are no bar for transplant and all. There's not been extrahepatic spread. That's the only indication. The development of complications such as hepatopulmonary or portopulmonary hypertension, intractable ascites, encephalopathy, or pruritus are other exceptions to MELD. Recipient evaluation. Recipient evaluation has to be extensive so that the recipient will benefit or is indicated or the same will tolerate the subject. The extensive evaluation include pulmonary, cardiac, renal, psychosocial, and looking for occult or overt infectious diseases. And laboratory workup includes liver function test, coagulation profile, hepatitis screening like BNC, serologies for cytomegalovirus, herpes simplex virus, Epstein-Barr virus, HIV, and tumor markers to rule out malignancy, ABG, apart from routine blood investigations. Imaging studies includes ureoscopy, X-ray chest, CT chest, ultrasound abdomen, CT abdomen or MRI abdomen, PET CT, as and when required, echo, contrast echo, coronary angiogram, as and when required. There are two types of liver transplant. This is not liver transplant, living donor liver transplant. DDT includes organ harvesting from the donor, recipient hepatectomy, bench dissection of the harvested liver, and liver implantation. What are harvesting steps? Before harvesting, one should verify the brain death certification and whether proper consent has been obtained. After that, only one should go for harvesting. It involves long midline incision from neck to pelvis. After assess the liver is fit for transplant or not, for fibrosis, any malignancy, or fatty liver, and so on. Then start mobilizing the liver, and gallbladder is emptied of bile because it can cause cell death, and bile can cause cell death, and irrigated. Next, go for liver chylum dissection. Then look at the anatomy, but there is any aberrant anatomy like accessory or replace the hepatic arteries. That is very important. Then portal vein cannulation is done for irrigation, and then infrarenal and supraspheric aorta is dissected and control is taken. Next, we heparinize the donor with 20,000 to 30,000 units of heparin, and aorta is candidated. And liver is perfused through aorta and portal vein using ice cold UW solution or STK solution. The 3 to 4 liters through aorta and 1 to 2 liters through portal vein. And IVC vending is done intrapericardially normally. And abdomen is cooled with fine ice or ice cold saline. And finally, liver is removed along with IVC and cuff of diaphragm and entire artery along with the cilia, trunk with patch, parallel patch. This is how we assess during donor harvesting. It is a very good liver because the liver is pink in color, it is soft, and it is very sharp. And this when the donor is very stable, we do majority of the dissection the on table itself. Here, the hepatic artery is being dissected, and this dissection will continue till celiac axis. And here, the gallbladder is open and bile is flushed because bile salts can be cells and all. Here, inferior mesenteric vein is cannulated and it will be kept in the portal vein for portal vein perfusion. We use 10 size infant feeding tube for aortic, this one, portal vein cannulation, and aortic dissection has already been done. So after perfusion and all, whole liver is removed along with the IVC, cuff of diaphragm, and entire celiac trunk. On table back, again the portal is perfused with 1 liter of University of Wisconsin solution and is packed nicely. The triple bag packing is done and transported to the recipient hospital. In hospital, the back table preparation is being done. The back table preparation is performed in preservation solution at 4 degrees centigrade, where permanent diaphragm is removed, interior vena cava is separated from all unwanted tissues, any indented or unintended openings of vena cava is sutured carefully to avoid bleeding after perfusion. Chronic vein orifices are sutured, portal vein is isolated to the level of bifurcation and anterior arterial axis skeletonized up to the caral stacks. Here the back table purpose is being done in the hilar region. This is the portal vein. This is arterial, this one. This is the bile duct. Here the fornix vein openings being sutured. Here the unintended openings of supracardiac IVs are being closed. This is very, very important to prevent bleeding following reperfusion. So with the use of Wisconsin solution, liver can be stored for 12 to 18 hours, but it is preferably transplanted within 7 hours to prevent cold ischemic injury. This coming to the recipient hepatectomy is the most difficult procedure and it can be associated with massive blood loss, especially in case of cirrhosis with portal hypertension. So we need meticulous, delicate, and systematic dissection is necessary. Veno-venous bypass or portal shunt can be done to reduce blood loss. It's an expanded liver. Coming to liver implantation, either classical method or piggyback method. Now, majority people are following piggyback method. In classical method, native IVs is not preserved, and piggyback method, native IVs is preserved. In classical method, suprahepatic IVC is anastomosed, suprahepatic IVC, then coming to infrahepatic IVC is anastomosed, then portal vein is anastomosed after reperfusion is done. During reperfusion, one should be very careful because patient can go for sudden hypotension and cardiac arrest because of the heart is exposed to hyperkalemic and acidotic blood. So one should prepare with inotropes and calcium infusion to take care of this and slowly reperfuse step by step to avoid reperfusion effects. Then hepatic artery is anastomosed. Finally, bile duct is anastomosed. Commonly, duct-to-duct anastomosis is done. Or duct is not available, hepatic anastomy will be done. The superior aspect shows the classical method where IVC is removed, IVC to IVC anastomosis. This is a piggyback technique where native IVC is preserved and IVC is anastomosed with the hepatic veins. This surgical team in our theater under action. After completing the IVC anastomosis, the portal anastomosis. This is a donor liver. See, before perfusion, it will appear like this only, very pale. And portal anastomosis is being done. This is the artery. This is the portal after anastomosis. See, after perfusion, the liver has become very pink. This side we can see the donor bile duct, and here the recipient hepatic artery waiting for to be anastomosed, and the donor artery. This is after hepatic artery anastomosis. One should have pulsatile flow. This is a satisfactory blood flow. And to wait for that actually. There are special circumstances when you get portal vein thrombosis. In early thrombosis, we can do thrombectomy, or we can use jump graft from using the vein taken from the cadaver, internal iliac vein. In the same way, hepatic artery may go for dissection, or there may be inadequate flow, or there is no pulsatile flow. We can fashion aortic hepatic graft using the donor artery, the internal iliac artery we can use. So one young patient with good healthy liver, the same liver, cadaver liver can be used for 2 people. So you can organ shortage. Right lobe can go to an adult, and left lobe can go to a child. So 2 in 1. The child will receive segment 2, 3 or 2, 3, 4 and adult will receive the right lobe. The overall survival is at 1 year 85 to 90%, at 5 years it is 75% and 10 years it is 60% and very good. From initial when death or 1 year from 10% to now we have 60% 10 years out. Living or liver transplantation. So, cadaver organ shortage led to the development of living or liver transplantation. And it's the primary transplant procedure in Asian countries, including our country. And right donor hepatectomy is the commonly mostly performed for adult recipient, and left lateral lobe is done commonly for pediatric recipients. The right lobe, left lobe, or left lateral segment. So how much liver is required? Normal liver is 2% of body weight. Optimally is more than 1% liver weight and body weight ratio. Normally 70 kg recipients needs at least 70 grams, but cannot go below 0.7 or 0.8%. So in liver or liver transplant, donor is very, very important. And we have to reduce the donor morbidity and eliminate donor mortality. And this software-supported CT has come as a boon to assess the liver status. So this gives good hepatic venous anatomy, non-venous biliary anatomy, arterial anatomy, portal vein anatomy in 3-dimensional view. So before surgery, we know everything in the liver, but venous anatomy and paragon. So there will not be any surprises during surgery. The paper has a portal actually, and we can do virtual resection and see what a structure we are going to do, divide, how much liver we are going to leave behind, how much liver we are going to remove, and pre-operative we can say whether we can do a safe surgery or not, and it gives accurate about everything. So this can be transferred to the right lobe graft. So advantage of LDLT being is elective procedure, there is no wait list, and the assurance of healthy donor organ and short ischemia time. But the sort of the morbidity and mortality of donor and recipient is increased incidence of biliary and vascular complications. So how do we know the liver has started functioning well? Hemodynamic stability, awakening from anesthesia, recovery from hyperglycemia, correction of hyperthermia, and acidosis, and production of good quality bile will tell, okay, this liver will function very well. So immunosuppression is very, very important. Even though liver is a immunologically privileged organ than other organs, it needs immunosuppression. And the risk of rejection, active rejection is highest during the first 3 to 6 months. So induction, usually it is done with steroid, except renal transplantation, or it is done with Bacillus and monoclonal antibodies. For maintenance, we commonly use tacrolimus, is 0.05 milligram per kilo body weight, steroids, and mycophenolate MF of around 500 to 101 gram BD dose. In 6 months to 1 year time, the steroids and MF are tapered, and after 1 year, depends mainly on tacrolimus. And routinely, the blood levels are monitored, and the tacrolimus levels kept around 5 to 10 nanogram per ml. Steroids, MMF, or delayed calcium inhibitor, that is tacrolimus, renal sparing protocol, or something will use sirolimus and steroids. In severe rejection, OK3 may be used. It is calcium inhibitor, tacrolimus, and cyclosporin, steroids, microfiltrate, and sirolimus is a mammalian target of rapamycin actually. Come to the complication. Primary non-function, it is very rare, less than 5%. When primary non-function occurs, patient needs retransplantation. Hepatitis thrombus around 2 to 4%. So it can be diagnosed by serial Doppler ultrasound and based on the increase in liver enzymes, especially AST/ALT more than 2000, it is more than 5000, it will almost always be the hepatitis thrombosis. And usually hepatitis thrombosis also leads to retransplant. And portal vein thrombosis may represent GFB and coagulopathy, and postoperative bleeding may be inadequate presence of clotting factors or technical factors. Other complications, infection. Infection is very, very important, especially in our country. And because of immunosuppression, opportunistic infections are very common. Fungal, virus, bacterial, and so on. So these patients are normally put on prophylaxis. For fungal, we fluconazole, and for pneumocystic RNA, we have given Cetron, and for viral prophylaxis for CME, we give dancyclovir. For 6 months to 1 year, we do all of these two. And recurrence of disease. Recurrence of disease means very common, especially hepatitis C, malignancy, autoimmune hepatitis, and primary biliary cirrhosis, and sclerosing cholangitis. One should be very careful to look for this recurrence of disease. And malignancy. Malignancy, either de novo malignancy or malignancy due to complications of immunosuppression, skin lymphoma, the very common following immunosuppression. So these are the complications, one should be aware of that. Because of immunosuppression, in case of infection, they may not give the normal signs and symptoms. So one should always look for that. So post-earlier transplant, as I told you, AST/ALT 2000 should be monitored very carefully. It could be the parenchymal liver injury, or it can be the arterial thrombosis, or can be even severe infections, and so one should be very, very careful. Normally, AST/ALT returns to normal within a week, and platelet decreases for 1 week and raises again. When there is parenchymal liver injury, either because of cold ischemic injury, liver may be raised for 2 to 3 weeks, and it will come back to normal. Types of rejection. The hyperacute rejection, it is antibody mediated, very, very rare. And it needs liver transplant. Acute rejection, T-cell mediated, and it commonly after 3 to 6 months, and it's very common the second week. And it can be diagnosed by mild malaise, fever, and raised AST/ALT, and diagnosed by liver biopsy. It can manage with pulse steroids.
Dr. Jaswant, can I interrupt you for a minute? Kindly hasten your presentation and wind up. We are running very short of time.
Sorry.
It's a request, please.
Right. Okay. So follow-up is very, very important to assess the clinical progress and detect complication. And immunosuppressive dose adjustment is always necessary because those may vary with time in particular patient. So laparoscopy and robotic liver transplant has made the acceptability of the donor acceptability among donors. And liver transplant team approach actually, anesthetists, hepatologists, and most important pathologists. Initially, we used to lose patients because pathologists did diagnose properly the rejection and all, and treated as infection. For infection, you have to give antibiotics. For rejection, you have to give steroids. So now in this current status, LDT is commonly performed, and that is a very safe procedure. And we need more and more cadaveric liver transplant. And nowadays, with the advent of NASH, and we'll be getting more and more of non-NASH-related cirrhosis, while hepatitis B is being controlled with vaccination and C with
the 1 meter will take this transplant of human organs act was 1994 and first liver transplant done was our hospital 1995 and successful liver transplant done in the 1998 by Dr.
Dr. Jaswant, we have lost your voice actually for a moment.
Hello?
Yeah, hello.
Can you hear us, Dr. Jaswant? Hello, Ashish? Hello, Ashish?
Yes, sir.
I think we have lost the voice of Dr. Jaswant. Please see. Please check out.
So please check your microphone, sir. It's not working, sir.
No, we have you actually. It's not my voice. It's the voice of Dr. Jaswant, presenter.
Yes, sir. With Dr. Jaswant को ही बोल रहा हूँ, sir. Dr. Jaswant, your voice is not coming, sir.
Hello.
Hello? Hello, can you hear me?
Yeah. Now we can hear you.
Okay. Yeah, now let us try to just conclude. Okay.
Yeah.
Okay.
Yes, it was really a very nice presentation.
Yeah. Now we have come a long way, and liver transplant is a very safe procedure. Even better than actually sometimes in uncomplicated cases, it is smooth recovery than even a Whipple's procedure actually.
Yeah.
It has come to stay and only progress on immunosuppression, and in future advances will also get a better immunosuppression and maybe development in hepatocyte transplant or stem cell transplant gene therapy may reduce the indication for at least in acute liver failure, the indication of transplant. Thank you very much for patient hearing.
Thank you very much, sir. As we are running short of the time, we want to make it up. So I will request the next presenter. Verma sir, can you please invite the next presenter? He's there.
Yeah, Dr. Senthil, I think he is the consultant at the GEM hospital. A very good friend of mine. I think there is the institute for doing all kinds of advanced laparoscopic surgeries, and I think they were the first from India to do the laparoscopic.
35 minutes. Around 30.
Yeah, and I think their institute was the first to start the laparoscopic Whipple, and they have done sizable number of cases in the liver, the pancreatic adenectomy by the laparoscopy with excellent results. And I think they're the first. The publication came in British Journal of Surgery in 17, if I remember correctly. I think he's going to corroborate. So Dr. Senthil, kindly present, and if possible, kindly just try to little shorten up your presentation because we are running really very short of time.
Hello. Dr. Senthil, are you there? We cannot see you on the screen.
Hello, Dr. Senthil, are you there?
Sir, he is not there in the meeting.
He's not there? Can you just call him?
Yeah, I am just trying. Huh?
Yeah.
I'm trying to connect to Dr. Senthil right now.
Yeah.
Acha, sir, you're logged in, but you're not able to share your screen.
I think, hello. Yeah, Professor Athiya. Yeah, hello. Can you hear me, ma'am? Hello.
I'll be talking to Mr. Ashish. Dr. Senthil is very much there. He's not able to connect.
Hello, ma'am. Are you there? Hello. Ma'am, can you hear me? Hello. Hello. Can you hear me, sir? Verma, sir.
Yeah, I can hear you.
Hello, Ashish.
Yes, sir.
Can you send him a link, for example, because earlier also Yadav sir was having the same problem.
Sir, I have already sent on mail.
No, you send him. You please contact him and send him a new link on WhatsApp.
Ma'am is talking to sir. मैम से बात हो गई है, वो बात कर रहे हैं.
अच्छा.
Dr. Atia, could you connect to Dr. Senthil?
Sir, I've spoken to him. I have resent him a link on his WhatsApp. He'll be connecting shortly.
Okay.
Shall I start, sir?
Yeah, please go ahead.
Right. Thank you, sir. You are like my mentor, Verma sir, and the other esteemed moderators, the organizers of the meeting, especially Professor Atia ma'am, and the entire faculty from AMU. It gives me immense pleasure to be among the faculty and teachers.
Yeah, please go ahead.
Right. Thank you, sir. You are like my mentor, Verma sir, and the other esteemed moderators.
Senthil sir, I think you are open WebNext.
Yeah. Yes. I think now it's fine. So thank you once again for the organizers. My topic today would be laparoscopic Whipple's procedure. The first half of my talk would be on the technical aspects of the Whipple's procedure. The second half, I will touch upon the literature evidence, the presence of the exact place of laparoscopic Whipples in our day-to-day practice. I bring greetings from Gem Hospital, Chennai. We all know that laparoscopic Whipples is a very formidable surgical procedures which involve multiple resections and reconstructions. And to make it very clear and also to make it understanding in a stepwise fashion, I'll break the entire laparoscopic Whipple's procedure into different easy steps for us to understand. It will be good for us to learn and also to categorize what's important, what's the first thing to learn, and subsequently the other things you can able to grasp. This is our journey in laparoscopic PD. As Professor Verma said, we have been fortunate to start first time in India, rather in the world, the complete laparoscopic Whipples, followed by the first presentation in 2000, then first publication in JACS in 2007. Since then, we have had at least close to a dozen publications in this subject. That's followed by the first RCT across the globe in 2017. So that's about a brief overview. I will go to the technical aspect. The team setup is like this, as you see in the picture. The surgeon stands between the legs. The camera surgeon is on the right side of the patient. We have changed the ports right from 1998, which is strict midline, to lateral port, and now this is the port placement in since 2017. Sorry, especially after the introduction of robotic surgery, this is our port since 2017. As I told you, I will divide the entire procedure into a short video clip so that we can understand it better. The first step is tucking of the falciform ligament and the gallbladder retraction. This gives an adequate exposure for the long procedure. It takes about 6 hours, so that we should have a crystal clear operating field, devoid of any structures. The exposure should be good. So we retract the falciform ligament, and if the operability is not in doubt, we can afford to do this gallbladder retraction like this. The advantage of these two methods are they don't require any assistance. We can free the assistant's hands and the instruments, so that this we got it from the robotic experience, so that now we can see the operating field is in our view. It's just coming to our view nicely without any additional retraction. The third one, retracting technique, is retracting of the left lateral segment of the liver. This we got it from single incision laparoscopic surgery. A big needle, straight needle with a tube attached to it. This can be used to retract the left lateral segment. So the combination of single incision laparoscopic surgery techniques and robotic surgeries we incorporated into our day-to-day laparoscopic Whipple's procedure gives a very good exposure, as you can see here. So this is about the first thing, adequate exposure. The next would be the right colon mobilization, which is called cattle brush maneuver. After entering the lesser curvature through dividing the gastrocolic omentum, we pull down the hepatic flexure colon so that the entire head of the pancreas, the duodenum, everything is exposed. This also can be facilitated by proper exposure. As you can see, hardly any assistance come into play. The main surgeon with a camera surgeon can able to manage the shows without much of help from the assistants, thanks to proper new innovative retracting techniques. As you can see, the duodenum is C-loop is exposed, the complete hepatic flexure colon is mobilized. This is the head of the pancreas mobilization. C-loop, you can see this is the C-loop, the head of pancreas, this is the gastrocolic trunk formation, so that this gives a proper exposure to the head of pancreas. Then we follow it up with the Coco maneuver. The duodenum is lifted up, separated from the underlying retroperitoneal attachments. As you can see, the IVC is getting exposed. Again, these are completely bloodless, nice planes. If you are in the proper plane, it's actually really treat to do it. We all do the intra-aortocaval group of lymph node sampling. As you can see, the IVC and the aorta, this is the exact intra-aortocaval group of lymph nodes. This will be sent for frozen section. And also for subsequent. This is again, you can see the left renal vein joining the IVC. So this much clearance you can have, and this is the root of the superior mesenteric artery. Just cranial to the left renal vein, we have the superior mesenteric artery's root. It's getting exposed, and we clear the lymph nodes on the right side of the superior mesenteric artery, so that lymphadenectomy in this area is not compromised. This is, you can see the fascia is inside. We don't circumferentially dissect the superior mesenteric artery for the fear of damaging the sympathetic nervous system and then going in for intractable diarrhea. So we don't completely denude the superior mesenteric artery, only on the right side. As you can see, this is done on the superior border of the left renal vein. Therein you get the origin of the superior mesenteric artery from aorta. This is called extended cocker, well on to the left side of the aorta. It's called extended cocker. You can see the origin of
the superior mesenteric artery. And this is again, majority of the technique we use, patients we use artery first approach. The next is we divide the neck in the sense, divide the gastrocolic trunk as low as possible so that the neck is exposed widely. Divide this trunk as low or as close to the its insertion or draining into the superior mesenteric vein so that you have what is called a wider neck mobilization for us, so that subsequent next division becomes easy. That's what we are going to do in the form of tunneling of the neck of pancreas. So this is, as you can see, Cocker maneuver is done. Exposure of the pancreas in the head portion is completed. Then we go to the division of the gastrocolic trunk formation, which is formed by the combination of right gastroepiploic vein and right colic vein, which drains into the superior mesenteric vein. So this is, you can see that neck, and then this is the tunnel, starting of the tunneling. So this is the inferior border of the pancreas. And this is what I said, divide low. This is as low as possible. The gastrocolic trunk, as you can see, the formation. Below the formation, we divide close to its insertion or close to its drainage into the superior mesenteric vein. And then this is again one of the key steps, the tunneling. This again requires a lot of learning curve. Once we cross this learning curve, I believe we can complete the laparoscopic, total laparoscopic Whipple's procedure. This we need to learn it properly. That's why proper case selection is vital in the initial stages. If there are resectability issues, this will be difficult. So we mobilize the neck away from the splenoportal confluence, taking care of small branches which drains into these veins. And these veins, if you don't identify, sometimes they can cause bleeding. So first thing is gastrocolic trunk has to be tackled. In fact, I worry about the gastrocolic trunk more than the GDA because the vein, these veins can retract, can cause bleeding. It's one of the important reasons for conversions. You can see the splenoportal confluence is identified and then the tunneling is done. So once the tunneling is done, then we go to the irreversible step of, the first step would be the duodenal divisions in case of pylorus preserving Whipple's pancreatoduodenectomy. As you can see, the lymph nodes, the suprastation 5 and 6 again comes with the specimen so that we do adequate lymphadenectomy here, as in this case, as you can see. So once that is done, the lymph nodes are cleared off in this area because we are going to apply staple. This is 5 and 6 stations, and then we apply endo-GI cutter so that the first of the 3 divisions is done, the duodenum or stomach, depending on the nature of the pancreatoduodenectomy. Next, we go to the porta in the hepatoduodenal ligament. So the division of the duodenum or the stomach gives a lot of exposure to the hepatoduodenal ligament. And in the first first step is to divide the gastroduodenal artery close to its origin, but leaving a stump. In case of GDA bleed postoperatively, we should have some stump for that to tackle it by radiological intervention. It should not be a complete flush ligation like we do it for other malignant, other areas. A small stump is left. Now the clipped portion is the divided end is the right gastric pedicle, and the hemolock is onto the gastroduodenal artery. So once the GDA is, as you can see, it's clipped and divided. It's not divided yet. We then go to the dissection of the bile duct. We can do it with sharp scissors or with energy sources. This is harmonic HT 1000, which has got long blade. So once the bile duct is divided, the distal portion is looped so that there will not be any seepage of any material from the distal divided portion. Proximal one is occluded with endobull duct, and then the gastroduodenal artery is divided. That gives even more space. That paves for the lymphadenectomy in the hepatoduodenal ligament. This lymphadenectomy has to be done properly. It's one of the key steps again. Exposing the portal vein, clearing the lymphatic tissues around the two vessels, both portal vein as well as the hepatic artery. In this particular case, we had the replaced right hepatic artery, as you can see. This is the replaced right hepatic artery. This is the common hepatic artery or hepatic artery proper. So this is the portal vein below. So we dissect and skeletonize all the vessels so that the lymphadenectomy in the hepatoduodenal ligament is complete. In the interest of time, I will just fast forward it. So this is, you can see, complete lymphadenectomy. So this is the bile duct division. Then we come to the pancreatic neck. We have to do the occlusion stitches so that the bile duct distance, and then put stage sutures. What we do it is leave a little bit more of the pancreatic duct stump, as you can see here, so that the anastomosis can be as you can see, the stump is little away from the divided edge, so that the anastomosis is, we can do it a proper duct to mucosa. This is the neck division. The occlusion stitches are done with a umbilical cotton tape, and then the stay sutures. This is, I'll just run it because it's very important. We can divide a portion of the pancreas with the energy sources, but at the site of the pancreatic duct, it's better to avoid the energy sources or just tease it so that there won't be any thermal injuries. As you can see nicely, the duct is seen clearly. We are going away from the duct. The energy sources are avoided. So it's a sharp cut, leaving a stump of about 5 millimeter, so that the mucosa sprouts out nicely, as you can see here. The juice, because of the distension sutures, or around the pancreas with umbilical tape, it distends the duct, so that while we divide, it just gushes out, the pancreatic juice gushes out. Then this is the, as you can say, long stump, which facilitates pancreatic anastomosis. The jejunal division is done. Initially, we were using dividing the jejunum in the infracolic compartment, but now we do it in the supracolic compartment, because that straightens up the first jejunal vessels, so that we can really see those vessels. It twists that mesentery and then brings the first jejunal branch to our right side, so that it can be identified, identify, and then cut. Make a hole in the mesenteric, jejunal mesentery, which facilitates the division of the jejunum. Yes, this is the jejunal division, as you can see. Then final thing is rubber band technique. This is again an innovative technique which we got it from the robotic surgery technique. And then once we retract it, now you see the uncinate, which is very crucial, uncinate and the SMA clearance. So this is the superior mesenteric vein, which is retracted. This is the superior mesenteric vein, splenoportal confluence. So once we retract the SMV portal vein onto the left side, the superior mesenteric artery comes into this is superior mesenteric artery. The entire attachment of the uncinate to the SMA. As you can see, the rubber band retraction helps us to push it, retract it onto the right side, so that we have a very good exposure here as well. We just tease the tissue, identify the structures. If it's a big vessels, we clip it. If it's a small vessel, we use. This is the inferior pancreaticoduodenal artery, which is clipped and divided. As you can see, it's not just a mass coagulation or mass division. So once we go, the final bit would be division, clipping of the superior pancreaticoduodenal vein. which is vein always better use the hemolock so that it doesn't slip. So that almost brings to the end of this resection. So this, as I already told you, this is a case of a replaced right hepatic artery. We have to take care to preserve that vessel. If you are not very careful, then this can sometimes be getting injured. And we should all have the information preoperatively so that we seek, identify, preserve, and rather than landing up in problem. Pancreatic jejunostomy, I'll run through it because I have a few slides on the literature part. This is the transpancreatic sutures. This is a modified Bloom-Gott type of anastomosis, figure of 8 stitch, and then we come back to the jejunum so that it just engulfs the pancreas. So especially for high-risk pancreatic anastomosis, we use these transpancreatic stitches, which keeps the jejunum approximated to the pancreatic stump. We use 1 or 2 stitches above and then 1 stitch below. So that's our routine procedure. So once, as you can see, we go back. And then this is a proper duct to mucosa. Initially, it's interrupted. If it's a dilated duct, we use a continuous sutures and one anterior, one posterior. So especially in dilated duct. If it's undilated, I prefer an interrupted. Even now, for undilated duct, we use a continuous suture, duct to mucosa. Then we come for the inferior to the anastomosis, 1 or 2 transpancreatic stitches that keeps the jejunum approximated to the pancreatic stump. So this is about the pancreatic jejunostomy. I'll skip the hepaticojejunostomy and duodenojejunostomy in the interest of time. I'll take hardly 2 minutes to complete. We have to have strict selection criteria to start, especially beginners. We should select with a small periampullary tumors. As you can see in the early series, all are predominantly periampullary. With regards to the oncological radicality, we also published a few years back, both are equal, both open and laparoscopy. Age is again no bar, again published. Even portal vein resection, after learning for a few years, we can also do portal vein resection. And this is our long-term results, which can be compared with any of the best open series as far as the 5-year survival is concerned. And again, we did the first laparoscopic, randomized control trial between open and laparoscopic PD, which showed that the short-term outcomes like the shorter hospital stay is with the laparoscopic arm. This particular our plot trial was followed by the parallel trial from Spain, but multi-center trial have shown that the results are not so great. But continuous improvement has led to increased or a better post-operative pancreatic fistula with the laparoscopy group. And any new technique has to go through proper guidelines. This was the first attempt in 2016 during the World Congress. That was followed by our Coimbatore. Majority of you were there to answer the question of technical details. This is our pancreatic, the Coimbatore Summit statements, the second international summit. The first one was in Sao Paulo. This was published. It dealt with technical details in detail. That was followed by the international summit on the evidence-based guidelines on minimally invasive pancreatic resections. And finally, the international consensus on laparoscopic pancreatic duodenectomy was published last year. These were the efforts towards standardizing laparoscopic PD. More importantly, we need to have a proper technique, a proper training in this particular specialty, because without training, this cannot be practiced widely. To improve the percolation of minimal access surgery, robotic surgery is being brought in, which has got surprisingly better acceptance than the laparoscopy. So I would say when you take into consideration the broader minimal invasive pancreatic duodenectomy, robotic surgery has got a bright future. So my conclusion is With regards to the laparoscopic PD, it has to be learned step by step. We need to standardize the procedures. Evidences including the randomized control trials, meta-analysis are forthcoming. Learning curve, proper learning is very, very important. And for that, we need to have proper fellowships, proper, residency programs are vital. And finally, to improve the percentage of minimal invasive pancreatic resections, I think robotic surgery is one of the ways to move forward. So with this, I conclude my talk. And once again, I thank you for the opportunity given to me. Thank you very much.
Thank you very much, Dr. Senthil. It was wonderful listening to your lecture. As always, I have seen you and heard you so many times. It's always great. You always make tough things seems like a child's play, and that is wonderful. And you are too modest a person. You do great things, wonderful job, extremely tough surgeries, and you pretend as if you are doing hardly anything. It's great of you. It was a pleasure having you. We would like to hear more from you, but because of paucity of time, we'll have to start the next session. Thank you. Thanks. Thank
you so much, madam. Thank you, Professor Varma.
Really. Words are not enough, Professor.
Thank you.
Great job. Can we start the next session, please? I think the next session we have moderator Dr. Sanjay Jain. Is Dr. Sanjay Jain logged in?
Yes, Athiya. Good afternoon.
Good afternoon,
Dr.
sir.
Athiya, I take a permission to leave this
Thank you
session.
so much. Thank you so much for being with us, sir.
Thank you.
Thank you so much. It was a wonderful experience. You are a great teacher, sir. Thank you so much. The next presenter is Dr. Sumohan Chatterjee. He's working as a senior lecturer in Manchester Hospital and NHS, and he'll be talking about breast reconstruction. Can we have Dr. Sumohan Chatterjee with us, please? Is he?
Hello, can you hear me?
Yes, we can hear you. Good morning. Good afternoon, sir.
Good afternoon. Good afternoon. Good morning from Manchester. It's a pleasure to join you. I know we are running a bit short of time, so I will start with the breast reconstruction talk. There are potentially 3 talks that I had prepared. So let's see what we can share. Okay. Can I share my screen? Can you see my screen at all? Can you see my screen?
Yes, we can see. We can see your screen.
Can you see the PowerPoint presentation?
Yes, we can see your PowerPoint presentation.
Oh, thank you very much. So I had 3 talks. One is on ADM, which is acellular dermal matrix presentation, breast reconstruction. I have 1 talk on the discus dorsal flap, but I'm still a bit stuck with time because I've got something else on my diary, 10 o'clock here. So bear with me, please. So this is the common reconstruction we do nowadays. This is based on using some kind of a mesh, and I use ADM. There are various meshes which are available, which go from bovine skin to porcine skin to artificial vicral mesh and things like that. There's lots of things. But the commonest one we use is some kind of a biological mesh. And why do we do it? It is because we can do this reconstruction direct to implant. The recovery is rapid, there's good cosmetic outcome, the lockdown rates are good, we don't need that much revision, and the patient satisfaction rate, very crucially, is very high. And we've been doing this for nearly 10, 11 years now. So if you look at the history of how things have evolved, obviously we started off doing the 2-stage procedure where we used to put the tissue expander underneath the muscle, and this was what used to be called the complete muscle coverage. And this never gave a very good result, although this was the simplest reconstruction to do. And one of the reasons why it did not give good results is because in the inferior pole, the muscles never used to expand very well to have the implant put in. So about 11 years ago, we started using Stratus, which is a porcine mesh. And basically we used the spectral muscle at the top, and we used the stratus in the lower half of the breast. and this provided a good opportunity to do reconstruction. And then from 2015, 2016 onwards, we started doing what is called the prepectoral, which is the sparing the pectoral muscle. So this is what we are talking about. This is a typical patient who has a multifocal cancer, who needs a mastectomy, who wants reconstruction. And this is all the ideal patients to start off with doing this kind of an operation. So this patient, again, she wanted implant reconstruction. Now you cannot have an implant reconstruction in a ptotic breast like this. So we decided to do uplift and do reconstruction at the same time. This patient obviously wasn't a breast cancer patient. She was a BRCA2 patient. And this was risk reducing surgery. And this one, actually, we did it in 2 stages where what we call supercharging the pedicle by first doing a reduction, leaving it like that, and then doing the operation. It's much easier to do it that way than doing it at one stage. So the preoperative workup in these cases are very, very important. So clinical assessment, having a breast care nurse, a specialty nurse with you, having an extended appointment where you can spend time with the patient, showing patients results, showing patients what can be achieved is very important in managing expectations and preparing the patient for surgery like this. And as I said to you, ptotic breast provides a different challenge. And you have to realize, and we didn't realize this when we first started, and this is always part of the learning curve, there are certain patients who don't do very well with this operation. And definitely we used to do some patients who had prior radiotherapy, and we stopped it now because we know that the integration of the mesh to the skin isn't very good. And obviously you have to be aware of patients with other health issues like obesity, like diabetes, like vascular disease, like connective tissue disorders, like scleroderma. So I don't think smoking is a huge problem amongst women in India, but in here, that is something we are very, very concerned about when we are considering this kind of operation. So when complications happen, inevitably, we think about what is wrong with it. There's so many idioms. Is it the idiom? Is it the implant? Is it the patient? But it's usually the surgeon. It's either you choose the wrong patient or you do the operation in a manner which is not going to give you success. So you have to put yourself and you have to really reflect if something doesn't go right so that you can learn from it. So let's talk about a few typical complications, and then we will talk about what can be achieved. So you can have seroma. This is very common. That's why we leave the drain for 1 week. You can have what's called red breast syndrome, but this is getting very rare now. Infection obviously is the biggest worry, and skin flap edge necrosis, which could be because the skin wasn't dissected properly or the edges were not trimmed, or the implant size is too big and therefore it put pressure on the actual reconstruction. The other issues can be late, which is seroma. Capsule contracture is relatively late, rare to happen. And we'll talk about dislocation and animation in a bit more details later on. So this is a little bit of our data of about 300 odd patients. And overall, the outcomes are very good. In the start, we used to use round implant, which was the 30%, which was the original series. But now, more or less every time, we use an anatomical implant. And again, it is the size of the implant which is very important, because none of these meshes have the tensile strength to support anything beyond 500 cc or so. So this is what we call instruction failure, where we have to remove the implant. This number is going down. This 4.9% was from 2017, 2018. I didn't put the latest data, is much lower. It's about 3%. And that includes salvage of implants, where we may have had to remove the implant because of problem, but we could salvage it by reintroducing the implant. So the patient did not really lose the implant, but may have gone through a period where they had to have secondary surgery. So as I said, what have we learned? Meticulous subcutaneous mastectomy plane is the key. So again, your ability to do a good mastectomy is what will give you success. And also we've started using other things like a negative pressure. And this has really have made an impact in wound healing, especially in the higher risk patients. Skin flap necrosis, and this is something I touched on, and it is very important to realize that it is ultimately how you choose patients and how you handle the tissue, which is going to give you success or failure. Infection, again, if you look at the national audit done here in this country in 2010, it was nearly 10, 11, 12%. Our unit was at 3%, and that is because we follow a lot of guidelines, a lot of strict instructions we give our colleagues and our juniors to follow. And how do we reduce infection? IV antibiotics intraoperatively and 5 days postoperatively, oral antibiotics, strict asepsis. We don't let anybody come in and out of theater. We limit the operative time. If you're doing bilateral surgery, we have 2 teams so that you reduce the time in theater, because whatever you try, the body cools down a bit, and this helps in bugs growing there. And as I said to you, if there is a problem, it is not good to sit on it, but actually go and aggressively treat it and attempt to implant salvage. Red breast syndrome, I touched on, it's relatively rare nowadays, and it was partly because the ADMs were not being washed properly, and it left the preservatives on it, and that caused the red breast, but this is getting very rare now. Early seroma, this is very common, and we get our radiology team to do an ultrasound scan and drain it under strict aseptic guidance. And it's important to drain the seromas which you think will cause wound problems. A little bit of seroma is very common, you'd ignore that. But if it's a big seroma and causing pressure on the wound, then that is something that you need to interfere. So these are the key things which is higher risk other than the patient factors we talked about. If you do clearance, higher risk of seroma, and that is what increases the risk of complication. Operating time, this is a very independent factor. So you have to do it in good time. Recent chemotherapy, neoadjuvant chemotherapy, again, is a factor. And as I said to you, implant sizes, which is more than 500, are not good news. So let's talk about the late complications. Late seromas can happen. But nowadays, if you have late seroma, you have to make sure that there is no evidence of ALCL. So you aspirate it and send it for cytology. But ALCL remains very, 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 very rare. Capsule contracture is relatively rare with this technique. And I think we'll talk about the pre-PEC reconstruction. It's getting even rarer. So it's not a big problem as we stand at the moment. This is a bigger problem with what we call animation. This is a typical problem where we use a subpectoral pocket, and it is the pectoral muscle which acts independently, and this is what it causes. So this is a problem. Patients don't like this, and it can be quite difficult to correct. And that is one of the big reason why we are moving on to more of the pre-PEC reconstructions. The other thing which can happen in the long term is what is called traction rippling. And this can happen because the implant weight is too heavy for the body to cope with. And what we can do is change the plane, put more ADM there and lipofilling. And this is all the functional deficit. So this is a lady who's in a wheelchair. So if you use a pectoral muscle, you can cause problems with her trying to get off the wheelchair. So let's talk about how we can do it. So you can see, you can also use the dermal flap. So don't forget that the body can sometimes provide you opportunity to use the own body to operate. So this is something which is low cost. In a ptotic breast, you can do a reconstruction in the subpectoral pocket just using the dermal flap, or you can do a prepectoral one by using a composite dermal flap and the stratus or any other ADM that you want to. So let's talk about the prepectoral full ADM cover. This is a relatively newer technique. We've been doing it for the last 5 years. In the start, we used 2 pieces of ADM before companies came up with better quality ADMs, which you didn't need to use 2 ADMs, because if you use 2 ADMs, that doubles the price, and each ADMs cost nearly £2,000, so it doesn't come cheap. So basically the concept is that we spare the pectoralis major muscle and we use ADM in front of the total coverage of the implant. And this is by and large giving better results and also preserving the shoulder function, not causing as much animation and less painful. So I want to concentrate on this because I think this is the way forward. So it's a single stage, it gives good cuspicis, and patients who like swimming or like playing tennis and is more active, this is a better option for them. So it's where the pocket is. And if you look at it, the pocket is in front of the pectoral muscle. And why does it matter? And as I said to you before, it's a shoulder, less postoperative pain. It gives a better opportunity to preserve the cleavage, less animation, and we're getting now better data that it actually, if you have to give post-mastectomy radiotherapy to these patients, they actually do better. So how do we do it? Composite dermal sling with ADM, with 2 pieces of ADM. And now we have, as I said, companies who provide ADM pockets like Braxton, which is a porcine mesh, or a complete anterior coverage using a Surgiment mesh, or even a synthetic mesh using the tie-loop bra, which is basically a synthetic mesh, like a hernia mesh kind of thing, but coated with titanium. So this is one of the examples. This is a Braxton. So basically you have to stitch the implant inside it, outside the body of the patient, and put it inside. And this is how we choose patients. So we choose a patient with the ideal BMI range. We stretch it to about 30, 32, no higher than that, no diabetes. We avoid patients who smoke, good ASA grade, no previous radiotherapy. And we stretch it sometimes with patients with diabetes and previous history of smoking, but we warn patients that they run a higher risk. And really, the morbidly obese patients, the poorly controlled diabetes, immunosuppression, and those sorts of things, it is not an operation which should be offered. And you really best avoid offering this to those patients. Is it perfect? Hell no, nothing is perfect. You can get rippling and you can get visibility on the top of the implant because you don't have the thick pectoral muscle to cover the top part of the implant. So there may be need for secondary procedures like lipo-filling. And again, you have to be very careful with dissection and preservation of the intramammary fold. So any cancer which is close to the intramammary fold, you may have to take the intramammary fold out, but recreate the intramammary fold for your prepectoral reconstruction to be successful and keep the oncological safety. So this is one of the patients. So she had 65mm high-grade DCIS, so she had nipple and skin-sparing mastectomy and reconstruction. Inevitably, immediate post-op, it looks much swollen, but you lose about 10-15% of the immediate post-operative size, which is due to tissue edema and things. So you have to plan that way. This is again a full implant cover with dermal flap and stratus. So this is a composite one. And the composite one is a good one to do in patients with ptotic breast because natural tissue is always better than man-made tissue or even mesh. Again, this is a bilateral risk-reducing mastectomy in a brachycarrier, and you can see we can get good results from this kind of operation without any donor site morbidity. Again, more example of these, Weiss pattern scar is something we commonly use. You have to be careful with the T-junction and obviously the nipple blood supply. So this is quite high skill. It is not sort of operation should be attempted in your first 25 or 50, but this takes time to develop expertise in to reduce your chance of failure. So there's a published guideline about how to use this matrix from the Association of Breast Surgery in the UK and the plastic surgical team. And let's talk about a patient that we did. So this is a lady, she had a wide local excision and sentinel node biopsy, and the wide local excisions showed extensive involvement of the margins. So she was offered to have a mastectomy. The original operation was done with a periareolar scar, and you can see she's got a fairly ptotic breast. She did not want any surgery on the other side, so we had to do everything we could do to match the other side. So we decided to do immediate reconstruction, skin and nipple sparing mastectomy with immediate reconstruction using a Surgiment mesh. And I'll show you the mesh in a second. And this is basically a bovine mesh, and it's a fenestrated mesh which you can stretch. So this is the preoperative pictures. So we did the mastectomy with the same scar. We extended it slightly in laterally, and that is because we wanted more access, and we wanted to we wanted to use that same old scar. So that gives you opportunity. You're near the nipple. Scars above the nipple don't do as well as scars below the nipple, and this is because of the blood supply to the nipple. So if you're doing this operation, if you put your scar above the nipple, you are higher risk of nipple necrosis. How do you preserve the nipple? You have to go back to the basic, where if you imagine if you're doing total duct excision, that is the plane that you have to follow. You have to core out the nipple and send it separately to make sure that histological analysis is done. And you have to warn the patient that if that comes back as positive, she will need the nipple removing at a later date. So this is the mastectomy, and what we do routinely is we weigh the mastectomy because that gives us some idea about the volume and the weight of the breast. Now, the next picture is me washing out the cavity, and this is a key part of the operation. And the other thing you can see there, I don't know how it projects, but if you can see my cursor, the inframammary fold is clearly marked there. In fact, nowadays what I do is, this is a picture from a couple of years back, but nowadays what I do, I put skin clips there because the skin marks can get rubbed off with the betadine or the washout and things. And that's when it's easier to put the skin clips. So washout is important because that cleans the cavity, that gets rid of all the fat which is there lying free, which can cause infection or fat necrosis if it's stuck to the back of the skin flap. And then prepare the skin again by re-draping it and putting betadine on the skin to reduce the risk of infection. Then we put the drain in. The drain is a crucial part of the operation because that will take away the seroma in the first 7 to 10 days, and that will help in the healing process. So then we measure things pre-op, but operatively we again measure the cavity using a ruler, and the weight of the breast and the measurements which give us some idea of what implant to use. We use a tissue sizer. So we put it in and we fill it with saline and we match it with the other side to see what exactly would be the correct volume. And this is not an exact art. And it's easy to get it wrong one way or the other. Either you can underestimate or overestimate. So this takes a bit of training to understand. So while we're doing that, the mesh needs to be rehydrated. So it's put into a bowl of saline for it to rehydrate. So these meshes don't need any further cleaning than that, which is a good thing. And this is the mesh, and you can see it's got it's like a lattice, and the lattice basically helps it to stretch and cover implants up to 550 cc. Anything bigger than that, it's not big enough to stretch. So then you put it inside the breast, and then you have to start putting it to place. It doesn't need many stitching. So first, when you put it in, so if you imagine the places to put the stitches are medial, so you need about 2-3 interrupted stitches medially, and you need about 3 stitches or superiorly where you know is the top of your implant. So you can restrict your implant's movement superiorly by that. So once you've done that, that creates the pocket, and then you introduce the implant into that pocket. As you can see, the implant, this was about a 500 cc implant, and it is completely covered by it. Once you've covered it, then you have to make sure you have some lateral control. So again, 2-3 stitches laterally to make sure your pocket is secure. And we try to push it as medial as possible, because if anything, if you don't do it that way, you may find that the implant has moved a bit lateral, because that's the easiest place for the implant to move. Inferiorly, we don't put any stitches, so we wrap the ADM around it so that you can get a much natural intramammary fold and ptosis. And after we've done that, we close the skin in 2 layers, dip dermal, which could be interrupted or continuous, and then subcuticular closure of skin. And then we use a tissue glue. Tissue glue is very good because it is bacteriostatic, and it blocks any bacteria going through it for the first 24-40 hours till the wound seals. And these are the immediate post-operative pictures. As you can see, she will get a good result out of this. And we also use the Pico dressing, and that is the battery with it. So that is how we do it. It looks simple, but it needs planning, and it needs people to understand what can be achieved and what can't be achieved. Any operations like this we do, we have to collect data, we have to collect, and we have to set standards. So these are the standards which are set at the moment, and we audit our work against these standards. So it's actually quite a relaxed standard. I think there is room for improvement, and there is always a learning curve with this. So that concludes my first talk. I can either go on to another talk, or I can use another presentation to talk about latissimus dorsi flap. So please let me know what you want me to do.
So I think you can go ahead with the LD flap, because that is
LD flap, okay.
Used.
Okay, thank you. Okay, so let me. Can you see my screen at the moment, or?
No, we can't see. We can't see your slides, sir.
We can't see. Okay, just 1 second. Can you see it?
These are the older slides.
Yeah, that's fine. I'll open the new one. Yeah, I'll open the new one. Can you see my slide now?
Yes, sir, it is visible.
So latissimus dorsi flap is a very versatile and a very stable flap. This is something, this used to be the workhorse of our reconstruction work. sadly, we don't use it as much as we used to do in the past because of the advent of the ADM. And when patients are given a choice between having an operation which there is a donor side morbidity, they inevitably choose something which doesn't. So we use it nowadays very sparingly in immediate reconstruction. There is a big role for it for post radiotherapy, mastectomy, skin radiotherapy, and that's where we use it commonly. It's not a new flap. It's been in use for over 100 years. It was first described by this Italian surgeon, and it's been in use for very long. And this is one of the first reconstructions I saw nearly 25 years ago, and it still is a lovely operation to do. I really enjoy doing this operation. Sadly, we don't do as many as we do. So this is one of the first use of publication talking about 30 latissimus dorsi flaps for chest wall defects. And it is, as I said, it's a versatile flap. You can use it for a lot of things. You can use it for chest wall coverings, for locally advanced breast cancer or recurrence. You can use it for immediate reconstruction. You can use it for delayed reconstruction. And I would say if somebody's had post mastectomy radiotherapy, I would advise you to wait at least 6 months, then evaluate the skin and then consider doing it. Contraindications, you have to check if the patient has got an absent LD. Have seen this once or twice in my career. When I first started, I used to do a lot of delayed LD flaps on patients who had been operated by somebody else. And there's been once or twice I've gone in and dissected the axilla to raise the flap and found there was lovely vitral or a Prolene stitch on the original thoracodorsal vessel, which has been carefully divided by the previous surgeon. Now, that is not a problem because the branch which goes into the serratus anterior is very strong, and that can be used to raise the flap. So it's not an absolute contraindication. Again, BMI is an issue, and the BMI is an issue because the fat is relatively poor in vascular. So you may have a very well vascularized LD muscle, but sometimes it does not go up to the skin because of the thickness of the fat. So be aware of that. I have once lost a flap where the muscle was absolutely fine, but the fat to the skin did not survive. And I can tell you I've lost 2 LD flaps, and that was one of them. And the other one was I had used it for a sarcoma patient. So it was in a slightly different angle. It was slightly higher, almost infraclavicularly, and maybe it twisted too much. So beware of patients with high BMI. So this is a bit of the anatomy. I'm sure I don't want to bore you with this, but this is how it works. This is the thoracodorsal artery, and that is what you base the flap on. And that is your skin pedicle that you're going to take. It's a very robust flap. And this is the basic surface anatomy that you need to be aware of when you're starting to do these operations. You have to preoperatively mark it. It is a fan-shaped muscle. When you're first doing it, one of the tip I can give you is you take an apron and divide it into half. And if you put the long end of it near the shoulder, you can literally see how the muscle is in the back of your body. And it's quite easy to then draw pictures and swing it and see how it sits. This is something we used many years ago when we were training. We don't use it anymore because we feel more confident, but it's still a very easy thing to show trainees how to use it and how to do it. And again, this is where it's very important to understand where the artery is, and especially if you're doing it as a delayed one in somebody who's had axillary node clearance and radiotherapy. It is very important to understand the anatomy so that you can go and find this artery without damaging anything. So this is a very important part of it. So if I'm doing a delayed LD, somebody who's had clearance and somebody who's had previous radiotherapy, I start by putting the patient on her back and opening the old mastectomy area and also dissecting it under direct vision. This obviously increases the theatre time a bit because you have to put the patient in 3 positions. So sometimes to save time, if somebody's not had a sentinel node or not had radiotherapy, you can put the patient directly in the lateral position, and then you have only 2 positions. So it increases the time that you save time on that. So it is very, very important to find the pedicle and make sure the pedicle is not twisted. So where do you put the skin flap? And again, you can be as innovative and imaginative about it. The top one is something that the French use a lot. And again, we've started using the green one here, which is like an anterior one. And the advantage of the anterior one is that you get whatever you want, skin flap and everything, but the scar literally goes down the posterior axillary line, and therefore the patient's back looks much more well preserved. So if anybody is wearing a low gown and things like that, they don't see the scar. The popular place to put it is transversely, what we call the brow line. So it gets hidden very nicely under that. But if you want a big skin flap, then I would go for the purple one because it gives you a long skin island, which you can then move forward. So if the patient's body habitus is such that you need a 20 centimeter skin island, if you're doing a delayed reconstruction, then that is the one I usually use. But you can be very innovative. You can, when you're drawing this up rapidly, you can show the patient where exactly it's going to be, and the patient might say, oh, I like it better here, I like it better there. So you can be very innovative about these things. So again, this is something that, this is a real patient that we did. So this is a lady who had reconstruction, and this is the preoperative marking. And you can see how we've done it because the patient had nice skin fold, and we wanted to use that skin fold to our advantage. So one of the things that we used to face in the past is where you put your mastectomy scar. So this was the traditional mastectomy scar, which was right in the middle or even angled. And this actually is a more difficult one to reconstruct. So nowadays, the planning starts at the time of mastectomy, and we try to do mastectomies based on the intramammary fold scar. And these are much easier to reconstruct later, whether you're going to use an LD flap or you're going to use a delayed ADM. So this is one of those traditional ones. And you look at the scar, then you have to decide whether you can, to excise the scar or not. Sometimes it's better to excise the scar, especially if the patient's had radiotherapy. And this is the position of the patient when you're harvesting the LD flap. And again, it's very, very important to maintain the patient in a good position, maintain that the pressure points are well protected. And remember, we're all used to doing laparotomies in the abdomen. There's a similar thing in the back. We have the fascia of Scaffer and fascia of Camper equivalent in the back. And that is the plane that you have to learn to recognize. So the superficial layer, if you're doing autologous LD, needs to be taken. And that is why if you're doing autologous LD, you can have to warn the patient of donor site disfigurement. If you don't want to do an autologous LD, you're going to use an implant anyway, then you can preserve the back and improve healing of the skin in the back and not take the superficial layer. So this is part of the picture. So this is, we were not doing a autologous LD. So this is dissection, which is carried out. You've taken, you have to gently slope the fat from your skin pedicle down to the muscle. And that keeps the flap in a better vascular shape. And as you can see, the muscle is carefully being dissected out. It's a lovely anatomical operation, and it's beautiful. So technical considerations. So we divide it into 6 zones, and it's all to do with how much fat you want to harvest. And nowadays, if you do not want to damage the back and take too much fat from there, what we can do is we can inject the flap itself with fat during the operation. And we started doing this more regularly nowadays. And this helps in preserving the back and also enhancing the volume you can get from a LD muscle. So you can get about 200, 250 grams of tissue from the LD muscle very easily. You can augment it by at least 100, 150. So up to 400 gram breast, you can reconstruct without using a fat. And again, you can remember, because if you do an autologous LD, you can always go back and inject more fat later on. So this is the flow chart we use. Delayed reconstruction, as I said to you, we can use more of the tissue by injecting fat and increasing the volume. And things to really consider is, do you divide the tendon? Now, one of the reasons of dividing the tendon is it gives you more freedom to the flap, so you can take it more medially. The secondly is it becomes easier to stitch down. And thirdly, in the post-operative period, the patients don't have that animation problem. So nowadays, if I can divide the tendon, I divide the tendon. And I divide the tendon right at the top. But the crucial thing when you're dividing the tendon is you have to be absolutely sure that you have identified the pedicle, and also you have not twisted it. So you have to do it under direct vision, because it's very easy to twist the pedicle once you divided the tendon. So where do you put it? Which pocket to use the pectoral muscle? If the patients had radiotherapy and the radiotherapy changes are quite pronounced, I do it in the subpectoral pocket. If I don't have to, then I do a peripectoral, where I use the whole muscle to cover the implant. Again, transacting the nerve, I don't do it routinely, but there has been occasions once or twice where we had to go back and divide the nerve later on, which can be a bit of a painful thing to do, because you will need a Doppler to identify the pedicle and then find the nerve. It's not easy, but we had to do it on a couple of patients where patient was really bothered by twitching, and we had to do it, but that's not common. So I wouldn't routinely transact the nerve, but when you transact the nerve, you will lose a bit of volume because of the loss of the nerve, low motor contraction. Perioperative care, again, it's pretty simple. You can manage these patients on the ward, make sure the patients are kept warm, and the flap is monitored by trained nursing staff so that they can inform you, and if you need to intervene, you intervene very early. And this is some protocol that we use for the nurses, where we teach them about flap. In my experience, it's the venous congestion which is more. Sorry, can you hear me?
Yes, sir.
Hello?
Yes,
okay.
Sir, we can hear you.
Yeah. So the venous congestion is more of a problem. And sometimes if this happens, you have to take the patient back to theater, open up everything. And sometimes you just need some warm saline packs. And once you've freed up everything, reassessed it, it settles down very quickly. But venous congestion is a more of a problem and more of a danger to these flaps than actual low blood flow into it. So venous congestion is very important to recognize post-operative period. Complications early, as we talked about, hematoma. Again, if you have the hematoma right behind the pedicle, then that can compromise the blood supply. Again, flap loss. Total flap loss is very, very rare. I've done over 350, 400 of these, and I've only lost 2. And as I said to you, one of them was wrong patient choice. The other one was wrong place to put it in. So it's not the problem of the flap, it's problem with the surgical decisions. And you can get delayed wound healing at the back. if the wound is so tight because you've taken so much of skin pedicle. Post-operative, these flaps last forever. I sometimes see my patients who have done 20 years ago and they come back and it still looks very good. So it's a very versatile flap. Considerations, and I said to you, who should operate and who to operate is possibly the most important things to consider. Again, these are some results. This is pre and post-op immediate reconstruction. These pictures are pretty old, actually. This must be about 10 years old, these pictures. We rarely use it nowadays. Mini LD flap, there's a lot we talk about. I have never been a big fan of the mini LD flap because you're burning your bridges. So I've never used it, and now obviously it's superseded by therapeutic myoplasties and light caps and other local perforative flaps and Tdaps and things like that. So I wouldn't advocate using such a valuable resource and using it as a mini LD flap and putting radiotherapy onto it. Yeah, that concludes my presentation. I hope it's useful. If I've got 10 minutes, so if anybody has any questions, I'm happy to take those.
Good afternoon, Dr. Chatterjee. This is Dr.
Hello.
Seema Khanna from IMS BHU.
Hi.
I compliment you for an excellent presentation.
Thank you.
I have one or two small queries. One is reconstruction either with an implant or after autologous reconstruction. How do you address the issue of adjuvant therapy, either radiotherapy or chemotherapy? How do you address that issue?
Adjust in what way? We don't compromise.
Means the timing, or how do you in the process of the treatment of the patient? Does it affect the timing of the adjuvant therapies?
No. We don't compromise on it at all. I mean, most of our patients who need adjuvant post-mastectomy radiotherapy inevitably needs chemotherapy first. So we are, once the wound have healed, we're quite happy for them to start chemotherapy in 4 to 6 weeks' time. We're very relaxed about it. You occasionally get problems. Just last week, I had to take a patient back to theater. She had immediate reconstruction and she was having chemotherapy. And in the middle of the chemotherapy, halfway down the chemotherapy, she ended up with neutropenic sepsis. And as a part of it, the wound got infected. So we had to go back and take the implant out. It was a late infection, almost 3 months after surgery. But then you can't legislate for such things. So we don't compromise. See, whatever we do, oncology, the main thing is giving them the right treatment. And we tell them that if you need radiotherapy, we give you radiotherapy. We know that there's a 40% chance of for revision if you have radiotherapy. That is well established. Now that 40% was with the old data, with the subpectoral reconstruction. The pre-PEC we think is lower. We think, but we haven't got solid data because it's only 5 years we're doing the pre-PEC ones. We think it is lower, but we haven't conclusively proven that. So no compromise. If anybody needs radiotherapy, chemotherapy, they have the chemotherapy. That is the most important thing for the patient's treatment. We cannot compromise oncological treatment. That's for sure. Cosmesis is important. Reconstruction is important. But we cannot compromise, and we tell that to the patients. And the good thing is there is no data anyway to show that immediate reconstruction actually delays adjuvant treatment. So it can be managed.
Right.
Thank you, Dr. Seema Chatterjee, for your enlightening talk. And we will move to the next.
Thank you very much for inviting me, and all the best for the rest of this seminar. Thank you very much.
We'll move to the next talk by Professor Anurag Srivastava. Anurag Srivastava, sir, are you here?
Yes.
Yes. And
the film first is a 5-minute film.
Okay, sir.
For breast examination, self-examination, and then start the talk PowerPoint. Okay. और ठीक है डॉक्टर
no introduction.
Nice to see you. आपको देख के बहुत अच्छा, बहुत खुशी लगती है आपको देख के, आपके हंसते हुए चेहरे को.
Thank you, sir.
तो पहले स्क्रीन शेयर करा दीजिए हमें.
जी सर.
ठीक है.
नीचे में ग्रीन वो स्क्रीन शेयर का वो होगा सर।
हाँ वो कर दिया हमने।
यस सर, हो गया सर शेयर आप।
हो गया।
सुना है चौपाल वाली ताई को कैंसर हुआ है।
आवाज आप बढ़ा लीजिए।
वो तो पूजा पाठ भी करती
सर, आ रही है आवाज।
तंबाकू और शराब भी नहीं पीती थी, तो उन्हें कैंसर कैसे हो सकता है।
दीदी हमें भी बताइए इसके क्या लक्षण हो सकते हैं और इसे कैसे बचा जा सकता है।
हाँ दीदी, हमें भी बताओ। जरूर जरूर, स्तन के कैंसर के बारे में हम सबको पता होना चाहिए। 90% औरतें अपने स्तन के कैंसर का पता खुद ही लगाती हैं। स्तन की जांच 5 चरणों में की जाती है। पहले 2 चरण में आईने के सामने कपड़े बदलते वक्त देखकर या निरीक्षण कर और बाद के 3 चरणों में छूकर स्तन की जांच करते हैं। पहले चरण में दोनों हाथों को कमर पर रखकर दोनों स्तन के आकार और साइज में किसी भी प्रकार के बदलाव का निरीक्षण करें। साथ ही स्तन की त्वचा में किसी भी प्रकार की लालिमा, चकत्ते, त्वचा का अंदर धंसना, संतरे के छिलके की तरह होना या निप्पल का अंदर धंसना, पानी एवं खून का रिसाव होना, यह सब देखना चाहिए। दूसरे चरण में यही सारी जांचें हाथों को ऊपर करके देखनी चाहिए।
अच्छा, फिर दीदी?
हाँ, आगे के 3 चरणों में स्तन को छूकर जांच करें।
वो कैसे दीदी?
तीसरे चरण की जांच किसी सख्त बिस्तर या तख्त पर लेटकर करते हैं। इसके लिए बाएं हाथ को ऊपर करके उसी कंधे के नीचे तकिया लगाकर दाएं हाथ से यह जांच करें। याद रखें, बाईं तरफ की छाती की जांच के लिए दाएं हाथ का और दाईं तरफ की छाती के लिए बाएं हाथ का इस्तेमाल करते हैं। गीली उंगलियों से छोटी गांठ भी पकड़ी जा सकती है, अतः उचित होगा अगर यह जांच गीली उंगलियों से की जाए। डायल ऑफ क्लॉक मेथड या घड़ी की सुइयों का अनुसरण करते हुए दोनों स्तनों पर यह जांच की जाती है। 12 के कांटे से शुरू करके बाहर से अंदर की तरफ यह जांच की जाती है। इसे 3 बार गोल गोल घुमाते हुए करते हैं। पहली बार से दूसरी बार थोड़ा अधिक दबाव और दूसरी से तीसरी बार थोड़ा और अधिक दबाव लगाते हैं ताकि छोटी से छोटी गांठ भी पकड़ी जा सके। बाएं स्तन की जांच के लिए दाईं तरफ करवट लेकर 12 से 6 और 6 से 12 तक सीधा लेटकर, इसी प्रकार दाईं तरफ के लिए 12 से 6 तक सीधा लेटकर और 6 से 12 के लिए दाईं तरफ करवट लें और बाएं हाथ से यह जांच करें। चौथे चरण में दूध की नलियों की जांच की जाती है। इसके लिए निप्पल को उंगलियों के बीच 2 बार घुमाते हुए पहले 12 से 6 और फिर 3 से 9 की दिशा में गांठ या पानी और खून के रिसने की जांच करें।
अच्छा दीदी, ये तो बहुत ही आसान है।
अरे रुको, स्तन के साथ साथ अपनी दोनों बगलों में भी किसी प्रकार की गांठ जरूर देखो। कभी कभी कैंसर बगल में भी फैल सकता है।
अच्छा दीदी, ये जांच कब करनी चाहिए?
मैंने अच्छी बात पूछी है बिल्लू। माहवारी के हफ्ते 10 दिन बाद यह जांच महीने में कम से कम 1 बार जरूर करनी चाहिए।
दीदी, मैं गर्भ से हूँ, क्या ये जांच मुझे भी करनी चाहिए?
हाँ रूपा, बिल्कुल।
और मैं तो 70 साल की हूँ, क्या मुझे भी ये करना चाहिए?
हाँ काकी, आपको तो यह जांच जरूर करनी चाहिए क्योंकि बढ़ती उम्र के साथ कैंसर होने की अधिक संभावनाएं होती है। सुनिश्चित करें 20 साल के बाद यह जांच सभी महिलाओं को करनी चाहिए। याद रखो, स्तन कैंसर जितनी जल्दी पकड़े उतना अच्छा है। इसका इलाज संभव है।
दीदी, अगर कुछ गड़बड़ लगे तो कहाँ दिखाना चाहिए?
मैं हूं ना, तुम मुझे दिखा सकते हो या फिर अपने नजदीकी स्वास्थ्य केंद्र में संपर्क कर सकते हो।
धन्यवाद दीदी।
ये शेयरिंग बंद हो गई है क्या?
नहीं सर, ये और कंप्लीट, इट हैज कंप्लीटेड आई थिंक।
कंप्लीट हो गया ना? अच्छा, तो अब एक पावर पॉइंट प्रेजेंटेशन है।
जी सर।
ठीक है,
शेयर दैट आल्सो।
हाँ, तो पहले फाइल खोल लेना।
यस सर, पहले
शेयर स्क्रीन में जाके।
हाँ, हमने वैसे आपको भेजी हुई है।
मैं शेयर कर देता हूँ, मेरे पास है सर।
है नहीं तो आप वहीं से खोल दीजिए। चलिए खुल गई आपके यहाँ?
यस सर,
ठीक है, ठीक है, तो ओके। तो गुड आफ्टरनून, नमस्कार। Thanks Dr. Atia and the whole team for arranging this session. The purpose of showing this film was that of फुल करना है कि इसी में रखें? आवाज आ रही है ना?
सर आ रही है।
ऑडिबल। स्लाइड चेंज वहीं से।
Okay, right. So the screening in our country has started on May 2017, and we are using 3 methods: the clinical breast examination, increasing awareness of women with showing this film by the basic accredited social health workers called ASHA workers or healthcare providers in the field at each primary health center or health and wellness centers, as the new name for the primary health center is. And once their awareness is increased, then they are invited for the screening at age 30 and above for clinical breast examination by a trained personnel. So I think skip all this. This is the commonest cancer of human race and it's increasing. And Brazil tops the list for the incidence of cancer, and then New Zealand. And then certainly you see the bottom of the 4 blue lines after all those European and American states. Then we have 4 states of northeastern part of India. Aizawl is the capital of Mizoram. Kamrup district cancer registry is the Guwahati cancer registry under Tata Memorial Center, and then Mizoram state, and then Delhi is the 4th one. And if you see the incidence of cancer in different states, then Delhi tops the list. 41 age-adjusted cancers each year per 100,000 population. Per 100,000 population each year, we are witnessing the highest number of cancers among Delhi girls, followed by Chennai and then different states. So each year about 7 lakh new cancer patients are registered. And unfortunate, the sad statistics is that 80% of these succumb to their disease because they present in late stage. And there is a difference in the urban and rural cancer registries. In Delhi, which is an urban population-based registry run under the ICMR, breast cancer is highest among ladies and lung cancer is highest among males. If you see a rural cancer registry run by Tata Memorial Center in Barshi district of Maharashtra, you find the cervical cancer is the highest among ladies and breast cancer is second. But it is rapidly increasing. And the projection is that in our country, if the same proportion of cancers keep going without any control or screening, by the year 2035, we will have almost epidemic or pandemic of cancers, not only the cancer incidence, but also the number of cancer deaths. So the deaths, the green triangle for males and the purple square is for females. So both the incidence in both genders as well as the death due to these cancers will reach almost a pandemic proportion by year 35 if we do not act now. This is the estimate of the Globocan. Just to touch few aspects about, because we are talking about prevention of cancer, so it's very important to appreciate that moderation in eating and recreation keeps the health in good control. And tobacco is a major enemy of mankind, and many cancers, including the breast cancer, is related to use or abuse of tobacco. Alcohol use again increases the risk of breast cancer besides other cancers, and the relative risk is around 1.32, not much, but 32% increase of women. So obesity is a risk factor for 13 different cancers, and certainly breast cancer also rises with increasing obesity. And the relative risk is about 2.85, very high if you compare. And the factors related to diet are increased usage of processed and red meat, and especially smoked meat, and a diet which is low in fruits and vegetables and high in alcohol increase the risk of. And of course, we know genetic factors, about 5 to 10% of all cancers, breast, are related to some gene mutation. And most notable among these are the BRCA1 and BRCA2 family. And the addition of genetic mutation together with the family history increases the risk very considerably. And ionizing radiation exposure, especially in early childhood, like the radiation for Hodgkin's disease, the mantle exposure, increase the risk as much as high 6 times compared to those who did not have exposure. Stress is now noted as a factor, and it is thought that stress causes some damage in the DNA repair mechanism. And so let us now come to the prevention part. We have 3 components of prevention: primary prevention, secondary prevention, and tertiary prevention. Primary prevention is defined as the process or the public health measures taken to prevent the occurrence of cancer before it has set in. And in this regard, health promotion, improving the dietary habits and lifestyle control of the body weight, regular exercise go a long way in preventing most cancers, including the breast cancer. And in those who carry a genetic mutation, then we have risk-reducing measures like risk-reducing mastectomy or some anti-estrogen drugs. So secondary prevention is defined as the process which halts the progress of disease and prevents the complication of cancer. And in this regard, screening is actually a type of secondary prevention. However, screening can also detect some precancerous lesions like ADH, atypical ductal hyperplasia, lobular hyperplasia, and LCIS and other risk factors, which in turn increase the risk. So screening can actually detect precancerous lesions, and if we treat them adequately, then we will actually be preventing. So screening offers both early detection, which is part of the secondary prevention, as well as prevention of the high-risk lesions. Screening is defined as a public health initiative to detect the disease in early asymptomatic stage among seemingly healthy members of the society. So, and it is not just the process of detection, it is not only diagnosis, it's a complete public health activity, a process of organized detection by some public health, usually government organized measures, and where we approach door to door or invite people for coming into some screening camps or checkup, and then offering appropriate treatment, and then long-term monitoring for the total benefits and harms of the screening. So that is the complete process of screening. It's not just the diagnosis of breast cancer. So if you see the different phases right from the start, commencement of a single cell undergoing malignant transformation, and then it becomes large, a pre-invasive state. And so our screening actually attempts to detect the disease in this stage where it has not become clinically overt lump or has progressed to other parts of the body. So early diagnosis treats the disease somewhere here, whereas the screening picks up and manages it in this phase prior to detection. Why we need screening? This girl, very young college girl, came to our clinic, and the entire breast was riddled with innumerable nodules and a hard lump. And when we evaluated her body with a PET scan, the whole body was full of tumor deposits. So if we leave the ladies to have their tumor grow, they will resume this. It is bigger than a cauliflower. I think it's a big lotus flower with ulceration, fungation, and we call it not T1, T2. This is beyond the TNM classification. We call it T10 tumors, and this will end up in a mutilating surgery. So with no screening, we get in Asia, in Africa, we get about half the ladies will die, succumb to their advanced disease, even without any detection. They will die in villages without any diagnosis. The other half will live with the big scars, painful shoulder, and all the complications of advanced disease. On the other hand, if you embark upon a screening program and detect the disease early, then like this girl lives and enjoys happy, healthy life 20 years down the line. And so we must appreciate that screening is actually very helpful, because therapy of advanced cancers is a societal waste. After initial chemotherapy for large ulcerated truncated tumors, which is actually poisoning the body, you end up having big surgery, often requiring even plastic reconstruction, as Dr. Sumohan just mentioned, and then you end up having radiotherapy, which is akin to roasting the body. And all this incurs enormous cost to the exchequer of the country, especially if you add expensive drugs like trastuzumab. And what happens at the end, about 60-70% will succumb to the disease in spite of all this poisoning, chopping, and roasting. So we must start a screening program, and we are fortunate that in India now a multi-disease screening program has been commenced. Why multi-disease? Because it is more cost-effective and sensible to approach a person and then have a full checkup. And this multi-disease screening in India has started with 5 diseases: diabetes, hypertension, cancer of the mouth, breast, and cervix. So it is more cost-effective. You approach a person, you examine her mouth, you examine the breast, and examine the cervix, and check the blood sugar and check the blood pressure. Any disease you find, you treat it appropriately. So the methods for breast cancer screening are mentioned on this slide, starting with breast examination, clinical mammography, and recently automated ultrasound imaging has also been armamentarium. Examination in the West has been condemned as a method of screening, but it is a very good tool to educate women about their breast health, and it increases their awareness about breast health, and they are told to notice any change in the nipple, any lump or ulcer, and report to the clinician early. So it is a measure of increasing the awareness. It does not reduce the mortality, but certainly it increases the awareness of a lady about her personal breast health. Clinical breast examination, it is used by different methods, and some research has revealed that dial of a clock method is the most sensitive search pattern out of the 4 search patterns that we commonly use, and different finger movements can also be used. So the technique of finger movements can be a rubbing circular motion using pad of 3 fingers as shown in that video, or vertical movement, or as if you're playing a piano. And the dial of a clock method is shown on this slide. You consider the breast as depicting dial of a circular clock, with 12 o'clock being at the mid-clavicular point here, 6 o'clock at the inframammary crease, 3 o'clock on the para-sternal edge on the right breast, and 9 o'clock in the mid-external line. For the left breast, 12 and 6 will be the same, but 3 o'clock will be in the para-sternal edge near the midline, and 9 o'clock here and 3 o'clock on this side. And a study at All India Institute of Medical Sciences comparing these 4 such patterns has revealed that dial of a clock method has the highest sensitivity, and especially when it was done by a female nurse. So she picked up 82% of the lesions correctly using dial of a clock method. A professor was second, and that is myself, and a trained resident had only 64% sensitivity. So out of all the 4 methods, vertical, strip, quadrant, and concentric, dial of a clock has the highest sensitivity. And these other parameters are revealed here, but dial of a clock method has the highest sensitivity, positive predictive value, and diagnostic accuracy. So we recommend dial of a clock method. Now we come to some methods of and data suggesting that use of clinical breast examination can actually help in screening for breast cancer. This is the information from Trivandrum Breast Cancer Screening Program conducted by the World Authority in screening, Dr. Shankar Narayanan. Dr. Shankar Narayanan is the most experienced screening person in the world. He was the chief of a screening program at IARC in Lyon in France, and he conducted large randomized trials, population-based studies. One such a study is depicted on this slide, and he showed that compared to the control arm, you pick up breast cancer at an earlier age, at an earlier stage. And another study to be quoted is conducted in Mumbai, and this was done by Dr. Gadgil and Dr. Shankar Narayanan group. And the third study, which is very significant, published last month, February 21 issue of British Medical Journal by Dr. Indranil Mitra and Professor Badwe group from Tata Memorial. And this cluster randomized trial initiated about 20 years ago by Dr. Mitra. It is a very large study funded by NIH of America. And they took a control group, a large group, 76,000 women compared to 75,000, where they performed clinical breast examination by a trained health worker. And they found that detection of early stage was much higher, 62% as opposed to 43%. Number of advanced stage presentation, stage 3 and above, were minimized. And number of women needing chemotherapy and advanced treatment was also reduced. So this is the data presented in the British Medical Journal last month, February issue, and with Dr. Mitra as the chief author here. They took 151,000 women and randomly allocated to two cohorts, 75,000 randomized for screening, and another was 76,000 in the control arm. And they showed that although overall survival was slightly better in the screen group compared to the control group, but overall there was no statistically significant difference. However, if you do a subgroup analysis for women below 50 and women above 50, in the above 50 age group, there was 30%, yes, 30% reduction in mortality by just clinical breast examination with a 20-year follow-up. And this is remarkable result for Asia, Africa, and other low and middle income countries. Clinical breast examination holds a great value and in reducing the mortality of breast cancer. Very affordable, low-cost technology. Why we do not want mammography in our country? Because there are many hazards of mammographic screening. And the biggest hazard is that of overdiagnosis. You will find editorials in New England Journal of Medicine saying, abolish mammographic screening. And the major problem is overdiagnosis. Overdiagnosis is defined as a histologically established diagnosis of invasive or intrarectal cancer that would have never developed, never surfaced into the clinical manifested tumor during the lifespan of a lady. So she would have lived happily for age 80 and then died, slipped in the bathroom, fractured her leg, and then died of pulmonary embolism, etc. Old age related disease. But if you do her autopsy, you will find a small tumor. So what? So these tumors are called overdiagnosis. If you launch mammography screening, you pick these lesions and then you are obliged to treat them. And then there is certain cost and some mortality associated with treatment. So some data suggests that as much as 30% overdiagnosis is happening based on mammographic screening. So we have chosen not to use mammography in our country. Tertiary prevention is actually not prevention of the cancer. It is usually for management of advanced disease to reducing the disability and rehabilitation. It's a palliative care, tender loving care, TLC. So I'll conclude. Breast cancer can be reduced or prevented by regular physical activity, exercise 40 minutes per day or 4 hours per week has been shown to reduce the incidence of breast cancer, reduce body weight, keep it under control, avoid alcohol, avoid red meat, especially animal meat and saturated fat, and surveillance for high-risk women who have strong family history or known to have a genetic mutation. things that we can change are the body weight, the diet, we can regulate, the physical activities we can regulate. And there is some doubt whether nulliparity is a risk factor or multiparity in different races. Say like in Caucasian, in large American studies, nulliparity is a risk factor. But if you take the Afro-American women living in America, their multiparity was found to be a risk factor. So it varies in different states. We sometimes see a lady as having 10 or 11 children, all breastfed for 2 years each. So for 14 years, the poor lady was feeding 10 children and still got breast cancer. So perhaps multiparity may be a risk factor in our community. And things, of course, we cannot change these. And some time ago, ICMR and National Institute of Cancer Prevention conducted a large brainstorming session with some world experts of screening, like Dr. Shankar Narayan here, chief of NCI America, and all the experts from India, and a Lancet article was published. And based on all these guidelines, the Ministry of Health launched on 16th May 2017 a multi-disease screening of oral, breast, and cervix, and it was launched by the Honorable Minister of Health. And this is the framework. The ASHA worker, the accredited social health activist, they visit door to door and invite women aged 30 and above to come to a health center where they have a checkup for mouth, breast, and cervix. They have their blood sugar taken and blood pressure taken. So the age is 30 to 65 for all three cancers. This keeps it simple because our ASHA worker and ANM, they are just high school pass. They do not have high IQ. And if you tell that start breast at 50 and cervix at 35 and oral at 30, they will get utterly confused and they will not do anything. So we have chosen 30. And another reason for 30 as the cutoff is that Dr. Shankar Narayan's data suggested that 1/3 of all breast cancers, 1/3, occur between 30 to 50. So if you start at 50 in India, you will miss 1/3 of cancers, so which is a large proportion. So we did not want to miss the 1/3 of all cancers in our country. Hence, we started at age 30 based on clinical breast examination, affordable technique, and now we have the data showing reduction in mortality. And so this is the framework. A lady is seen by a trained health worker. It need not be a doctor, just trained auxiliary nurse midwife. If she has some abnormality on the clinical breast examination, she goes to the surgeon and then further algorithm goes on. If there is clinical breast examination is normal, she is advised to continue a monthly breast self-examination according to the film that we just saw. And this film has now been translated into almost all languages: Tamil, Telugu, Malayali, Bengali, Assamese, Gujarati, Marathi, and it is being used across the country for enhancing awareness about breast health. And this is from last year's data before the COVID lockdown. And the current data is that more than 10 crore population has already been studied. And so this is a screening. And I urge all of you to visit this website, India Against Cancer. This is very informative website we have developed in collaboration with National Institute of Cancer Prevention and Research and ICPR, which is an ICMR institute. And please also visit our National Cancer Institute in the AIMS Jhajjar campus. And in conclusion, screening in Asia is effective in early detection and saving lives by clinical breast examination by a trained female nurse, and teach ladies to perform breast self-examination in order to increase their awareness about breast health. Thank you very much. Thank you, Dr. Atia and the whole team. I'm not showing the film on clinical breast examination, but we have developed training modules for doctors and nurses how to conduct clinical breast examination. See, clinical breast examination has been just blamed that it does not improve the mortality because in the West, medicine is very much driven by market forces. So the big companies and the radiologists do not allow clinicians to carry out clinical breast examination based screening because their mammographic machines will not sell. And no private company would like to support clinical breast examination because it doesn't fetch any revenue. So this is the reason it has never picked up and has never been tested through the rigor of science. Dr. Mitra and Dr. Badwe have tested that, and they have found 30% reduction in mortality, which is a significant achievement. Thank you.
Thank you, sir. And Professor Kumkum, do you want to have any comment?
Yeah, thank you, Dr. Anurag. A very nice talk, very interesting and very informative for all the pages. I just wanted to know that there are handheld ultrasound machines also nowadays which are available and which are now being supplied by the government of India to various states where like ASHA workers are trained. Also, second point that Dr. Raghuram has made an WhatsApp device in 15 languages where people are trained to how to do the self-breast examination and clinical examination for early diagnosis.
Yes, yes. Dr. Raghuram actually started the Association for Breast Surgeons of India under the Asian Indian Surgical Society, and we are really congratulate him for this effort. He's doing a commendable work in the state of Hyderabad. Thank you. Thank you.
What about what is your view about digital mammography as a screening tool? Because in the West it is very common and compulsory.
I told the problem of overdiagnosis. Number two, problem of availability of the machines. Then problem of the people to read the mammogram. If you detect some cluster of microcalcification, no lump, who will read that? Who will do stereotactic vacuum assisted biopsy? So these are the problems. Certainly, if you have a high-risk lady and she has a family history, then go for it. But not on a population-based, government-supported screening program.
It is more popular in the literate population in the metro cities where people are more aware of the breast disease when the family history is there. People are now started getting routinely mammography done. I have seen many patients come with a family history. They're coming for regular checkups. I think awareness has increased now for this.
May I add one thing, ma'am? Good to have you here, and thank you for postponing your travel plan. Please do not travel at least for a month's time until COVID goes off. I was really concerned and worried when you told me you are planning an inter-city travel. I was really scared. We wish to have you. Your life is very precious. So that is one most important thing that I wish to reiterate and re-highlight. The other thing is that, as a matter of fact, majority of patients, as Anurag sir has already said, belong to the age group of 30 to 50 years. And so these women who are young have dense breast. And mammography is not a good tool for diagnosing lesions in dense breast. So,
No. My contention was those with a family history of breast cancer, ladies are more aware and they come early for doing a digital mammography as compared to a layperson. That was my question. Yeah.
That is the reason why, ma'am. I'm saying that if you go in for a digital mammography, a dense breast in a young lady, see, high-risk individuals tend to have it at a younger age. So these individuals who are young have denser breasts, and so because the breasts are dense, so the lesions might be missed out on digital mammography, but are picked up better on ultrasound. So a high-frequency ultrasound having a range of at least 7.5 megahertz, preferably around 11 to 12, 14 megahertz would be ideal.
I agree with you totally. I agree with you.
I think because of paucity of time, we cannot take any further questions. Let us proceed to the next talk. Over to you, Dr. Afaf.
Yeah, Dr. Aditya Sarkar, and he's a professor and chief of breast surgery and research unit at IGMR SSKM Hospital, Kolkata. And his next talk will be recent advances in the management of axilla. So over to you, Dr. Aditya Sarkar.
Thank you very much. And at the outset, I'd like to thank Professor Atia and the whole team of AMU for organizing such a relevant and wonderful CME in the times when the COVID virus is raging the population. I hope it is beneficial to all the postgraduate trainees and for all of us. And if I'm allowed to share my screen, well, I hope I am audible and visible as well. Is it?
Yes, sir. Audible and visible. Your slides are also
Thank you. Thank you very much. Now, the story of breast surgery over the last 132 years since the successful by William Halsted had been like this poster, the good, bad, and the ugly. And what has happened? So the paradigm shifts that have taken place in the axilla in terms of the ugly period was the Halstedian concept of a radical axillary dissection. People did supraradical dissections where they took out something from the supraclavicular fossa, whereas people took out things from the internal mammary chain, and which they call extended radical mastectomy. Then came the Fisherian concept of the disease being a systemic disease, and suddenly conservatism in the axilla was around the corner, and people shifted to level 1, level 2 dissections, and there were people who were more conservative who would do just a lower node sampling. Till the turn of the millennium, when the good arrived and the spectrum theory at the same time, which states that the cancer is likely to be a loco-regional disease at least up to 1 to 2 centimeters in some group of people, and after that it will have its systemic phase. And therefore, following a blanket policy of doing axillary surgery in every individual that is diagnosed as a breast cancer would definitely mean that 35 to 50% of them will have the morbidity of lymphedema without any purpose. And therefore, in the next 20 to 25 minutes, what I'm going to try to convince you people is that there have been a changing spectrum of axillary surgery, which is far more interesting than what is happening in the field of breast surgery. The first barrier to us, if we look in terms of axillary lymph node dissection, reduction in lymphedema, is sentinel lymph node biopsy feasible in locally advanced breast cancer and node positive disease? That is possibly the burning question that comes to all of us who are sitting in this CME or those who practice breast surgery throughout India. Now, before we go to the main talk, I mean, if we have trainees, they must understand the surgical pathology of how metastasis take place and how it looks like when you do an axillary ultrasound. Now, what happens is that the metastasis enters into the axillary cortex through the small little afferent channels. And then what happens is that after there are multiple entry of cancer cells through the afferent channels, there is a cortical thickening. So in radiology, the first feature that comes is cortical thickening. After that, the cancer cancer cells goes into the medulla and then comes to the hilum, and therefore there is effacement of the hilum. And once the effacement of the hilum takes place, it leads to the change in shape from a reniform to a globular shape. And that is exactly what happens. So as a surgeon, it is very, very important that all of us know these phases so that we understand, looking at an ultrasound plate, what should be your plan of surgery right at the beginning. And this is a classical example of how a normal flattened node with the mented hilum would look like. And this is a classical example of how a metastatic node would look like in ultrasound. So if we look at flatly that if patients have been given neoadjuvant chemotherapy and if we try to do a sentinel lymph node biopsy, these are the major trials, and the standard that was set was the identification rate more than 90% and the FNR less than 10%. You'll understand that none of these studies, except a study from Safdarjung Hospital, the meta-analysis quite clearly states that none of them would pass the bar, the quality assured bar that has been set. And therefore, the consensus statement that I would like to make at the end of 2020 is data is not very robust in favor of sentinel lymph node biopsy post-neoadjuvant systemic therapy. Most of the study is extremely heterogeneous. Maybe it is suitable in T3N0 tumor, but in subset of patients where it is T4B, it is unlikely to have any impact in terms of reducing the chances of axillary lymph node dissection. But the paradigm shift started just before the pandemic. And now we are into a phase where this paradigm shift has actually taken place. And I'm going to show you the trials that have come into this field. Now, the new concept is if you have a metastatic node in the axilla, just like the breast, you put in a marker, then put the patient on neoadjuvant systemic therapy. And after the neoadjuvant systemic therapy is done with, you are going to go for a localization of the marker and combine it with a sentinel lymph node biopsy and check out the nodes which are involved. And the new nomenclature is targeted axillary dissection. Now, this is how it is done. This is one of the techniques. Now, what is being done here is somebody is taking an iodine seed and putting in an iodine seed as a marker in the center of the metastatic node. Now, this is the center of the metastatic node where exactly the marker has been placed. Now, after you have placed the marker and you have given the patient neoadjuvant systemic therapy, the node has apparently disappears. Now the patient comes back to you. Now, what you are going to do at this time, you are going to take two tracers. One is you try to locate, as you see here, which is known as the Murray node, that the iodine seed is being localized with a handheld probe. The other one is the standard sentinel lymph node probe. So what you are trying to localize is both the sentinel node as well as the node which have been treated by neoadjuvant systemic therapy after a marker has been placed. So there are enough evidence to suggest that it crosses the bar that we have said, the sensitivity and specificity both are above 90% and the false negative percent is 7%. So both of them, it qualifies that this technique is the standard of care that is going to come in next decade. Now, this is one of the study that was recently presented in by one of our very good friend, Dr. Amit Goel from Derby Hospital, and he was able to prove that carbon tattooing of the cortex of the node before you start the chemotherapy is a wonderful tool, and you can, after the neoadjuvant therapy has been given, reopen the axilla and locate the carbon tattooed node and take it out. I thought it was very interesting because in Indian perspective, where iodine seed may not be available very freely, one would choose to have a carbon text. This is another interesting study that is going on. It is a conglomeration of multiple studies, which is known as the Axena study. What they are trying to do is trying to put under a basket, under a scanner of the different techniques. Similarly, the trial like the ACNIC trial also is trying to come up with whatever is best for these patients who have got a metastatic node and where a marker is being placed. As of now, these are the standard markers which have been validated. You can put in a clip at the center or at the surface of the lymph node. You can place in an iodine seed, which is the most commonly followed method. And while I was visiting the Mayo Clinic just before the pandemic, this was the technique which is used by the Mayo group of people, and our good friend from Derby, Mr. Amit Goel, has started this technique of carbon tattooing. What happens after neoadjuvant systemic therapy is that there's a 5% discordance. That means in 95% of the cases, both the sentinel node and the mark node are the same. So makes your life very easy. But in 5% of the cases, they may be different. And if it is different, you need to take out both the group of nodes. And therefore, this has been nomenclatured as the targeted axillary dissection. So it's a dual target way of localizing the metastatic node, and to be very sure that you are not leaving behind anything. It is definitely above berry picking and is going to be the standard of care very soon throughout the world. The second important barrier which I thought we discussed today is, should patients with 1 or 2 positive sentinel nodes undergo axillary lymph node biopsy? Now the verdict came from the Z11 trial, which sports that among patients with T1, T2 invasive primary cancer, no palpable axillary lymphadenopathy, and with 1 or 2 lymph nodes containing metastasis, the 10 years overall survival for patients treated with SLND alone was non-inferior to the overall survival with those being treated by ALND. Now, all of you must understand this statement. This is a non-inferiority trial which proves that axillary lymph node dissection may not be required in all those patients with 1 or 2 sentinel lymph node biopsy. Now, before we go, I'm extremely apologetic to all the ladies who are sitting here, but I thought this is the most, way to present how statistics is. Statistics are like bikinis. What they reveal is suggestive, but what they conceal is far more vital. And let us go through the statistics of this trial. Now, if we take a reality check 1, what was the meaning of mean tumor size in this RCT? The mean tumor size was 2.5 centimeter. Now, if we look at that, the fact check in India is T1 tumor is less than 10%. So that means almost 90% of the patients, if we follow the trial data, will not categorize to be included in clinical practice. Number 2, the reality check 2 is what is the age distribution in the trial. So 64% of the patients were above the age of 50 years in the trial. Now, we just heard from Dr. Anurag's presentation that majority of the patients in India will be less than 50 years. In fact, Dr. Deo's series would quote it is around 46.1 is the mean age. And therefore, again, extrapolating the data blanketly will not be very appropriate. The reality check 3 states is that the molecular subtype that was predominant in this particular study was ER positive in 77% of cases. Whereas in India, most of the studies would quote that 35 to 50% will be triple negative breast cancer. And therefore, when you are dealing with more aggressive cancer, you have to be careful in implementing that. The reality check 4 states that what is the pattern of nodal involvement. Now look here, look very carefully that 40% in the study group were micrometastasis or isolated cancer cells. That's a huge number and it's almost unavailable in Indian subcontinent patients. So if we look at that and plus that 240 of the patients had only 1 positive lymph node, looking at the trial's conclusion and implementing in India, again, would be a foolish texture. Coming to the reality check 5, what was the treatment offered? Now, this is the most important thing for all of you to understand, that Z11 includes only breast conservation surgery, does not include mastectomy. So if you are doing a breast conservation surgery, you are going to give a radiation in a tangential field, and therefore you are going to irradiate the lower group of nodes in the axilla, whether you choose to or you don't choose to. So therefore, it may not be applicable in mastectomies where you are not giving radiation in many of these patients. Now the final one is, what does the trial exclude? Again, just to make it brief, it excludes all patients undergoing mastectomy. So therefore, it is not applicable in patients undergoing mastectomy. So you must understand that though this one is baseball and this one is cricket, but they are quite different when you are on the field or in the gallery. So it's a different ball game altogether, and we need to choose things far more wisely, not treating the recent advances only. the final reality check was the particular trial concern adequately powered in terms of the sample size. Let's go back to the NSABP B04 trial, which told that axillary dissection should be out. Now, when this trial was reopened, it was initially on 1180 patients. When it was reopened, we found that to get a statistical significance, it should have been 20,000. So again, it's ineffective or inappropriate to extrapolate the data of NSABP B04 trial blanketly in Indian patients. Now let us look at the AMAROS trial. Once again, look at this. The adverse event that was actually studied in the AMAROS trial was the incidence of axillary recurrence. Now 681 is the sample size of patients who have undergone a sentinel lymph node biopsy. Of them, 11 had metastasis, recurrence, whereas 7 out of 744. The sample size is calculated, should not be calculated on the sample size 681 or 744. It should be based on 7 and 11. And so therefore, if you actually want to derive any conclusive statement, it has to be a wider group of sample size, at least 20,000, to come to an effective conclusion. So what I would not agree on Z11 is why the group of trialists suddenly terminated it at 891 instead of their pre-specified 1900 sample size, which they thought they would undertake. So we are actually, and I personally is very worried, are we trying to fast forward our vaccine trials and the drug research like the ones that is happening during the pandemic? Of course, we can debate it out, but we need to take things more wisely. Now, this particular trial, which is likely to end by 2023, again run by Mr. Amit Goel from Derby Hospital, which is known as the POSNOC trial. And this POSNOC trial, look carefully, it is not choosing patients in a blanket policy. It has got a stratification of age less than 50, more than 50, BCS, mastectomy, year status, number of positive nodes, and in the UK they would choose OSNA, whether OSNA has been chosen or not. And this would actually address on a larger platform what is more appropriate. Till then, the consensus that I would like to make for trainees without any creating confusion is if the sentinel lymph node is 0, I mean not metastatic, then no. If there's micrometastasis, you can get away without axillary dissection if you are doing a breast conservation surgery. If it is a micrometastasis in a single node, it's a good biological subtype. Again, you can do no axillary dissection. For rest of the patients, axillary node dissection becomes the standard of care. So therefore, the statement that I would like to make is that axillary lymph node dissection still in India remains the most commonly practiced axillary surgery. And the fact is that 35% of the patient on an average will develop lymphedema if these surgeries continue. So the question means, does it mean the end of the world? Does this mean the ugly is putting the good at the gunpoint? Now, what next from axillary lymph node dissection is axillary reverse mapping. It has revisited the context of breast surgery. Now, what we have been doing in the last almost couple of years now is a trial on axillary reverse mapping. And we found, and it is quite in line with most of the studies, that there is only 3 to 8% crossover. That means the likely possibility of going to the arm lymphatics or the arm lymphatics to drain into the axillary node is only 3 to 8%. So therefore, it's a valid one. So the future ARM trials that we are addressing now is trying to address the variation in anatomy. We have already got around 25 such patients. They want one published data, and that data is matching with ours, which states that in almost around 80% of the patients, the arm lymphatics is situated in the upper outermost part of the axilla, which is situated upper and outer to the thoracodorsal pedicle. And even if you are doing a blanket axillary dissection, if you keep that area untouched, the chances of axillary lymph node dissection is likely to reduce. And we are going to publish this possibly in 2022 when our trials are over. In the meantime, these are things that we are doing. In spite of that, there will be a group of patients where, having said everything, an axillary lymph node dissection is required. And for them, what we would try to put forward in front of this august audience is something called a primary lymphovenous anastomosis after axillary lymph node dissection. And this is how it is done. Now, while you are doing an axillary lymph node dissection, most of you would encounter the axillary vein going like that. And again, if you recollect, you will find the descending vein which comes down, which we tie regularly while we are doing an axillary lymph node dissection. The special character of this descending vein is that it has got almost a 6 to 8 centimeter extramuscular course. And so therefore, you understand that is an ideal vein where you have a long segment of vein freely available for an anastomosis. Another important character of this node is that it has got a valve which is situated at the point where it drains into the axillary vein. So what it does is it doesn't allow the axillary venous blood to come inside this vein. And therefore, if you put in a lymphatics and put in inside, it is not going to be suppressed by the huge pressure of blood coming from the axillary vein. And so, if you are able to identify the arm lymphatics, and then you can dunk it inside the axillary vein, in this descending branch of the axillary vein, which is a very low pressure system, the lymphatics is likely to drain directly into the axillary vein, reducing the chances of lymphedema of the arm. Now, this is exactly where we would put in this is an ICD guided procedure. We are injecting the dye, and after dye is being injected, what we do after that is we use the ICG camera, which is a spy. There is a mode called a spy mode, and in the spy mode, before we insert that, look, we are dissecting the descending branch, which is the extramuscular long vein, which is almost 8 centimeters. Look carefully, it doesn't back bleed. If this vein back bleeds, it means that the valve is incompetent and this vein is unsuitable for lymphovenous anastomosis. But if you are sure there is no back bleed, we go to the next step. Now, this is how, in a static view, you would identify the arm lymphatics draining in the spy mode. And in the other mode, you can also see how it looks like. But the spy mode is the most, it's a wonderful mode. It's a total dynamic way of visualizing the arm lymphatics. And what we do after that is, now we are dissecting it under vision. And this is the arm lymphatics which has been identified, and the arm lymphatics is being, sorry for the sound. The arm lymphatics is being slowly identified under vision, and I usually do it with a loop only, though of course it can be done with a microscope. But the place where I saw it and tried to reciprocate or replicate in my theater was from the Mayo Clinic. But with the Mayo Clinic, the standard practice is done by is under a loop. So this is the lymphatics which has been dissected out. Now, once the lymphatics has been dissected out, now look carefully, we have put in the vein flon into the vein, and the lymphatics is just parallel to it. Now, once we have put both of them side by side, we would begin the anastomosis. Again, as you see, it is being done with a 9O proline. We would take at least 3 to 4 bites into the lymphatics and dunk in the lymphatics into what is known as the descending branch of the axillary vein, which is likely to have a competent valve at its junction with the axillary vein. I'm not going into the details of it, and this is the next part. You see how the anastomosis proceeds. It's quite tedious, and particularly for us who do not have a formal training of microvascular surgery. But I can assure you, if most of you start this technique, this is going to do wonders. And I must at the same time announce that our work has been accepted. I was supposed to deliver this presentation in ABS on 17th of May, but because of the pandemic, it would be on a digital mode that it will be presented. Now, this is the completed anastomosis of the lymphatics with the descending branch of the vein. And this is how it looked like in ICG after in a SPY mode or a chrome mode after you have completed the anastomosis. This is on a macroscopic view that you look like how it looks like. And this is the end point of a prophylactic primary lymphovenous anastomosis. So the keywords is identification of arm lymphatics using methylene or ICG is a feasible option. It requires microsurgical skills. It requires you can try. We are trying either end-to-end versus end-to-side dunking. I'm sure end-to-side dunking is going to be a better option, and we are awaiting the true results of the reduction of disability arm, shoulder, and hand if it occurs. And we need to wait for at least 3 years from now to see whether there is a reduction or not. And we are waiting for this validation to come. And this study was originally, it's not our work, it's originally started in Italy. It was published, it's called the LYMPHA, that is the lymphatic microsurgical preventing healing approach. And the authors have definitely validated that it reduces the incidence of lymphedema. And I thought, as the West have moved strongly into sentinel lymph node biopsy, and as in countries, on all the developing countries, I saw Professor Minazur Rahman here from Bangladesh. So for us, for Bangladesh, for all the Southeastern countries, this is a very acceptable technique to go ahead and reducing lymphedema. So in 2019, before we went into the pandemic, we were left with an option of either an axillary lymph node dissection or a sentinel lymph node dissection. And by the time we have been calibrated and recalibrated by this pandemic in 2020-22, those of us who survive would see that there will be multiple options like sentinel lymph node biopsy using either a blue dye or 4-node, as has been started by the Tata Memorial Group, the ICG or the dual technique. We will have targeted axillary dissection after neoadjuvant systemic therapy. We are going to have axillary lymphatic dissection with primary lymphovenous anastomosis. And if some of these patients comes back with an arm lymphedema, we might go for a secondary lymphovenous anastomosis in the limbs. And therefore, we are looking at a lymphedema-free world by the turn of this decade. We are looking at something, and I don't know whether we will be able to be successful or not. And we are doing this study on axillary nodal mapping, and we are looking at creating a virtual surgery so that we will be able to understand which one is metastatic and which one is not. And that's where the world is going towards. And I'm sure at the end of this decade, the ugly lymphedema is going to go away in favor of the good. Thank you very much.
Thank you, Dr. Jitendra. And I would like to ask the chairpersons, Professor Kumkum Singh, Professor Seema, would you like to have any query on this talk?
Dr. Piyush is also there with us. He's a...
Piyush has joined. Dr. Piyush, have you joined?
There with us. One thing I'd like to tell you, sir, Dipten sir, your talk was excellent, and courtesy you and Dr. Mizanur Rahman, who's currently logged in. Lots of people from Bangladesh have joined, Nepal have joined, Bhutan have joined, even people from Pakistan have joined, from UAE, they have joined, from US and UK, they have joined. So it is a pan-India talk going on Zoom platform as well as WebNext. And we have 123 honorable faculty members who have joined and endeavor together. The faculty belong from range from Gujarat to Northeast, that is Meghalaya. We have honorable faculty members from J&K and Tamil Nadu as well. So across the length and breadth of our great nation, we have got wonderful teachers who have joined us, helped us out in our academic endeavor. And thank you, Dipten sir. You have been a wonderful person who has always guided us and helped us along. Thank you so much, sir. And to talk about lymphedema, it is a horrible thing. We all know it's really a very sensitive issue. In fact, at times it puts tears in our eyes to see our patients like this. Because many a times they come with LABCs, and in LABCs, if you do an MRM, then of course lymphedema is most likely to occur unless and until you go in for a bypass. And the facilities of bypass are not everywhere. At least I am not doing that at the moment. I'll be doing it shortly. Hopefully, you're going to get a microscope soon.
I can see Professor Kumkum Singh, who happens to be, I will always call her my Guru Ma, and so I am looking forward to her comments, please.
Okay. No, Dr. Ditendra, you have given an excellent presentation as usual, and also you have addressed the axilla very well. And for the postgraduates, you have addressed the newer topics, which students normally do not read. The Z11 trial, the MROS trial, these, which are the new things, reverse mapping. This will help them in their PG exam to know what is new and how to address the axilla now. Especially in the days to come, this has been addressed very well. And I think you've covered everything very nicely, I think. But the only thing is facilities are not available in most of the places in India, except for very few dedicated breast centers where we get all these techniques to do. But at least the knowledge of these topics helps us a lot. And I think you've covered it very well. Thank you, Diptendra.
Thank you. Thank you very much.
So our next speaker is Professor Gaurav Agarwal. He is here. I can see him. And he is Professor of Breast and Endocrine Surgery, SGPGI, Lucknow. And so you have your talk. Start your talk.
Thank you very much. Am I audible?
Yes, yes.
Firstly, let me begin by thanking Professor Athiya. It's such a pleasure to be back to the AMU Surgery update, even though this is only a virtual one. I so fondly remember the last year when I traveled from Lucknow to Aligarh, and it was such a nice experience for me. So the job given to me today is to discuss about the controversies and challenges in management of locally advanced breast cancer. Is my presentation visible?
Yeah, it is visible.
Excellent. So locally advanced cancers are the kind of cancers that we all have to tackle in India and in most other developing countries. So it is something that is crucial for us to discuss. There are a number of challenges and controversies which mar the management of locally advanced cancer, and I'll try to address at least some of them. I think that the controversies and challenges can be discussed only when we are clear about what is the third C, which is the consensus, or what is the agreement about how we manage a particular condition, and in this case, how we manage the locally advanced cancers. So there are a number of challenges and controversies relating locally advanced cancers. Some of them have been resolved in recent years. Some others continue to rage. Some others continue to trouble us. There are new controversies and challenges which keep arising with every new bit of information and understanding of disease process, as was highlighted even by my friend Dr. Deeptendra Sarkar in the previous talk, that more we do, more we understand an issue, a new controversy crops up. So there are, as I said, number of controversies and challenges. I would try to focus on a few of them and relating locally advanced cancers. These would range from definition of locally advanced cancers, what are operable locally advanced cancers, where do we position large operable cancers in context of locally advanced, what kind of investigative or evaluative workup is required in patients with locally advanced cancers, what treatment protocols are appropriate, the use of neoadjuvant systemic treatment, what extent of this should be treated with, should be used, where should be the surgery fit in, where should surgery fit in this context of neoadjuvant systemic treatment, what is the extent of surgery and timing of surgery, what kind of adjuvant treatment is required, and then something about the outcomes. So to define locally advanced cancers, these are primarily stage 3rd cancers in the TNM staging of breast cancers, which include patients who have skin invasion or chest wall invasion or both, or those who have inflammatory breast cancer. Besides, patients who have fixed axillary nodes or supraclavicular nodes, and also patients who have large operable cancers with nodal metastasis. These are all patients who belong to the stage 3rd cancers, and so they are called locally advanced. If we also include some relatively smaller cancers such as T3N0 and T2N1, but which are high-grade triple negative, these have somewhat similar outcomes to patients with stage 3 cancers, and also because these are patients where treatment options are or treatment strategies are similar to patients with locally advanced cancers. These are by definition cancers where there's no systemic metastasis, and we can expect about half of them to be surviving at 5 years. In the Western world, locally advanced cancers are not so common. They're not such a big issue, but in our own country and in so many other countries, up to 50% of all breast cancers treated belong to stage 3rd cancer or those who have locally advanced cancer, even though the proportion of these cancers has been coming down drastically over the years. And this is just a gist of the data from our own experience at SGPGI in Lucknow, where in the first decades between 1989 and 99, a good 50% of all our patients belong to locally advanced group. Over the next 2 decades, we have seen progressive diminution of this proportion to 45%, and in recent years, close to 35%. Locally advanced cancers by themselves represent a huge spectrum. They can be relatively small and not so bad to treat cancers, which are perhaps the good locally advanced cancers. Then there are bad locally advanced cancers, which involve almost the whole breast with extensive skin involvement. But then these are still better compared to the ugly ones, as you can see on the right-hand side of the screen, an ulcerated fungating mass, which again, and yet it is not metastasized systemically. So this too is a locally advanced cancer, perhaps the worst of the 3. How do we evaluate locally advanced cancers? A patient presenting with this kind of clinical picture must have a complete clinical examination followed by imaging. And this would almost always be performed in form of a mammogram and ultrasound. We can use selectively MRI, and the third and perhaps the most crucial step of triple assessment in form of histological evaluation by a core biopsy. Mammography is the preferred imaging modality. However, in patients who have bulky and especially ulcerated disease, it may not be easy to perform, but with some bit of commitment and application, it can perhaps be done. And in patients who are young with dense breast, perhaps this may not be an optimal imaging, and an ultrasound and in certain cases MRI may be of great help. Core biopsy or core needle biopsy is an essential step in evaluation of locally advanced cancers, because we want to have the histological confirmation, not just cytological, before instituting any kind of treatment. And not just the histology, but we also would like to know the tumor biology. And the crucial few things that we would like to know is the ER and PR status and the HER2 status, and what kind of Ki67, especially in patients who are triple negative, we would like to know the Ki67 index too. And all this should be done before institution of neoadjuvant systemic treatment. Patients who have locally advanced cancer, they have a relatively higher probability of having asymptomatic systemic metastasis. And this is very different to early stage cancers where as a routine, we do not indulge in metastatic workup. But in these stage 3 cancers, we do either a whole body PET CT or else a combination of imaging in form of MDP bone scan with abdominal and thoracic CT or ultrasonography of the abdomen and CT of the thorax. This issue of use of whole body PET CT continues to be in debate. There are a number of recent studies which have shown perhaps it is cost effective to do a one single whole body PET CT rather than doing a number of imaging investigations for metastatic workup. However, this should be left to the individual centers to decide based on the logistics and the cost involved in various things. Now, in terms of the consensus of how to treat locally advanced cancers, one thing which cannot be doubted is the need for a specific protocol based on which one should address the management of locally advanced cancers. At LCPGI and perhaps in majority of the centers, beyond the physical examination of the patient, a core biopsy and imaging is done and the metastatic workup is performed, followed by institution of neoadjuvant systemic treatment. Almost all patients with stage 3 cancers today are treated with neoadjuvant systemic therapy, mostly in form of chemotherapy, which is a combination of anthracycline and taxanes. In patients who have locally advanced HER2 positive cancers, neoadjuvant trastuzumab, and if logistics allow, neoadjuvant pertuzumab too is of great value. In patients who respond to this neoadjuvant systemic treatment, who have good partial or complete response, they can be offered breast conservation or mastectomy, followed by radiation therapy and rest of the adjuvant treatment. In patients who do not respond sufficiently, alternative systemic therapy should be resorted to, and if they remain unresponsive or have progression of disease, they may require palliative mastectomy. Following this kind of treatment, selected patients may require further adjuvant systemic treatment in form of hormone therapy in all patients who have hormone receptor positive disease. Patients who are premenopausal perhaps are best treated with tamoxifen with ovarian ablation, and we prefer oophorectomy or salpingo-oophorectomy, which we do laparoscopically over Goserelin because of the cost efficacy. Patients who are HER2 positive, they should be treated further with adjuvant trastuzumab to complete one whole year of treatment, but up to 3 months is also acceptable. And patients who have triple negative cancers and have residual disease following completion of neoadjuvant chemotherapy, they would benefit from capecitabine and adjuvant treatment as setting. So looking more about the challenges and the controversies of neoadjuvant systemic therapy, this is indeed a strategy which has emerged as a standard of care for locally advanced cancer, because with neoadjuvant systemic therapy, we can achieve rapid control of the disease, and it has the potential of making inoperable locally advanced cancers operable and improve the eligibility of breast conservation in a certain proportion of patients. Neoadjuvant systemic therapy also provides an opportunity for in vivo assessment of the tumor chemosensitivity. The overall survival following neoadjuvant systemic therapy vis-a-vis adjuvant systemic therapy is perhaps equivalent, though there are some relatively small questionable studies which report that perhaps there is a somewhat improved survival in patients who have received neoadjuvant systemic treatment compared to those who have received adjuvant treatment following mastectomy or conservation. There is a certain subset of patients who achieve pathological complete response with neoadjuvant systemic treatment, and these are patients who certainly have better overall survival compared to patients who do not achieve PCR. The neoadjuvant systemic treatment should be decided based on the tumor biology besides the tumor stage or the tumor size and the nodal stage, and also based on the desire of the patient to have conservation of the breast. That is to say that in patients who have an operable disease, if the operability is judged in terms of mastectomy, they perhaps could not achieve much by neoadjuvant treatment if they do not desire to have conservation. Neoadjuvant systemic treatment is more applicable to certain subtypes or biological subtypes, that is triple negative and HER2 enriched types, because these are patients where we expect them to respond better to neoadjuvant treatment. This can be in form of neoadjuvant chemotherapy or neoadjuvant anti-HER2 therapy, which ideally should be a dual pertuzumab, trastuzumab, but even single agent trastuzumab is good enough in majority. And in selective patients which are, say, elderly hormone receptor positive, neoadjuvant hormone therapy can be used. In the last year of pandemic, this has been a great savior for us, where we did not want to admit and operate elderly ER positive patients. We simply put them on neoadjuvant hormone therapy to buy time, and then in a safer time, we brought them back and operated them. In patients where we have decided to use neoadjuvant chemotherapy, there is definite evidence to document superiority of combination of anthracyclines and taxanes, and perhaps the best strategy today is to use them sequentially, which is to use anthracyclines followed by sequential weekly paclitaxel, because that way we can achieve the greatest degree of pathological complete response or extent of response, and also keep the toxicity to a manageable limit. In patients who have triple negative cancers, there are talks about use of platinum agents in neoadjuvant setting. Though there is a trend to increase response rate, it has not resulted in any benefit in terms of event-free survival or overall survival. So the present understanding is that platinum agents can be added to patients who have not responded sufficiently to the first line therapy, that is anthracyclines and taxanes, and to those who are triple negative, but not as the first line. There are certain other strategies which can be used in non-responder patients to neoadjuvant chemotherapy and who are triple negative. These may be in form of immunotherapy in PD-L1 inhibitors and PARP inhibitors, but these are all still under trial phases. Bevacizumab, which used to be at one stage or at certain time be of great potential or seen as an agent with great potential, hasn't really come up to the expectations, and it's not recommended presently. Patients who have HER2 enriched locally advanced cancers, the ideal way to treat them is to use dual agent anti-HER2 therapy. It is definitely should be considered if it is feasible. That is to say, if the patient can afford or your health system can afford. And the ideal way is to do a dual anti-HER2 therapy using trastuzumab and pertuzumab, which is supported by sufficient trial data. Pertuzumab is used for 6 cycles, and trastuzumab can be continued to complete one whole year of systemic treatment after the surgery. However, often we cannot use pertuzumab owing to the very high prohibitive cost of this drug, and so we use neoadjuvant trastuzumab along with cytotoxic therapy, taxanes specifically, and that too results in quite a bit of improvement in pathological complete response. And there are a number of trials which have provided evidence to support the neoadjuvant trastuzumab usage. And this is just the result of just one of them, the NOAA trial, which resulted in doubling of the pathological complete response rates in patients who were treated with neoadjuvant trastuzumab. As I said earlier, in patients who are elderly and who have hormone receptor positive locally advanced cancers, or patients who have locally advanced cancers and multiple severe comorbidities and yet are hormone receptor positive cancers, one can opt for neoadjuvant endocrine therapy. In postmenopausal patients, aromatase inhibitors are the agents of choice, and this can be continued for a minimum of 3 months to 6 months. And the maximum effect is supposed to be seen by 6 months of neoadjuvant endocrine therapy. A question is often asked that should we continue systemic treatment to achieve a complete clinical response beyond the standard cycles of neoadjuvant chemotherapy to improve the chances of pathological complete response? The answer is no. In patients who have responded sufficiently or have at least a good partial response to neoadjuvant chemotherapy, it doesn't make sense to continue beyond the usual cycles of planned cycles of chemotherapy. And usually we would use 4 cycles of anthracycline-based chemotherapy, followed by either 12 weekly cycles or 4 3-weekly cycles of taxanes. The exception being patients who have not responded well or those who have progressed with neoadjuvant chemotherapy with the standard chemotherapy. There are a subset of patients which we classify them as operable locally advanced cancers. These are patients who are those who have small locally advanced cancers, and especially when they are elderly and hormone receptor positive, which means that we can avoid, we would like to, and we can possibly avoid cytotoxic therapy in these patients. A primary surgery can also be considered. And this is if the patient has a disease which can be treated with mastectomy and primary closure of the flaps, perhaps one can do primary surgery and not resort to neoadjuvant chemotherapy. This strategy is, however, not applicable to patients who have triple negative or even to HER2 enriched and high risk patients, where even though you may achieve a bit of control of the cancers with neoadjuvant chemotherapy, but you cannot avoid them altogether. So it doesn't make sense to do primary surgery. It may well be wiser to resort to neoadjuvant systemic treatment followed by surgery and rest of the adjuvant treatment. Now, switching gears and coming on to the surgical treatment, what are the controversies and challenges that we can face while tackling the locally advanced cancer surgically? Almost always, these patients are treated surgically following neoadjuvant systemic treatment. That is because neoadjuvant chemotherapy facilitates safe conservation surgery in certain proportion of patients and also facilitates tension-free flap closure following mastectomy. Primary surgery, as I said earlier, can be done in exceptional locally advanced cancers which are operable, but in a certain proportion of patients who do not respond well to neoadjuvant chemotherapy, one may have to resort to salvage therapy even before completing whole of the systemic treatment or neoadjuvant systemic treatment, especially patients who have bleeding tumors or fungating or those who have palliative needs. So the surgery is required both on the breast and on the axilla. So firstly, looking at the surgery of the axilla, one can resort to or one can offer breast conservation to a highly selective group of locally advanced breast cancer patients who have responded very well to neoadjuvant systemic treatment. One can use oncoplastic techniques, which are quite handy in offering breast conservation, especially to locally advanced cancer patients. One can use tissue displacement or even regional flaps as tissue replacement, such as the Lettsman's dorsal flap. But a large proportion of patients with locally advanced cancers, they would require mastectomy. One can use reconstructive procedures with that using autologous reconstruction or implant-based reconstructions. So what is the status in today's era of the post-NSCT breast conservation surgery in locally advanced cancers? It is definitely a valid option in a highly selective group of patients. This is possible because of the high magnitude of clinical response to neoadjuvant chemotherapy in locally advanced cancers. There are a number of trials, some of which are randomized trials, which have evaluated outcomes of BCS following neoadjuvant chemotherapy. Unfortunately, a large proportion of patients in these trials are not locally advanced cancers, but they are operable cancers or early stage cancers, stage 2 cancers. But in a selective way, one can derive sufficient data of safety of breast conservation following neoadjuvant chemotherapy, even for locally advanced cancers. There have been concerns raised about higher local recurrence rates following breast conservation in locally advanced cancers. But as I said earlier, these seem to be unfounded in very highly selective group of patients who are at a low risk of recurrence following breast conservation. So the current practice today is offer breast conservation following neoadjuvant chemotherapy to a very selective group of patients who are at a relatively low risk of recurrence. There is a relative paucity of data or trial data documenting safety of breast conservation following NSCT for locally advanced cancers, but there are a number of non-randomized and mostly retrospective comparative studies which have documented that there is no impact or no detriment in overall survival with breast conservation, and there's a comparable to a somewhat higher local recurrence rate and comparable disease-free survival following breast conservation compared to mastectomy. So this is the gist of results of a meta-analysis which was published not so recently, but nonetheless a large meta-analysis involving more than 4,000 patients, including the NSABP B18 trial, which had by itself more than 1,500 patients. And all of them put together, they documented that there was no excessive risk of local recurrence rates with breast conservation vis-a-vis mastectomy in patients who were treated, who were operated and were treated with adjuvant radiation therapy following breast conservation. So it is indeed a challenge to perform post-NSCT breast conservation for various reasons, especially in locally advanced cancers. One has to be mindful of the extent of skin involvement that may be there in the patient. So one has to excise that part of the skin or the breast. The challenge also is informed because of the fact that the response to neoadjuvant chemotherapy may result in indiscrete tumor margins, and then there's no set pattern of response. There may be patients who have a concentric response to neoadjuvant chemotherapy of the tumor, but more often than not, the response is a combination of concentric and a patchy or honeycombing kind of Swiss cheese pattern of response. So the key to successful breast conservation following neoadjuvant chemotherapy is to select the right patients or select the right candidates for conservation following neoadjuvant chemotherapy. These are patients who have favorable prognostic indices. One must follow all principles of breast conservation, that is to achieve infiltration-free margins at all costs, preserving the breast shape and contour and symmetry, and use of oncoplastic surgical procedures or surgical techniques is very helpful in doing this. So if one cannot achieve infiltration-free margins, or in the effort of achieving infiltration-free margin, one has to excise so much of the breast volume that one cannot achieve good breast shape and contour and symmetry, then perhaps it doesn't make sense to do breast conservation. It would perhaps be better to do a mastectomy and reconstruct the breast. One technique which comes very handy in terms of achieving safe conservation is to mark the tumor before initiation of neoadjuvant chemotherapy. Marking the tumor with a radiopaque marker, it aids breast conservation in patients who have responded very well to neoadjuvant chemotherapy, and it has been shown to provide better oncological outcomes. Breast conservation is possible in some patients without margins who have relatively small tumors and small breast, but markers may be the only remaining evidence of tumor bed in up to 40% of all patients, according to some studies. So it is definitely valuable to mark the tumor before initiation of NSCT. And in a study from the MD Anderson Cancer Center in Texas, it was very clearly documented that patients who had a marking of tumor before initiation of NSCT, they had lower local recurrence rates compared to patients who did not have the marking of tumor before a neoadjuvant chemotherapy was initiated. In our own experience, we have published it a couple of times now how breast conservation is made feasible following marking of the tumors, either marking of the margins of the tumor before initiation of treatment, or so to say bracketing of the tumors, or else marking of just the core of the tumor. And one can use the commercially available tackers or marker devices which come at a substantial cost, or one can use an innovative way, the way that we've been using loading a small sterilized silver wire or a straightened Liger clip on the tip of a lumbar puncture needle and inserting it at the margin or the core of the tumor, either aided with an ultrasound or just by palpating the tumor. And this kind of bracketing can be of great use in patients who have a patchy response, and then especially patients who have luminal A and luminal B cancers, or even in certain low grade, triple negative cancers. We prefer doing bracketing, but for majority, we now just put one marker at the core of the tumor, and using the guidance of these silver wires or the clips, one can do a wide excision. Oncoplastic procedures or techniques are of great value in ensuring safe breast conservation. They facilitate good cosmesis with wide margins and low ipsilateral breast tumor recurrence rates. They are also vital in reducing deformity and ensuring breast symmetry. However, they come at an added challenge, both in terms of surgical techniques and expertise, but also not only in that way, but also in form of the challenges posed during the adjuvant radiation planning and in terms of early detection of recurrence in the follow-up. This is just one example of a volume replacement mini LD flap. You can see on the left breast. This patient had a locally advanced cancer with a relatively small area of skin involvement, and she had a wide local excision or a segmental mastectomy with a mini LD flap reconstruction with a fairly good cosmetic outcome with a good breast symmetry and contour. Coming to the surgical management of axilla in locally advanced cancers, quite a bit of this has been covered with the previous talk by Dr. Deeptendra Sarkar, but just to recapitulate, in patients who have locally advanced cancers and who have received neoadjuvant chemotherapy, the standard of care by and large remains a full axillary dissection following neoadjuvant chemotherapy. However, the alternative strategies of either a primary sentinel lymph node biopsy before initiation of neoadjuvant chemotherapy in patients who present with CN0 axilla, or a post-NSCT sentinel lymph node biopsy in patients who have post-NSCT N0 status in the axilla are being discussed. So to answer this question, whether sentinel node biopsy is appropriate for large tumors or post-NSCT N0 axilla, there have been a few studies, including some of our own data, which has been published. This issue is not as well addressed and as well established as the value of sentinel lymph node biopsy in early breast cancer patients who are undergoing primary surgery. But the limitations of post-NSCT in this scenario is if we do not use this strategy, we would perhaps waste some of the advantages that we get from the neoadjuvant chemotherapy. The pre-NSCT staging negates the advantages of downstaging of axillary disease, and the post-NSCT sentinel lymph node biopsy is fraught with the high false negative rates, and perhaps as a result, the optimal strategy is still not yet determined when we talk of post-NSCT sentinel lymph node biopsy for locally advanced cancers. There have been a number of studies which have documented the value of sentinel lymph node biopsy following NSCT. These include the ECOSOC Z1071 study, the Sentinel study, and the FNX study. Quite a bit of this was discussed earlier. I would not go into details, but as a number one fact is that only a very small proportion, either very few of these patients were locally advanced cancers, or perhaps, for example, in the SNFNAC study, none of them were locally advanced cancers. So one should not extrapolate the evidence which has been provided by these trials to address the axilla following neoadjuvant chemotherapy in patients who have locally advanced cancers. In perhaps one of the only exclusive study of sentinel lymph node biopsy in patients with locally advanced and large operable cancers that we conducted, we found that the accuracy of sentinel lymph node biopsy following or before neoadjuvant chemotherapy in patients who had large operable cancers and who presented with N0 disease, the sentinel lymph node biopsy, sentinel lymph node identification rate, as well as false negative rates were very good and acceptable, comparable to patients who had undergone early breast cancer surgery or primary surgery for early breast cancer. However, in patients who had locally advanced cancer and in patients who had undergone post-NSAT surgery for a disease which as an index stage had skin involvement or T4B disease, or had matted nodes or N2A disease, or who had external invasion or lymphovascular invasion, and especially in patients who were young and had disease in the upper outer quadrant. These patients had unacceptable sentinel lymph node identification rates and very high false negativity. So, post-op radiation therapy is a standard of care in patients who have been operated for locally advanced cancer. In terms of outcomes of locally advanced cancers, we know that locally advanced cancers have certainly much worse outcomes or survival in comparison to early cancers. But then, as I said earlier, locally advanced cancers too are reflective of a whole spectrum. In our own experience, we have documented very clearly that triple negative breast cancers who are locally advanced cancer, triple negative cancers, triple negative locally advanced cancers who did not achieve pathological complete response, they had much worse outcomes in terms of survival compared to hormone receptor or HER2 positive triple negative cancers. And in patients who had triple negative cancers and who achieved pathological complete response with neoadjuvant chemotherapy, there was not much of difference in terms of survival compared to non-triple negative cancers. So far we have talked about neoadjuvant chemotherapy or systemic treatment, surgery, and adjuvant RT. What about adjuvant treatment following surgery? Adjuvant RT is a standard of care, but in patients who have HER2-enriched locally advanced cancers, they should receive ideally 1 whole year of anti-HER2 therapy at 3 weekly intervals, which has a better compliance compared to weekly intervals. And there is no documented benefit of continuation of anti-HER2 therapy beyond 1 year. However, there are some studies which have documented quite a bit of benefit even with at least a 3 months period of anti-HER2 therapy. There is perhaps no role of adjuvant dual anti-HER2 therapy, which was, as we discussed earlier, is a very vital strategy in neoadjuvant systemic therapy. In neoadjuvant setting, addition of pertuzumab, trastuzumab in HER2-enriched cancers, it has the potential of doubling the pathological complete response rates. However, in adjuvant setting, this is not so. In patients who have triple negative cancers and who have not achieved pathological complete response, the CREATEX trial and now certain other trials, they have very clearly documented the value of adjuvant oral capecitabine chemotherapy. So 6 to 8 cycles of adjuvant capecitabine can be given in such patients, and that has resulted in certainly improved event-free survival and perhaps overall survival too. So having treated these patients, we have to follow them. How intense or how frequent and how long should this follow-up be? Local regional recurrence and distant relapse, they are much higher in locally advanced cancers compared to early stage cancers. But these events are the most probable in the first 2 years, and then they keep decreasing. The probability of these continues to decrease with time. There is a lifetime high risk of contralateral breast cancer in these patients and metastatic disease, and these necessitate lifelong follow-up. Commonly, we resort to this kind of a protocol where we do a clinical evaluation once every 3 to 6 months in the first 2 years, and then advocate breast self-examination by the women themselves monthly, annual mammography after completion of therapy, breast imaging after 6 months, and then annually, and metastatic workup either in form of annual PET CTs or by a combination of other means once every year, lifelong. So to summarize, there are a number of controversies and challenges in the management of locally advanced cancers. It is vitally important to have a protocol-based comprehensive treatment plan for each patient with locally advanced cancers. Neoadjuvant systemic treatment is the standard of care. In majority of patients, we try and use a combination of anthracyclines and taxanes in a sequential manner. In patients who have HER2-enriched locally advanced cancers, neoadjuvant trastuzumab, and if the cost can be borne either by the patient or by a funding agency, then pertuzumab too is of great value. Carboplatin as a second-line treatment in non-responding triple-negative cancer patients can be considered, but has no value as a first-line therapy. And post-neoadjuvant chemotherapy surgery is essential. It can be mastectomy in majority, but in a highly selective group of patients with relatively low risk of recurrence, and where we can perform a reasonable and valuable or good outcome breast conservation. One can resort to oncoplastic approach to conserve the breast. Post-op radiation is essential, and it can be followed with adjuvant hormone treatment in hormone receptor positive cancers and adjuvant trastuzumab in qualifying patients, followed by a lifelong follow-up. And in terms of surgery for locally advanced cancers and large operable cancers, breast conservation seems appropriate in a highly selective group of patients where conservation results in comparable overall survival and disease-free survival, and with somewhat higher local recurrence rate compared to mastectomy. The follow-up, while we are operating these patients, especially when conserving the breast, one has to follow all the principles of oncologically safe surgery, and oncoplastic surgical techniques come very handy to achieve infiltration-free wide margins while maintaining good cosmetic outcome or good breast shape, cosmesis, and symmetry. Post-op RT is standard of care, and one can add marking of the tumor before neoadjuvant chemotherapy, and that facilitates good breast conservation surgery in these patients. So I thank you all for your patient hearing. If there are any comments, any questions, I'll be happy to address them. Thank you.
So it was a wonderful presentation, very nicely presented. The reason why we requested you to present such an important topic is because majority of our patients, or rather a major chunk of our patients, are now having LABCs. Although with increasing awareness, even people from rural areas are now coming for asking for prophylactic mastectomy on the opposite side and coming with early stage breast cancers. It is in fact people from rural background who are more aware about their malignancies rather than those who are educated, because educated individuals tend to be hesitant at times, especially those working as faculty members in medical colleges. They try to look for other things out. Is Dr. Noor Topno with us?
No, he is not there. I just had a word with him.
Acha. Okay, sir. For the paucity of time, I think we can start the next. Acha, ma'am. Okay, ma'am.
Dr. Gaurav, can I ask you one question, please?
Certainly, ma'am.
Suppose there's a patient, she has got a large operable breast cancer, a large breast, heavy breast, with a tumor of about 6 centimeters, but it is still mobile and operable. Should we offer her upfront surgery or go in for neoadjuvant? A large, bulky, large breast with a tumor of about 6 centimeters, would we offer her upfront surgery or put her on a neoadjuvant regime?
Okay, so this patient, as I discussed during the talk, I would need to know the tumor biology and whether the patient wants a conservation or a mastectomy. This patient is large operable cancer, certainly operable cancer. So if the patient is not too keen to conserve the breast, is demanding a mastectomy, it doesn't make a difference whether we operate or we neoadjuvant chemotherapy followed by surgery. With the exception that if this patient is triple negative, I would perhaps still be keen to do neoadjuvant chemotherapy. The reason being that in case she fails to respond sufficiently or she does not achieve pathological complete response, then we know that she will benefit from adjuvant capecitabine treatment. But if the patient is keen on conservation, then I would be, my first choice would be to do neoadjuvant chemotherapy followed by breast conservation surgery.
Because many patients sometimes ask for upfront mastectomy. They say we do not want any neoadjuvant chemotherapy. Please remove this thing. We do not want it. So are we doing anything wrong by offering upfront surgery? That was my question to you. In such cases, patient does not want conservation. That's
Yeah, ma'am. In that case, again, it depends on the tumor biology. If
tumor
the patient
biology.
has,
Correct.
if it is a luminal cancer, then by doing an upfront surgery, you have absolutely not caused any detriment to the patient. But however, if the patient has a locally advanced cancer, perhaps neoadjuvant has a triple negative cancer or HER2 enriched cancer, then neoadjuvant systemic treatment is appropriate.
Thank you.
I think we can proceed to the next session. The next topic will be delivered by Professor Anita Dharban. She'll be talking about evidence-based management of benign breast disease.
Thank you very much, Dr. Atya. Thank you.
Thank you so much, sir. Actually, I've got so many things on hand. I've forgotten the basic courtesies. I'm so apologetic.
No, this is perfectly fine.
I'm extremely sorry.
Okay.
I hope you will understand. My hands
Certainly.
are full. Can we have Dr. Anita Dhar, ma'am, please?
Good evening, Dr. Athiya and the team. Thanks for inviting me. Am I audible?
Yes, you are very much audible. Can we have your slides shared?
Yes, please. Are my slides visible?
They are very much visible, ma'am. Please proceed.
Thank you. So this topic is quite different from the rest of the talks in this section. Benign breast disease is something that many of us, almost all of us, see in abundance in our practice. And many a times we feel like, what should be the treatment? And I put some evidence-based management and try to get it from the literature, and as well as cover our trials and the studies that we have done at our own center. So the benign breast disease has the full spectrum, starting from mastalgia, breast lump, mastitis, nipple discharge, all of them, they fit here. Mastalgia, also called as mastodynia or mesodynia. Almost 50% of the patient population coming to a clinic most likely you also see such an increased number. And 70% of the ladies of a woman's time, she will have some problem related to the mastalgia. 5 to 20% of the cancers have pain, but it's not a primary symptom. It may be an associated symptom. So we have to classify them whether it's a cyclical or a non-cyclical. Non-cyclical can be a true pain arising from the breast or the surrounding tissues, the musculoskeletal tissues around it. So why do we need to know so much detail about it? The fact is that it interferes in our physical, sexual, social, and day-to-day activities. I still remember there are a lot of young girls, they come with mastalgia and they say, we're working in some office, but I can't hold my pen. The severity of the pain is tremendous. So that is what hampers their day-to-day work. This is a typical Cardiff breast pain chart where it's shown the cyclical pattern of the mastalgia. We can see there is typical exacerbation of the pain just before the onset of the menstrual cycle. It may be 7 to 10 days to 1-2 weeks. And this is a non-cyclical one. A true non-cyclical pain, there is no relation, no pattern, fixed pattern to it. We at our own center, we modified it a little bit, and we do recall that there are a lot of ladies having pain on right side, no pain on the left side, and this created a little bit of thought, and this was a modification given to it. This chart will have right breast pain, left breast pain, and it will be based on the visual and log scale provided at the top. And they will also make a note of the menstrual period, the days when she had it. And she will come with this chart when we ask her to see what pattern she is following. It goes without saying, triple assessment is the most important key whenever a patient comes with whatsoever problem in the breast. So we have to evaluate the patient clinically, check the patient imaging, and wherever there is necessity to do cytology or biopsy of the lesion. So mild pain on visual analog scale less than 3 needs reassurance, and almost 85% of the patients, they settle. That's the most important worry, whether they have cancer or they are having some other disease. The minute you tell them, no, you do not have cancer, that takes away their worries. So they will be at peace with themselves. Then providing some sort of exercises and weight reduction wherever you find that patient has increased BMI, because we know the heavy breast, they pull on to the ligaments and that gives pain. So provide them proper breast support. It relieves tension on the suspensory ligaments of Cooper. Local application of diclofenac gel that helps in milder forms. Oral medications may be required to do away with the pain. And then if it's a non-cyclical or a true pain around the musculoskeleton, if we have a trigger point, we can do some injection of triamcinolone combination with lignocaine in that spot. What about moderate to severe? It's more than 3. Systemic therapy is required. We may combine it with the local application of diclofenac gel, and there are drugs that are available like tamoxifen and danazol, bromocriptine, goserelin, and then our own ormeloxifene. I'll tell you about some detail about this. Cyclical pronounced mastalgia, which is common type, and if there is pain more than 3 on visual analog scale for a period of more than 1 week per cycle for consecutive 2 months, they deserve some more treatment, or they have pain that interferes with their quality of life. We need to start oral medication. This is a full spectrum of the medicines that is available under this heading: tamoxifen, danazol, bromocriptine, LHRH analog, gamulinic acid, and evening primrose oil, still a favorite of many, whereas while it has its own limitations, I'll tell you about it. This is on a table where we can see an overall view of tamoxifen. For example, if we give 10 milligrams OD, the response rate is excellent, 98% in cyclical mastalgia, 56% in non-cyclical, but it's associated with its own set of side effects. 50% hot flashes, endometrial, hyperplasia, stroke, cataract, all sets of complications are associated and known with it. Ormeloxifene, an Indian molecule, 30 milligrams. I'll give you details about this drug in a minute. It has 89 to 90 in older, but we have new trials. I'll speak about that. The only problem is amenorrhea or scanty periods, and we'll talk about it further. Danazol, 100 to 300 milligrams given per day, has 70% good control. The problem is weight gain, acne, hirsutism. The evening primrose oil, 6 capsules daily, it's not more than a placebo for that patient. So why give it? So we have stopped using evening primrose oil for the patient. Of course, it has some element of nausea and vomiting also. Then bromocriptine, 1.25 to 5 milligrams, BD, 70% control, also has its own set of the complications. LHRH has been reserved as a drug for short-term use and in refractory cases. 3.6 milligrams per month for 6 months is the treatment given, but it has a significant amount of side effects associated with it. This was a meta-analysis, evidence-based mastalgia treatment, a meta-analysis published by our department in 2007, which said it was actually restricted to the randomized controlled trials comparing bromocriptine, danazol, EPO, and tamoxifen with the placebos. what was the conclusion of this? We found that danazol was a good drug for the pain relief, but the end point was that tamoxifen is associated with least side effects and should be the first choice. But do we have choices other than this? Our own Indian molecule, ormeloxifene, as earlier it was called as Centroman, or the trade name may be Novex, and synthesized by the Central Drug Research Institute, Lucknow. So this is a drug which is a selective estrogen receptor modulator. It's a non-steroidal, a weak estrogenic. How does it work? At our own place, we conducted many trials. First trial was non-randomized, published now in World Journal of Surgery, and was presented in 2005 at World Congress. It gave excellent results. It was a combined trial that time on both mastalgia and a separate group on fibroadenoma. But later on, we did a trial comparing it with danazol, and regression of fibroadenoma also was associated with it. This was the published trial. We later on did a randomized trial with danazol with excellent results. You can see the results here. Mastalgia, in the first week itself, patients came and they were happy and satisfied. And up to 3 months, we gave this medicine. We can see this pink color. It has a linger on or a carry forward effect for the next 3 months, whereas the danazol, few cases did come back during the next 3 months. Nodularity, ladies are very much worried about nodularity. This is how it dropped, and significant improvement in 8 weeks, rather in first week with both the drugs, but it was seen in a very efficient way in the first week with danazol. What about tenderness? Both drugs had a magical response in the first week itself, and there was some amount of comeback, but not too significant. So it was significant at par with danazol and had a carry forward effect and lingering effect in the next 3 months. But the problems were there were ladies who came with that I have the scanty menstruation, I have scanty, maybe there's amenorrhea, and this was worrisome for them. And then there were certain trials other than AIMS, and they found that cyst formation were there. So we designed and wanted to settle what was the exact dose that was required. Because when we started it as an alternate day, 30 milligrams. Then we even gave daily. Both the combinations had nice effect, beneficial, but what about the side effects? The only contraindication was the polycystic ovarian disease. We regularly get ovaries checked by ultrasound before we initiate this treatment. So we designed a trial where we compared ormeloxifene with tamoxifen, and this was based on the thought that it has a long half-life of 168 hours. So we wanted to have a look, what is happening to these side effects that were not truly documented in various trials. This was presented in World Congress in 2019, and we found that it was equally good. We have tamoxifen 10 milligrams daily, ormeloxifene 30 milligrams twice a week, ormeloxifene 30 milligrams thrice a week. And you can see it's almost an overlap of the curve. They worked very nicely, all the 3 combinations. And you can see here the breast nodularity had equally good response. Physical domain, social domain, the psychological domain, environmental domain, they were all the quality of life domains that were checked with excellent results. Now, what about the menstrual irregularity? At 12 weeks, we found there was no change. Tamoxifen had excellent results here, some irregularity only. And what about twice a week dose? It had some little bit of change here, but with thrice a week, we had significant delayed menstruation and oligomenorrhea. That was little more than twice a week, which settled immediately after we finished the treatment and within 6 months, they were all normal. And 24 weeks now, 24 weeks, all of them, they settled at the end of the 6 months. Now, what happened to the ovarian cyst? Ovarian cyst, none of the tamoxifen group developed any cyst. The ormeloxifene group temporarily developed ovarian cyst at 12 weeks, but they all settled by 24 weeks, as I said, twice a week dosage regimen, whereas only few had at 6 months in the thrice a week group, but they all settled in next few weeks. So we concluded that all the three, they were equally beneficial for the patient. Ormeloxifene 30 milligram twice a week and thrice a week had similar improvement, but they had tamoxifen, and both, they are known to have a carryover effect also, which is very important in the next 3 months after stopping the drug. 30 milligram twice a week had least incidence of the side effects or the adverse events, and ovarian cyst and menstrual irregularities, they were all transient. So that settled, this trial settled that we should give a dose of 30 milligram twice a week for 12 weeks and observe after that. And this optimal dosage regimen has the least side effects. So I say that whenever we have to give drugs, ormeloxifene or centroman, it should be the drug of choice and should be avoided in PCOD cases or ovarian cyst, which has a complicated ultrasound finding. Tamoxifen may be the drug of choice in select cases where maybe there is PCOD. Danazol or bromocriptine has side effects, so it should be a reserved drug. Whereas lopramide or groserelin, it's a drug of choice for refractory cases because it cannot be given for a long time. So what are the don'ts? Don'ts, even if it's a beautiful flower, please do not prescribe evening primrose oil, which is an extract from it, vitamin E, pyridoxine, vitamin A, and gamolinic acid, which is an extract from evening primrose oil. This and diuretics, of course. These are not to be prescribed. Coming to the lumps, again, a very important symptom seen in the clinical practice. How do we manage breast lumps? After triple assessment, if it's a fibroadenoma, less than 3 centimeters, age is less than 30, we usually follow up. But if there is a need to give treatment, medical treatment, the choices are tamoxifen and or ormeloxifene, 30 milligrams daily. There are surgical treatments reserved. I'll come back to it. And the problem comes if patient has multiple fibroadenomas and maybe that too on bilateral both breasts. This is a trial I mentioned. We prescribed 30 milligrams daily dose of ormeloxifene, and we found that 30% of the patients, the breast lumps less than 3 centimeters, they disappeared. And another 54% decrease in size, means even if you have to remove them, the size will come down and patient will have a cosmetic incision. And we found that 16% while on the medicines, they increased. Whereas in the control group, we found a progressive increase in almost 75% of the patients. This was quite a bit. Surgical management or the excision, if there is associated pain, patient preference, sometimes they feel like, no, you should not be there. More than 30 years, giant fibroadenomas, by definition, more than 5 centimeters size. Or if fibroadenoma on an ultrasound gives an atypical or complex fibroadenoma image and family history of breast cancer, will not like to leave it behind. So age more than 35, size 2.5 centimeters, restricted mobility, imaging gives us discordance with the clinical findings, we should remove it. Enucleation is the treatment of choice in less than 30 years with intact capsule. But the excision is the treatment of choice when there is age 30, more than 30 years, because there is risk of maybe because fibroadenoma and phylloid, sometimes it's very difficult to make it pre-operatively. And This is a case of giant fibroadenoma. Gallert-Thomas incision was given. It's a neat surgery and lifting the breast anterior surface to the pec major fascia, and you can enucleate as large as these fibroadenomas. And there are other methods available for the intervention. We talk about the minimal invasive techniques, cryoablation, laser interstitial thermotherapy, vacuum-assisted biopsies, radiotherapy, radiofrequency ablation, or high-intensity focused ultrasound therapies are all available in different centers. Now let's go to the phyloid tumors. A brief review. Phyloid tumor is something, it's notorious for recurrence. So they are clinically known to have present like rapid growth rapid growth of the breast lump, bossylated surface, overlying skin may be stretched, and there may be prominent veins over the lump. They are known to grow rapidly within the mesenchymal elements of the breast. Propensity for local recurrence is there. And the role of pathology is very important, as I said, even to differentiate it from fibroadenoma, and having a pathologist taking its own time to report. Maybe there is a tussle between whether it's a fibroadenoma or it's a phyloid, because the treatment offered will be a little different, because we know phyloid has a local recurrence high rate. So Jacqueline et al. Devised a Paddington score for accurate diagnosis of phyloid tumors in 2006. It has its own 6 criteria. 2 of them, if present, we can clinically or radiologically or imaging, we can diagnose it as a phyloid tumor. So these are the 6 factors that can be accounted, and we can make a diagnosis of suspicion based on the clinical pathological criteria. So we modified, because FNAC, it's based on FNAC. So we are not doing FNACs in our center now. We are always using ultrasound and ultrasound guided core biopsies. So we make some modifications of this, and we have a core biopsy based modified Paddington score, and we are doing a trial right now based on the phyloid tumors, and it has the accountability of high stromal cellularity, nuclear atypia, increased mitosis. All of that is recorded in this. Now, what is the consensus? How much should be the margin to have an adequate excision of the phyloid tumor? That is something debatable. People say, most of the trials say it has to be more than 1 centimeter. Whereas there are people who say this should be 2 centimeters, and less than 1 centimeter, if it's a small breast, phyloid is there. As a surgeon, we are also concerned about the cosmetic result outcome of this patient. And that creates a big problem clinically, what to offer such patients. And the recurrence benign has 1.9 to 6.2%, whereas borderline tumors 4.5 to 11.5%. Malignant, of course, is as high as 19%. So this is what is the basic issue. Now, there are school of thoughts whether we should remove and block the whole thing along with the skin because of this huge recurrence rate and also the underlying muscle. So there are ancient guidelines. They recommend 1 centimeter. We at our own place, and this is Tata Memorial Center in Mumbai, they also are practicing 2 centimeters and a wider excision because of the worry of the local recurrence. Yes, we are worried about the cosmetic benefit, the impression of the patient, and the first concern should be the coming back of the tumor. No hooks is the dictum. We cannot raise the flaps to create flaps and then close. If it's a large tumor and the deficient, the residual breast is very small, we have to take a call on it. We cannot take flaps. So this is how we are doing it at AIMS. We take a margin and go beyond it 2 centimeters. Now we have a trial where we are thinking that 2 centimeters may be more, as it's recommended 1 centimeter, and 1 and 2 centimeters is the randomized trial going on. It's en bloc along with the skin and the underlying muscle have in a such large tumor. And we do consider smaller tumors with a restricted excision, but not compromising the margin. This is the en bloc removal as the whole. So in 61 women for over 5 years, they were mean age of 35 and tumor size mean 8.7. The observation was where wide local excision of 2 centimeters was done, 25 patients were total. Radical mastectomy was done in 25 patients. No, this is based on the size of the involvement of the breast and whether the whole breast is involved. We do have patients where the almost whole breast is involved. There's nothing short of a radical mastectomy in such patients without touching the axilla. No local recurrence was seen in a follow-up of 0.16 to 5 years. What is the role of radiotherapy? Radiotherapy remains a little controversial because inadequate data from each center is available that could extend the time to local recurrence and decrease the local recurrence rate. This is what is thought of. In malignant phalloids, it helps because we know otherwise also the recurrence rate is very high. And borderline phalloid tumors remains controversial. And if we have left positive margins, ideally one should go back and excise the positive margins. Coming to another breast lump, especially when patient is lactating and or after cessation of immediate lactational period, is galactocele. There should not be a tendency to excise and remove it. Galactoceles it may have a communication with the milk duct. They are painless, small, mobile swellings. And you can see this patient, and aspiration is the treatment of choice. It may be required 2 to 3 times, but sometimes it's from the literature we have picked up one study where they have used 2,0 nylon to cannulate the duct from which this milk was coming, and we thought it was blocked with a good result. They thought that there is a plug in the duct and that can be opened. And we have tried it in few cases, and usually the aspiration works. But what about this calcification of this galactocele? You can see this mammogram, and it requires occasionally excision of the lung. Coming to cyst, 1/3 of the ladies in the age group of 30 to 50 may have an cyst present, and they may mimic malignancy. Simple cyst, they don't need any intervention most of the times, and they are smooth-walled and by RIDE 2 classification. They may need some aspiration if there is this pain and stretch in its giving problem. Make a note of it, what kind of aspirate it is. Is it bloodstained or not? It will help us in further management. If there is a residual lump after the aspiration or it's bloodstained, a core biopsy may be needed for histopathological examination. What is a complex cyst for students? A simple cyst, it doesn't have any added findings, but a complex cyst, there are some solid components in the wall that necessitates core biopsy to rule out cyst adenocarcinoma. What is a complicated cyst? It's defined as a cyst containing intracystic debris, which moves within the cyst itself. It usually indicates some sort of an infection, and a short course of antibiotics given may treat this and resolve it. And we have already talked about it. Another condition called mastitis. Lactational mastitis. There was a study from Professor Shukla in 2006 where they have used the vacuum suction drain to evacuate the breast abscess. You can see the whole one can present like the erythematous surface with the abscess. You can aspirate and found the evidence. Patient can pour out pus, and this is an ulcerated one. partly healed, ulcerated again, and vacuum assisted or vacuum suction drain can be placed in a minimal invasive way in the pocket. This is all done under ultrasound guidance, and we can evacuate the pus. We can irrigate through this and evacuate. A baby can have milk in the lactating mother, comfortable mother with a comfortable child. And there are advantages. There is quick resolution of the abscess, no need of daily or alternate day aspiration. There is no need of dressings. Patient is comfortable and child can continue to take milk from the nipple. We are embarking, almost coming close to finishing a trial where there is aspiration in one arm, it's a randomized trial, and a vacuum drain placement in another. Maybe in next meeting, we can present the data. This is how the results are. This is the result after 30 days follow-up after vacuum suction drain was placed. What about non-lactational mastitis? Non-lactational mastitis is again a challenging division of the benign breast disease, and it can be periductal mastitis or idiopathic granulomatous mastitis. We recently finished with observation, and it was an observational cohort study for decision analysis and approach to such patients of non-lactational mastitis. We have seen in our country that most of the patients who do not respond to antibiotics short term, because people don't give for a longer time period, and they start either excising them or put them on antitubercular therapy without any proof, and also the drainage and all is done unnecessary. The steroid is given without evidence. So this is typical definition of a non-lactational mastitis: inflammation in the breast in a woman who were nulliparous or had onset of inflammation 6 months after stoppage of breast. So anything beyond that will be non-lactational. And I can come back directly to this. This is the study where we can divide it into periphery and center. This is center. If it's a granulomatous tuberculosis, tubercular, after getting the thorough examination through imaging and all for the tuberculosis, and also sending gene expert the sample for gene expert. If it's a tubercular granulomatous mastitis, then only we prescribe ATT. Otherwise, medical treatment, antibiotics are given. Very few patients who do not respond to long-term therapy. What is long-term therapy? Patient may need 2 weeks or even stretchable to 3 weeks antibiotic therapy. And if they do not respond, then only we can think of giving steroid, which is a very, very minuscule of patients. Whereas surgical intervention may be required in the form of radical duct excision in such patients with the central mastitis. What about acute ones? They need drainage of the abscess and they continue with antibiotic. Selective patients will have radical duct excision. Whereas in periphery, granulomatous mastitis or certain amount of tubercular, they need antibiotic treatment. Select group where gene expert is positive will be put on ATT and steroid, for example. In such cases, we couldn't do, there was no need to, they responded, most of the patients responded. And again, antibiotic therapy where it's an acute on chronic variety. I conclude from this trial, the decision analysis approach, it's a useful aid in decision making and creating an algorithm for management of such patients. Allows selective use of ATT. ATT is not to be given as a free drug if patient does not respond to the antibiotics. They do respond. The only thing is it's to be given for more than 2 weeks or 3 weeks in most of the patients. And very selectively steroids where there is a recurrence or patient is not responding to antibiotics. Coming to nipple discharge for students, if we say this, There are different types of discharges available, like presentation in the patient, blood-stained, serous, watery discharge, or colored or milk-like discharge with variety of diseases named with them. And this is the color, sanguineous, clear watery, cheesy discharge. This is complete serous, and this is milk discharge. Risk of cancer in blood-related discharge, less than 40 is 3%, 40 to 60 years is 10%, and as the age progresses, it's 32%. So we do investigate, go for triple assessment, and do mammogram. If it's less than 35 years, we do offer MRI and look at the cytology. Cytology, though it's not so much helpful, low sensitivity of 45 to 55%. And many patients may have on ultrasound dilated ducts in subalveolar region. And it's very effective in telling us the details. Few centers are doing ductoscopies and retrieving material for cytology and doing some therapeutic, which is very restricted and not very select centers are offering this. This is intraductal papilloma. You can see this and gets detached. Patient has blood-stained discharge. We group them together, and if it's less than 30 years of age, in the blood-stained person, we offer microdocotomy up to the length of 5 centimeters or till the duct is dilated. But about age of 30 years to 45 years, surgery is offered in case there is a family history. We do offer, if patient is married and has completed family, the patient may be offered radical duct excision. Major mammary duct excision is offered to above 45 years of age, because most of the times they may have multiple papillomatosis, and that relieves them. We usually find that in first 5 centimeters, this papillomas, they are not seen. Too many patients are not seen in the periphery with papilloma. Non-milk bloody discharge we offer, they associated with infection, also anaerobic or aerobic. We prescribe them antibiotics first 2 to 3 weeks, and if there is a subalveolar pus, we drain it, but actually aspirate it, and we may offer after 3 to 6 weeks later radical duct excision or whatever the case may be. This is ductectasia, dilatation of major ducts due to involution. You may find typical toothpaste-like discharge, and sometimes patient may have some fistula associated with it, and coarse calcification may be required. And there is a need to remove the cone at most of the patients, and this is how we do it with just less than 1/3 of the circumference involved in to prevent necrosis of the skin. This is the ductal cone that is retrieved, and we mark it at the nipple end and shave off the undermined below the surface of the areola. We trim that residue so that the recurrence is not there. This is the result after 6 months. It works well for these. As I said, single young ladies, single duct microdocotomy may be done. It's a neat procedure. We can cannulate, put some methylene blue, identify the duct, and remove it depending on the indication, 5 centimeters or so. And this is the result. The problem is in the non-bloody discharge cases, how much length we should remove. There are evidences, trials, they say it should be 1 to 2 centimeters. And if papilloma is associated, this should be 5 centimeters. We are having, I'll show the results of a trial we just finished, few cases, there are defected hair, and 1.5 centimeter versus 3 centimeters. In non-bloody type of discharge, we did radical duct excision, and we found excellent results with both 1.5 and 3 centimeters. But when we see about the nipple areola complex, anesthesia, paresthesia, and the necrosis, they were minimum in 1.5 centimeters. Cosmesis was excellent in 1.5 centimeters. and compared with the 3 centimeters. And not many patients we found of the invasive ductal carcinoma. So this is how it is. Cosmetic partial necrosis was seen in 10% in 3 centimeter category, whereas none. So through this study, we concluded, though it had limited numbers, we are going on still with this study. And we said 1.5 centimeters is good enough length for excision of the ductal cone in non-bloody discharge cases. And it can be achieved very much under local anesthesia. So I finish here, and for a wide topic like this, I couldn't figure out any take-home messages, but I can conclude triple assessment is a must as an initial evaluation. Different entities of benign breast disease should be identified, evaluated, and offered appropriate treatment. Treatment can be evidence-based as per the guidelines, and randomized trials now available in a variety of centers, and that will bring in satisfactory results for such patients with minimum recurrences. Thank you so much. Thank you.
Thank you, ma'am. It was indeed a pleasure to have you with us. Because of paucity of time, I regret to inform everybody that we do not have any scope for having any interactive session after this wonderful, valuable presentation made by Professor Anita Dharban. She has been of great help to all of us. She has been associated with the previous update as well. I'm very grateful to you, ma'am, for being there with us. The next session will be moderated by Dr. Syed Hassan Haris, who is very much into endocrine surgery, and Professor Ejaz Ahmed Malik from Sher Kashmir Institute of Medical Sciences. Welcome, Dr. Hassan Haris and Professor Ejaz Ahmed Malik. Both of you are requested to moderate the session. Incidentally, I happen to be the first speaker of it. Please read the names of the chairpersons as well. Dr. Hassan, over to you, please. Can we have Dr. Hassan or Dr. Malik here?
Yeah, thank you, Dr. Atiya. Yeah, I'm there. Hello. Yeah, Dr. Atiya.
Yeah, I can hear you. Should I share?
Yeah. So we'll start with the session immediately, and the chairpersons for the session are Dr. Noor Topno, Dr. Anubhav Vindal, Dr. Puneet, and Dr. Kamal Kataria. So I'll request Dr. Atiya quickly to start with her presentation, and which is an approach to a patient with goiter.
I hope my screen is visible to everybody.
Yes, that's visible.
Okay, so basically what I wanted to do was because we are going to have great presentations by Professor Anand Kumar Mishra on differentiated carcinoma thyroid, which will be followed by medullary carcinoma thyroid. And then, of course, wonderful presentations are going to be made by Dr. Padma Kumar, Professor Abhay Dalvi, as well as Professor Chintamani, sir. So I'm a very small person, but nevertheless, since we are talking of goiter, so I think it is very pertinent that we should talk about, एक मिनट में कहती हूँ जरा, आशीष जी उसको फुल स्क्रीन कर दीजिए, मुझसे हो नहीं पा रहा है.
मैम इस पे क्लिक कीजिए.
हो गया, चलिए हो गया ना?
Yes ma'am, हो गया.
So the reason why we are talking of goiter is it is a very common problem that we all come across. Goiter, as it has been derived from a Greek word. Thyroid has been derived from a Greek word that is thyroides, and goiter has been derived from a Latin word that is gutur, which means throat. There are certain specific terminologies which have been used. One is swelling, which is a discrete swelling in an otherwise non-palpable abnormality in the gland elsewhere. There's a dominant nodule, which is a predominant swelling in an otherwise diseased gland. So these are the basic definitions that we always come across. I'll not be going into any detail. I'll just brush up and rush through the slides. The things that we need to examine and look for in every case of goiter is to evaluate the patient's endocrinological status, whether the patient is euthyroid or is having thyrotoxicosis. Why we are using the word thyrotoxicosis is because all patients who have thyrotoxicosis have, in addition to hyperthyroidism, features of adrenergic response as well. So there are other things, and insulin resistance. So there are multiple other endocrinal abnormalities which are involved, and that is why it is not just an excess of thyroid hormone that is responsible for the symptomatology, it is other things as well. Some patients with goiter can also have hypothyroidism. So these are the things that we need to examine. Besides that, we need to find out whether there is any evidence of compression symptoms on the surrounding structures, be it the trachea, be it the esophagus, be it the recurrent laryngeal nerve at times might be compressed, or there may be invasion of the trachea, invasion of the recurrent laryngeal nerve, or there may be evidence of metastasis. So these are the things that we need to examine. Now, coming to thyrotoxicosis, the classical symptomatology is an unintentional weight loss despite increased appetite. So that is a very specific feature of thyrotoxicosis that needs to be looked for. There can be increased perspiration because of an increased cutaneous blood flow. Patient might have heat intolerance, which is a classical symptom. There will be increased thirst, not only because of heat intolerance, but also because of resistance to the insulin. The patient might have menstrual disturbances or libido, anxiety, poor concentration, diarrhea, palpitations, hair loss, and sleep disturbances. So all these things can make a person's life topsy-turvy. There are certain specific signs of thyrotoxicosis. These are lid retraction, which classically have a staring look. There can be lid lag, which might be present. Patient might present with adrenergic response leading to fine tremors, which are classically seen on the tongue, or fine tremors seen on the hands. Patients might present with tachycardia, patient might present with ectopics, and later on they may even develop arrhythmias. Hypertension is classically present in these patients, and these patients tend to have a wide pulse pressure. There can be severe symptomatology later on as the disease progresses if left untreated, and that is a high cardiac output failure. And of course, there can be onchochirosis as well. The signs of thyrotoxicosis, in Graves' disease, we can find classical ophthalmopathy. We are all aware there can be lid lag, lid retraction, supravital or intravital swelling, conjunctival swelling, edema, proptosis, and exophthalmos. There can be infiltrative dermatopathy, which is classically described as pretibial myxedema. So many times people tend to get confused. Why talk of myxedema in thyrotoxicosis? Pretibial myxedema is a classical feature of thyrotoxicosis seen as an autonomic response. There can be musculoskeletal system involvement as well, and the proximal muscles are predominantly affected. And the patient might complain initially of exercise intolerance, increased fatigue, difficulty in completing tasks after 6 months of onset. Later on, if the disease is untreated, there may be worsening of symptoms leading to difficulty in swallowing and respiratory distress, ultimately leading to death of the patient. In all such patients, when these are evaluated for creatinine kinase, the levels are almost often found to be normal. There can be osteoporosis leading to pathological fractures, especially in elderly individuals. There can be other endocrinological symptoms. For example, females may present with oligomenorrhea or amenorrhea, infertility, DUB. Males might have gynecomastia, increased libido, infertilities, and so on and so forth. There can be glucose intolerance, which also might be responsible for increased thirst, besides the increased perspiration that leads to an increased thirst. So these are the things we need to look for in cases of thyrotoxicosis. There could be evidence of hypothyroidism. For example, a patient having dysharmonogenesis may present with hypothyroidism. So there may be increase in weight, there may be a slower response to normal things. The patient would be very scared of cold weather, would like to put on much more sweaters than the rest of the relatives per se. Patient might have hair loss, especially of the outer 1/3 of the eyebrows. There may be muscle fatigue, dryness of the skin, as well as constipation. So these are exactly opposite to those symptoms which we find in thyrotoxicosis. Now coming to the etiologies of euthyroid goiter. It could be a benign etiology, it could be a malignant etiology. Just to enumerate, it could be a colloid nodule, it could be a simple cyst, it could be a follicular adenoma, it could be a Hashimoto's disease, it could be dysharmonogenesis, and the classical syndrome that is quite often asked in PG interest is what is Pendred syndrome. So that is a bilateral sensory neural deficit associated with goiter and hypothyroidism. Malignancies, of course, differentiate carcinomas, anaplastic carcinomas, medullary carcinomas, lymphomas, and metastasis through the thyroid gland may also present with goiter. And these patients are having a euthyroid state. Now, as far as patients with hyperthyroidism are concerned, it could be because of George-Basidos phenomena or subacute thyroiditis or chronic lymphocytic thyroiditis, postpartum thyroiditis, just to complete the list. Multiple drugs, for example, even lithium might be involved. There could be struma ovari, there could be Graves' disease, there could be nodular goiter, there could be hyperfunctioning nodule. Now, coming to patients with hypothyroidism leading to goiter can be present in patients who are having endemic goiter, who are deprived of a proper nutrition, or it could be a physiological goiter. Hashimoto's disease classically has three phases. Initially, there is a presence of thyrotoxicosis. Then in between, the patient becomes euthyroid. And then later on, as the thyroid starts failing further, the patient becomes hypothyroid. Dysharmonogenetic goiter, it can present in myriads of ways. If it is a severe entity, it can present even in neonatal period. But classically, dysharmonogenic goiters usually present at puberty or before 30 years of age. And many a times, dysharmonogenic goiters do not have any symptomatology if adequate amount of iodine supplementation is done. Dysharmonogenic goiters are classically present in individuals who have history of consanguinity. Now, the reason I know I'm rushing through, but I can't help it. Therefore, it is very important for all of us to note what is the age of onset of the disease. If it occurred in the neonatal period associated with cretinism, it is likely to be dysharmonogenetic goiter, or maybe the patient's mother was treated with radioiodine ablation, as a consequence of which the patient also got affected in the intrauterine life. And the duration of symptomatology is also important. For example, if a person is having a prolonged multinodular goiter, secondary thyrotoxicosis, or follicular carcinoma thyroid can develop at a later stage. Dietary history is extremely important. For example, if a person is taking rock salt, which of course is very difficult to get nowadays, it was present in good olden days when people were not having iodine supplementation in the salt per se. There can be a certain diets like cabbage, cabbage, rape, etc., which are goitrogenic. There can be medications, for example, antithyroid drug medications or amiodarone or lithium. There can be history of drug intakes which might be affecting the thyroid hormone. There can be exposure to certain infections or irradiation, either as a consequence of a nuclear disaster, or maybe a person had undergone irradiation during early childhood because of lymphomas per se. If the patient is having a goiter, we should also ask whether the goiter is painful or painless. In certain cases of thyroiditis, or in patients with suppurative thyroiditis, in autoimmune thyroiditis, or even cases of certain suppurative thyroiditis, the goiter is usually painless, usually painful. Painless goiters, of course, might be present in later stages of Hashimoto's. Goiters can present with toxicity. Now, whether the toxicity appeared at the same time as the appearance of goiter, it is likely to be Graves. If there was development of toxicity in a pre-existing long-standing goiter, then it is likely to be a secondary toxic goiter. Patients might present, as I had already mentioned, needless to mention, patients might present with hypothyroidism depending upon the etiology per se. So a family history is of tremendous importance. Why family history is important? Why? Because it tells us about the diet the family is taking. There may be multiple individuals in the same family having goiter, which are non-dysharmonogenic goiters, which are non-neoplastic goiters, which are only because of ingestion of goitrogens that are being taken up, or because of rock salt which is being taken. There can be autoimmune endocrine diseases and multiple endocrine neoplasms associated with goiter. So these things need to be looked for. Now, whenever we come across a case of goiter, this table has been taken down from the latest edition of Love and Bailey. We have to find out the levels of TSH, T3, and T4. I don't think we need to mention it, but nevertheless, in euthyroid, everything is normal. In toxicity, TSH is undetectable, and T3 and T4 are high. In myxedema, it is TSH which is high, and T3 and T4 are low. So this is a child's play. Laboratory tests of medullary thyroid carcinoma will be taken up by Professor Sunil Chumbar. I think I need not go through it because we have paucity of time. Anti-thyroid autoantibodies also need to be evaluated. Antibodies against TPO, if they are more than 25 units per ml, or anti-thyroglobulin and titers having a ratio of 1:100. They are highly suggestive of lymphocytic autoimmune thyroiditis. The presence of antithyroglobulin antibodies interferes with the serum thyroglobulin levels, an implication for all follow-up, and therefore have an implication for follow-up of thyroid cancer. In Graves' disease, we can find TSH receptor antibodies. As far as imaging is concerned, the main thing that can be used for imaging the thyroid gland is ultrasound. CE, CT, and MRI are of little value. PET is of little value. Scanning, yes, can be done in selective cases. So ultrasound can identify the number of nodules, whether they are solid, whether they are solitary or multiple, whether the lesion is solid, cystic, or mixed solid cystic, whether there's a dominant nodule or there's an isolated nodule, whether the nodule is likely to be benign, because classically benign nodules are round in shape, homogeneous, slightly hypoechoic, and they are easily distinct from surrounding structures. They may have comet tail lucencies as well. Malignant nodules are classically irregular in shape. They are heterogeneous, markedly hypoechoic, poorly demarcated, and they have fine internal calcification and hypervascularity. Cysts, if they are benign, are thin-walled without any internal echoes. Mixed solid cystic lesions are indeterminate and are grouped with solid lesions for further evaluation. This is a table that I have taken out from the latest version of Sebastian textbook of surgery, and they have given this reference. So there is these features of microcalcification, hypoechogenicity, irregular margins, solidity of the tumors, intranodular vascularity, and the tumors being more taller than wide are having different levels of sensitivity and specificity. And that is why nowadays, for the last 2 decades, that is in 2011, thyroid's classification was being done by the Koreans as well as Americans. The latest version has been given by in 2017. That is too tough, too elaborate, not being very widely followed. So that is why I have skipped that. As I had already mentioned, CE, CT, and MRI are of little value. CE, CT can determine invasion of surrounding structures. MRI is superior to CT at determining the presence of prevertebral facial invasion. Isotope scanning can be done in selective cases. A technetium-99 is found to be more rapid, produces sharper imaging than iodine-123. The advantage of iodine-123 is that it has a more precise quantification regarding the uptake of iodine-131 prior to treatment, and it has a better bone penetration, especially if the goiter is substernal. As is already apparent in Graves' disease, there's a homogeneous radionuclide uptake, and in a heterogeneous uptake with 2 or more areas of increased nodularity. This is a classical feature of TNG or toxic nodular goiter. A solitary nodule will present as a high uptake spot. So, contrast administration, if it is being used, iodinated contrast administration, if it is being used, may interfere with further iodine-131 therapy, and that needs to be remembered. PET, of course, has limited value, can be done in selective cases, especially when the patient's thyroid does not take up iodine, and in that case, lesions might be picked up on PET-CT. As far as FNAC is concerned, there's a Bethesda system for reporting the malignancies per se. This is the classification that has been mentioned, that is Thai 1, Thai 2, Thai 3, Thai 4, Thai 5, and Thai 6. Can be easily used for cramming purposes. Pathologists always mention it on the FNACs. So Thai 4 means malignant, Thai 6 means malignant, Thai 4 means suspicious for malignancy. Thai 4 is follicular neoplasm, suspicious for follicular neoplasm. That means because follicular neoplasm you cannot detect on the basis of FNAC. For making the diagnosis of follicular neoplasm, we need to find evidence of capsular or vascular invasion, which cannot be done on FNAC, and that is but obvious. So from 4 to 5 to 6, these are the lesions which should be treated with special care. Regarding the treatment of choice, I just brushed up everything, just rushing through the slides because of paucity of time. And an important indication for thyroidectomy or any kind of thyroid surgery in a euthyroid benign thyroid disease is cosmetic involvement. That is, the patient doesn't want a swelling in front of the neck. So if the patient wants surgery, you cannot say no. Otherwise, if it is a benign colloid nodule, a small nodule, patient is not much concerned, you can ask him or her to keep herself or himself under follow-up. Simple cyst, if more than 4 centimeters, can be aspirated and observed. Repeat aspiration can be done at least twice. And if it is non-hemorrhagic, we can safely counsel the patient, keep him or her under follow-up. And usually they do not tend to fill. Follicular adenoma, of course, resection is necessary. At least a thyroid lobectomy needs to be performed to exclude the possibility of malignancy. Why? Because follicular adenomas cannot be differentiated from follicular carcinomas on FNAC, and so one should not put any person's life at risk. Multinodular goiter, of course, resection is done for compressive symptoms, dominant nodules of more than 5 centimeters, or when we are having a suspected dominant nodules. Chronic lymphocytic thyroiditis, resection for compressive symptoms, or if there is suspicious dominant nodule, that is the recommendation for surgery. Regarding thyrotoxicosis, medical treatment is initially the treatment that is started in all cases, and the treatment that is being used is propyl thyrouracil or carbimazole, etc. So these drugs can be given. They can be given in combination with beta blockers at times to palliate the symptoms of palpitations, especially if patient is having severe amount of palpitations or tremors. They can be taken care of with the addition of beta blockers. Of course, tremors are not as much taken care of. It is the palpitation which goes off with atenolol or propranolol. The efficacy of these anti-thyroid medications or thionamides is monitored by regular TFTs and clinical evaluations, and most patients are usually rendered euthyroid within 6 weeks of treatment, and virtually all patients are euthyroid by 3 months. So this is the initial treatment that is offered to a patient with thyrotoxicosis having goiter or goiter. So regarding preoperative treatment, if we are planning surgery in Graves' disease, of course, all of us are aware, a treatment of choice in United States of America is surgery. In Europe, of course, treatment of choice in United States of America is radioiodine ablation. Surgery is usually offered by the European nations. So I'll be talking of that. But if you are planning surgery in a patient having Bruin's disease, then we can give these patients glucose 3 to 5 drops TID, or we can give sodium iodide 2 to 3 drops TID 7 to 10 days prior to surgery to decrease the amount of vascularity. Now, this has become slightly controversial as many people are not using this inorganic iodine administration nowadays. As far as beta block alone is concerned, supplemented by inorganic iodine, this has not been found to be as effective. So it is anti-thyroid drugs which are definitely much more effective for preoperative control of symptomatology, and usually patients become asymptomatic or euthyroid by about 6 weeks of treatment. So if the patient can wait, give anti-thyroid medications prior to surgery rather than rushing through the preoperative treatment, because we may have thyroid crisis on the table or immediate postoperatively. So as I had already mentioned, in Graves' disease, radioiodine ablation is the definitive management of choice in United States of America. Approximately 60% of these patients become euthyroid within 6 to 8 weeks after a single oral dose of 5 to 15 microcurie, and nearly all remaining patients become euthyroid within 7 months. Surgical treatment is preferred for patients with Graves' disease who are having relative or absolute contraindications to radioiodine therapy, patients with compressive symptoms, and those patients having concurrent suspicion or indeterminate nodule. Even in these cases, it is surgery which is offered upfront. Anti-thyroid medications are usually reserved for patients who have limited life expectancy. So the fact is that now then, when I have talked of radioiodine ablation, now I'd like to come back to the contraindications. In cases of ophthalmopathy, that is severe or moderate ophthalmopathy, if we give radioiodine ablations, the symptoms might worsen. So that is a relative contraindication. Patients who are pregnant or lactating, this is an absolute contraindication to radioiodine ablation. Why? Because it can be iodine 131 crosses the placenta, and iodine 131 is also excreted in the milk, so the baby might be adversely affected. And therefore, women who are offered radioiodine ablation should be advised to defer pregnancy for 6 to 12 months after receiving the treatment for their thyroid disease. Radioiodine ablation is also contraindicated in patients who are allergic to iodine. So that is why I said surgery is reserved in United States of America for patients with Graves' disease who have absolute or relative contraindications to radioiodine ablation. And also for those patients who have compressive symptoms or who are having evidence of concurrent suspicious or indeterminate nodules, antithyroid medications practically have hardly any role, considered only in patients having limited life expectancy. As far as toxic nodular goiter is concerned, world over, the standard treatment of choice is thyroidectomy. Radioiodine ablation is usually not of much help. Why? Because the uptake is less uniform. There may be a need for a second dosage in majority of patients, and that is why we usually do not advise it. Antithyroid medications, as was true for Graves' disease, even in toxic nodular goiter, reserved especially for patients who have limited life expectancy. As regards toxic nodule is concerned, thyroidectomy is the treatment of choice. Radioiodine ablation is reserved only for very high surgical risk candidates or patients who refuse operation. ATM, of course, is the last resort. So that is all I wish to say. I rushed through the topic. I'm sorry, but because of paucity of time, I did not go into details. Over to you, Dr. Hassan and Dr. Malik.
Hello.
Yeah, sir.
It was a spectacular presentation. You have depicted so many things in a small presentation. It was really, really great. We would like to have questions later on because of paucity of time. I would like to request Professor Anand Misra from KGMU Lucknow to present his talk about the differentiated thyroid carcinoma. I welcome you all to this AMU CMU.
So may I interject? We have Professor Noor Topno from Meghalaya. And you're most welcome, sir. It's great to have you on board. The reason why I'm saying so is because our update is covering the entire length and breadth of a great nation from Jammu and Kashmir to Tamil Nadu. We have got faculty members, we have got delegates, and from Gujarat to Meghalaya, we have got wonderful faculty members, Professor Noor Topno being one of them. Welcome to our board, Professor Topno. All of you are great surgeons, great faculty members. Nice to see you here, sir. Over to you, Professor Mishra.
Good evening. Can you see my slides?
Yes.
My slide is visible?
Yes.
Okay. So good evening, everybody. And my sincere thanks to Dr. Atia for giving me this opportunity. I'm very happy to be part of this academic feast. I'll be speaking on differentiated thyroid cancer. I bring ratings from my university. So these cancers are less than 1%. They consist of less than 1% of all human cancers. And thyroid cancer is the most common endocrine malignancy. It is the most common cause of also death from any endocrine malignancy. Now, this is just a simple classification for the postgraduate. You can classify these neoplasms into benign and malignant. When the malignant cancers can be primary or secondary, there are 2 to 3 types of specific cells which are there in the thyroid: follicular cells, parafollicular cells, and lymphoid cells. So derivatives of the follicular cells are usually called as differentiated thyroid cancers, and they consist of papillary and follicular cancers, and less commonly a variant of follicular cancer, Hurther cells. The derivatives of parafollicular cells are medullary thyroid cancer. Now, some of these follicular cancers, they can get undifferentiated, or these cancers can get undifferentiated. They are anaplastic cancers. The derivatives from lymphoid cells are lymphoma. The secondary cancers can be from renal cell, from lung carcinoma, from breast cancer, or melanoma. So we have mainly derivatives from follicular and parafollicular cells. If I just tabulate all cancers although my job is to talk about the differentiated thyroid cancers, but just give you an idea, most of these differentiated thyroid cancers have mutations, and BRAF mutation is most commonly present in papillary cancers, RAS mutations most commonly present in follicular cancers, while in poorly differentiated cancer, it's a combination of BRAF and RAS. They also have T53 mutations and TART promoter mutations. Anaplastic cancers, they are totally undifferentiated, so they can have all types of mutations. While medullary cancers, we see usually red mutations. So for postgraduate, it's a very common question. What is the rate of carcinoma in a nodule? So it's in a single nodule, it is 5 to 17%, and in multinodular patients, it is 5 to 13%. But if I summarize, they should have remember this figure of magic figure of 5%. So any question answer to this question is rate of carcinoma in thyroid nodule is 5%. Now these patients do present, they can have varied presentation. These are the commonest presentation. We have been discussing, Dr. Atia was discussing about the goiter. So they can present as a goiter, nodule, mass, or heaviness in the lower part of neck. They can have associated lateral swelling, which is a lymph node swelling. These swellings may be associated with various compressive symptoms. I'm not going into the detail, and they can have voice changes or hoarseness of voice. Now, what are the symptoms which are suggestive of malignancy in a patient? So, if patient presents at extremes of ages, patient is a male, there is history of head neck radiation, there is family history of thyroid cancer, family history of endocrine MEN tumors, multiple endocrine neoplasia tumors, any patient who has hoarseness or recent change in voice, any patient who has rapid growth or short duration history, or there is a history of hemoptysis. These are the features which can suggest a malignancy. On physical examination in a patient who has a cervical lymphadenopathy, nodule is very firm or hard, it is restricted mobility or fixation, and in association there is vocal cord paralysis. Although very rarely we can see vocal cord paralysis in benign cases. Diagnosis has been already discussed, so all these patients need to undergo a triple test. So diagnosis involves anatomy, it can be solitary, it can be multinodular. Then these we have to see the functional aspect. Patient can be euthyroid, hypothyroid, or hyperthyroid. And then, so this was a workup nodule for the nodule, which has been already discussed. And depending on these triple tests, we ask investigations in these patients. So the most common investigation is a high resolution ultrasound followed by an FNAC, which should be a guided FNAC. We have to ask minimum a TSH, and further free T4 or serum calcium can be done. CT scan, neck is advisable, supremediastinum and chest, it is advisable when there is a lymphadenopathy. All patients in which we suspect the dysfunction of the vocal cords, they should undergo an ENT examination. MRI is rarely used. When you feel that there is cervical esophageal invasion, CT, it can be used, it should be used very frequently when you're operating a thyroid cancer. Now, thyroglobulin does not have any role in preoperative as a preoperative investigation, and calcitonin is indicated in selective cases when you suspect medullary thyroid cancer, or on FNAC it is suggestive of medullary thyroid cancer. In fact, CEA also, when you see a medullary thyroid cancer, CEA should be done. Ultrasound features for malignancy, Dr. Atia has already discussed. There are certain ultrasound features for lymph nodes which suggest malignancy in these lymph nodes, metastasis in these lymph nodes. You should remember when you're reading these ultrasound reports of these patients, the characters can be different in different modes of the ultrasound. B mode, it can be a destroyed architecture, capsule related. You can see some features on color, Doppler, you can see something on vascular resistance, something on the contrast, enhanced ultrasonography, and elastography. So these are the features which can suggest malignancy in ultrasound. Now, Bethesda system, Dr. Atia has explained you. So it is 6 categories, and malignant means 5th or 6th category. So now we have to understand a basic concept about the differentiated thyroid cancer. Now, if you see the survival rates, 10-year survival rates, in cancer we always talk of survival rates, overall survival. So 10-year survival rates is more than 98% in all patients. Now, if you see very long-term survival rates, 30-year survival rates, it is in excess of 90 to 95%. So bottom line is that this disease has low disease-specific mortality rate. Now, which are the patients which are going to die? We have to identify these patients. So risk of recurrent disease, if you see risk of recurrent disease in these patients at 20 to 30 year of follow-up, 20 to 30% at long-term follow-up, we see around 20 to 30% of patients do develop recurrent disease. And if you see in the next series, OU state cohort series, there was 25% recurrence. And if you see the various place of recurrences, it was in neck, lymph node, thyroid bed, or muscular trachea or distant recurrence. Now, last two lines you have to understand. Disease-specific mortality rate, 8% of local recurrence and 50% of distant metastasis. So only those patients are going to die which develop local recurrence and which are harboring or which develop distant recurrence. So any patient who is having local recurrence, that patient has more chances of dying from the thyroid cancer. So this is a cancer where risk of recurrence is linked to disease-specific survival, but it is usually true only in older patients. So that concept you have to remember from this slide. Now, when you start treating these patients, your goals of initial therapy are removal of primary disease, and if there are cervical lymph nodes, you have to remove it. We need to decrease the treatment-related morbidity. We want to stage the disease. And why we want to stage disease, I will be coming to that concept. Then once these patients are high risk, we need to give them adjuvant treatment. And there are two forms of adjuvant treatment. One is radioactive iodine and other is thyroid hormone suppression. Now, once treatment is complete, then we have to keep the patient under surveillance for disease recurrence. So these are the plans of therapy. Now, in thyroid cancer, since it is a rare cancer, so there are now no prospective randomized trials. So once there is no randomized trials, so we draw all decisions, all conclusions, all our things, literature is based on retrospective series. So because of these retrospective series, there are some controversies regarding extent of surgical resection. I will give you some clarity on this. When we should dissect these lymph node, what should be the extent of the lymph node dissection, when you should give radioiodine, it should not be given to all patients, what dose of radioactive iodine ablation or suppression of TSH, the role of post-operative radiotherapy. Some of these points I will be taking into controversy. Now, I told you it is uncommon. These are the reasons for the controversy. This is an uncommon cancer. Some of these cancers have indolent behavior, no controlled trial. We need a large number of patients for these randomized trials, and length of follow-up has to be very long. And this is not possible. So if you see what is the treatment, any patient who is harboring a differentiated cancer more than 4 centimeter, or if it is a smaller, any patient with gross extrathyroid extension or metastatic lymph node or distant metastasis, all these patients need to undergo a total thyroidectomy. If total thyroidectomy is not possible, it becomes near total thyroidectomy. Means we have to remove all primary tumor. Any patient who is having tumor less than 1 centimeter, it has to be lobectomy or hemithyroidectomy. Now, between 1 to 4 centimeter, without extrathyroid extension, without lymph node, means without any high-risk features, these patients can undergo either total thyroidectomy or lobectomy. This will depend on the surgeon's choice. This will depend on the region's choice. This will depend on the institution protocol. This will depend on your previous experience, your results, your institution results. Now, these are the different types of surgery. So hemithyroidectomy is lobe plus isthmus. Near total means Total thyroidectomy, you remove all gross tumor, and near total means you just leave 2 remnants of tissue where this parathyroids and then recurrent algia nerves near the various ligament. Now, there have been various arguments why you should do total, why you should do AMI. I kept this slide specifically for the postgraduates. When you do a total thyroidectomy, what are the advantages? You can use radioactive iodine. Thyroglobulin can be used in follow-up. You remove all microscopic foci, and which is there in papillary thyroid cancer up to 85%. There are no chances of recurrence in the opposite lobe. And I told you, the patients who will develop recurrence, they are going to die of cancer. It also eliminates the theoretical risk of de-differentiation. Then people believe that if you do a reoperative surgery, it has more chances of complications. Now, there are another set of people, clinicians who believe in the lesser than total thyroidectomy. They say that is a lesser complication procedure. The procedure also has a good prognosis, and it can be done with lesser experienced people. And I told you that if whatever surgery you do, 90% of patients in differentiated thyroid cancers, if they are not of high risk, if the type of surgery doesn't make any difference. Now, if it is a follicular or Hurthle cell cancer, because Hurthle cell and follicular cancer cannot be picked up on FNAC. So on FNAC, you would usually have, Atia has already stressed on this point, you will have a follicular neoplasm report or a Hurthle cell neoplasm report. So initial operation is hemithyroidectomy. Now, once you have operated, you receive the histopathology report, you have to read that histopathology report, whether it is a high-risk tumor or a low-risk tumor. High-risk means there are vascular invasions. And if it is minimally invasive tumor, then you can carry on with the hemithyroidectomy. It is a low-risk cancer. If it is a high-risk cancer, then you need to go back again and do a completion thyroidectomy. What are the patients in which you should do a central compartment dissection in papillary thyroid cancers? Because papillary thyroid cancers spread by lymphatic spread. So central compartment neck dissection is beneficial for accurate staging of disease. It assesses the risk of recurrence. It also determines the need for adjuvant postoperative radioactive iodine treatment. Now, all high-risk patients, you should do a central compartment dissection. If it is more than 4 centimeters, you should do a central compartment dissection. And this can be done safely, although there are more complications because parathyroids and these recurrent algial nerves are located in central compartment. So one has to have acquired this skill and then perform central compartment dissection. Now, there are certain arguments. Some people say that we should not do central compartment dissection because it produces more of complications, but you have to follow certain rules and then you decide about the central compartment dissection. There are definite rules. If it is large tumor, if it is extrathyroidal extension more than 4 centimeters, then you need to do. And if it is radiologically confirmed, lymph nodes are there. And during intraoperative, when you're operating, you see these large lymph nodes, then you need to do a central compartment dissection. Or regarding the lateral dissection, if it is clinically enlarged and proven on radiology, I showed you certain features on radiology. So if it is clinically enlarged by ultrasound, it is suspicious, and by FNAC, if it is positive, then you need to do a lateral neck dissection. And in thyroid cancer, lateral neck dissection is not a classical modified neck dissection in which you also do a level 1. It is level 2, 3, 4, and 5 level dissection. So 2, 3, 4, and 5. And in thyroid cancer, we divide this lateral neck and central compartment dissection. Then there can be metastasis to different sites, to lung, bone, brain, liver, and skin, soft tissue. Now, sometimes if these are surgically possible, you can remove these metastasis in differentiated thyroid cancer, then you should do a metastectomy. Because the post-operative radioactive iodine demand becomes less. Like this patient, she had a follicular cancer and then a mass in the scalp. So surgery was done, total thyroidectomy, and then this mass was removed and patient was treated with radioactive iodine. So that way the radioactive iodine demand decreases. Another patient, left side follicular cancer with the left lateral, you can see the clavicle swelling. So you remove this, you can do a total thyrectomy and then remove the up lateral half of the clavicle. Same way patient can present with paraparesis. They have vertebral mass metastasis. Then one should do a total thyrectomy and then stabilization of this, excision of this and then stabilization of this. Same way patient can have sternal metastasis. So remove this. So any patient differentiated thyroid cancer, total compartment. And once you do a central compartment, it should look like bare trachea and the two parathyroids, these by the cells, and then recurrent large nerve. It should be clear. Now, if recurrent large nerve is functioning in a differentiated thyroid cancer, you should always try to save it. And like in this case, you always suspect because there is a right side mass, and you always suspect that this right recurrent nerve will be enclosed, entrapped in the mass. So any functioning nerve, you should try to save. Same way, most of the time you can remove part of the trachea. If there's a tracheal invasion, you can remove part of the trachea and put a tracheostomy tube, or you can do the saving of the trachea, saving of the adventitia of the trachea. Now, once you have done the surgery, you receive the report, and then you need to do a post-operative staging in all these patients. And what are the purpose of post-operative staging? Purpose is prognostication. Purpose is to plan post-operative adjunctive therapy, two types of therapy, thyroid suppression, thyroid hormone suppression, radioiodine. You have to risk the patient for recurrence and mortality, and then you have to plan the frequency and intensity of follow-up. So any patient high risk, you need to closely follow up these patients. There have been various risk classification, but none of these risk classification are acceptable because they cannot cater all the patients. So ATA has classified these patients into three groups: low risk, intermediate risk, and high risk. High risk means patient has distant metastasis, patient has incomplete tumor resection, patient has macroscopic tumor invasion. Any low risk patient means there is no local or distant metastasis, all macroscopic tumor has been resected, no tumor invasion of local regional tissues or structures, no aggressive histology or vascular invasion. And accordingly, you can classify the low risk, intermediate risk, and high risk in papillary cancers or follicular cancers. This you can find, this table you can find on the ATA guidelines. So according to this, you give patient radioactive iodine. So all high risk patients need to get radioactive iodine. All intermediate risk patients need to get radioactive iodine. But low risk patient, you should not give radioactive iodine. Same way, TSH, any patient, now after that, you classify these patients on the low risk. So any patient who has excellent response. So, and that patient has no known risk for thyroid hormones. The patient is menopause, there is no tachycardia, no osteopenia, no age less than 60, or there is no osteoporosis. So these patients need not to be suppressed by the thyroid hormone. Any patient who comes into intermediate category, any patient in follow-up who has biochemical incomplete response, any patient who has a structural incomplete response, they need to be given suppressed by thyroid hormone. What is these responses? I'll be explaining you. So just a follow-up plan. You have done a surgery. Now you do a post-operative staging in all these patients depending on age, size, histology, resection, extrathyroidal invasion, and metastasis. Then you do a risk stratification, low, intermediate, and high. And then accordingly, you plan the adjuvant treatment and then categorize these patients. Excellent response means you have operated, you have done. Now patient is behaving in follow-up excellently. The TZ is not rising, no recurrence. There can be biochemical response or structural response means you have done everything, but there is structural recurrence. And there can be indeterminate response. And depending on these, you plan these patients follow-up. So any patient who was a low risk after surgery, that patient can behave as an intermediate risk or a high risk after 1 year because patient has developed metastasis, means that patient becomes a high risk case. Any patient who was high risk initially, means had aggressive histology, you operated that patient, given the complete treatment, radioactive iodine, TSS suppression. Now that patient has not developed any recurrence, that patient has not developed any distant metastasis, so that patient had become an excellent patient. So there is a concept of ongoing risk stratification, means you cannot label a patient once high, always high. So a high risk patient can be a low risk in the follow-up, a low risk patient can be a high risk patient, the high risk in the follow-up, and this is called ongoing risk stratification that you have to follow in these patients. So you judge these patients on depending on the clinical response, on the biochemical response during the follow-up, and in the biochemical you see TSS, thyroglobulin, TSS stimulated TZ, anti-TZ antibodies, and then structural. Structural response you can always see by the CT scan, MRI, ultrasound, and radioiodine. So this concept you have to understand, in breast thyroid cancer, there is now an ongoing risk stratification or delayed risk stratification. It means that you have to keep these patients under follow-up depending on the high risk, low risk of that time, but a patient of low risk can behave as a high risk later on in the follow-up or low risk. So this is just to give you an idea. You have done a surgery, depending on the age, size, histology, on all other features, you do a risk stratification, low, intermediate, high. You give radioiodine treatment or TSS suppression, and then on basis of response to therapy, you classify these patients excellent biochemical or structural response, and on this basis you you follow up these patients. So this table you can find in the ATA guidelines, depending on the details of this excellent response, biochemical response, structural incomplete response, and determinate response. So these are different definitions. Now there are certain prognostic factors at the bottom line which are associated with thyroid cancers. They are age, sex, at extremes of ages, they behave badly, male sex behave badly. Then there are certain tumor factors, size, type of histopathology, papillary, follicular, Hartel, or variant of papillary, nodal metastasis, age more than 55 years, there is local invasion or distant metastasis. And there are various management factors. Extent of surgery is very important in high risk case. Post-operative radioactive iodine, thyroid hormone suppressive treatment in high risk cases, and then delay in treatment or experience of surgeon. These all factors come into play when you're managing a thyroid cancer, and they become a prognostic factor in these cases. So if I just summarize a treatment, all patients need to undergo triple test, and depending on diagnosis, if it is AUS plus follicular neoplasm suspicious, the initial surgery is diagnostic lobectomy. Depending on the histopathology, if it is PTC, good quality, so and less than 1 centimeter, then you continue with your hemithyroidectomy. If it is high risk case, then you do a completion thyroidectomy. All patients in which diagnosis is confirmed, size is more than 4 centimeter or between 1 to 4, depending on it is follicular or papillary, you perform a total thyroidectomy. So total thyroidectomy you perform plus minus neck dissection. Adjuvant treatment is radioactive iodine scan or serum TZ, and then you follow these patients by radioactive iodine. There is no uptake. The patient is a good candidate, excellent response. If there is residual or metastatic, that becomes a high risk case, and then you give high dose ablations. So if I conclude, total thyroidectomy is choice of operation in all cases more than 4 centimeter, or DTC, which are between 1 to 4 centimeter. It depends on the local policies. Quality of initial surgery is the best predictor of outcome in these DTC. Majority of non-medullary DTC patients have an excellent long-term prognosis. It is important to target the occasional high-risk patient for more aggressive management. Post-operative risk assessment is the key for adjuvant treatment plan and follow-up. Thank you.
Thank you so much, Professor Anand Mishra, for a wonderful presentation. If there are any chairpersons want to ask a question.
Yeah, I am Dr. Kamal Kataria. I have one query. Good evening, sir.
Yeah.
I have one query. Do we need a diagnostic radioiodine scan in all cases where radioiodine is indicated?
You mean to say after surgery?
After surgery, post total thyroidectomy.
Yes, most of the places when it is more than 1 centimeter. And if it is aggressive variant of the PTC, if there are associated lymph node, if you suspect that it was going beyond capsule, patient is of more than 55 years, you should have a radioactive iodine. Otherwise, I will suggest that what you should do, what we do, we send these patients to consultation to our nuclear medicine colleague, and then we take a call. So it is usually not an individual call, it is MTT call, but then in high risk patient, you should do a radioactive iodine, because what happens? The metastatic tissue, the thyroid tissue, original thyroid tissue has 30 to 40 times more iodine avidity, means liking for iodine, than the metastatic tissue. So unless you have done a total thyroidectomy in the neck, it is clear. Then only the iodine will go to the peripheral sites, mean metastatic site. Now, if there is still some tissue is left in the neck, so all iodine, whatever you are giving, 5 microcurie, it will go to the neck only. So in all high risk cases, you should do. Because there are incidences when we thought that there is if this patient will not have metastasis, and once you do a post-operative radioiodine check scan, and then suddenly we find that there are something in the lung or bone.
Thank you. Okay. Thank you, Professor Anand. I think we should move on and ask thank you so much. Let us ask Professor Sunil Chambar from the All India Institute of Medical Sciences to give his talk on medullary carcinoma of the thyroid gland. Dr. Sunil. I hope Dr. Sunil Chambar is there for his presentation.
I'll just inquire. I'm trying to contact the Vision Plus.
Yes, he's there. I have talked to him. He's there.
Yeah, we can see him, but
Shiji, wo chumba.
Professor Ejaz, if you have any comments to make before Professor Sunil Chambar joins us.
Yes, thank you very much. It has been really a very good time on this show. It's not that easy to get all the people on the same platform what Professor Athiya has done. And I welcome all from the paradise of earth, that's Kashmir. And I would request all to visit Kashmir this year. In fact, there has been an endeavor from our department also to do some CMEs. We have done local CMEs here in our state between medical colleges and institute and Jammu. They have also proved very successful. I think it is there should be a continuous endeavor of every person, every professional, whosoever is working in whichever hospital in these COVID times to create and continue the academic atmosphere, which is very important for the health of the surgeons as well.
Thank you so much, sir. Professor Athiya, Professor Chambar available, or should we move on to the next speaker?
I really don't know.
Yes, I am here at the moment.
Sir has joined.
Yeah, but I am not able to start the video from here.
Sir, please share your slides, sir. Sir, please share your slides, sir. I send a request. Please grant permission, sir.
Yeah, yes, done that.
Sir, are you using the Zoom link, sir, which I have?
Yes, I am using the Zoom link.
No, it's available now.
Sir, your screen is shared. Please open your presentation, sir.
Yeah, now we can see your presentation, sir. You can start.
Yes, sir. Please start. Sir.
Can you see that?
Yeah, we can see it very clearly.
Okay, I'm sorry for the glitch, and good evening and welcome to all of you. And I must thank the organizers for giving me this opportunity to be here with you and share with you our own experiences and our own understanding of medullary thyroid cancers. And after the presentation by Anand, I think I will have a difficult time measuring up to him in the treatment of this particular cancer. Okay, I'm not able to go on with this. Okay, now this is overall, it cannot be considered as a very old carcinoma. It was identified only in the 1960s by Hazard, and over the next 2 decades, it got finally identified as a neuroendocrine tumor, which produces calcitonin and has a link with multiple endocrine neoplasia, and is also associated with the C-cell hyperplasia in familial tumors. Now, as I said before, it was identified as a distinct tumor, and now our understanding of this tumor has further improved. It arises from parafollicular cells, or what are called as the C cells of the thyroid, which produce calcitonin and which are a part of the group of cells which arise from the ultimobranchial body, the so-called, apodomas, or amine precursor uptake and decarboxylation cells. It is only in the last 20 years that we are looking at them as of neuroendocrine origin rather than of endocrine origin. And that is why they have gone out of the loop, which Anand mentioned, of differentiated carcinomas. Medullary cancers have a strong relationship with multiple endocrine neoplasia. In multiple endocrine neoplasia type 2, there is a high risk of medullary thyroid cancer. It is linked through a germline mutation in what is called as the RET proto-oncogene. And it has 3 subtypes seen in men 2A, familial medullary thyroid cancer, and men 2B. Men 2A are inherited as an autosomal dominant manner. And in this, the offspring of affected individuals have almost a 50% chance of inheriting the gene mutation. So there is a greater stress on DNA-based testing of the RET gene, which will identify the disease-causing mutation in these patients. The molecular genetics of multiple endocrine neoplasia has become important in recent times. And we learn that it is on the chromosome 10 that the RET gene is located and which undergoes a mutation. And this is identified in almost 95% of families with men 2A and about 85% of families with familial medullary cancer. There is a strong relationship of the functional aspects of RET mutations and genotype-phenotype correlation. That means the stronger the mutation, and it gives rise to greater the clinical manifestations. In recent times, genetic testing in men has become very important. This helps to identify the at-risk family members, and at-risk family members include first-degree relatives. That is, this would be the parents, siblings, and children of a person known to have MEN2. And testing is done for identification of people with asymptomatic MEN2 who can be offered prophylactic treatment, especially thyroidectomy, as a preventive measure. Also ensuring long-term survival in these patients. Now, medullary thyroid cancers have a very characteristic tumor marker, and in fact, in medicine, this is rated as an ideal tumor marker. And this is calcitonin, which is very specific and very sensitive for this tumor. This may be abnormal, elevated and abnormal long before any imaging techniques can locate the tumor cells. Provocative testing has also been mentioned, stimulated by calcium or by pentagastrin infusion to look for calcitonin in these patients. Sometimes there may be sources of error, especially in patients with lung or breast carcinoma. MTC and other tumor markers we find in these tumors, you can have as many as 100 hormones or peptides related to medullary cancer. However, over a period of time, we have realized that it is calcitonin and CEA, which are commonly elevated and have become strong markers also used in prognosticating such patients. Sometimes we will observe ectopic ACTH secretion in these patients, giving rise to Cushing syndrome. Provocative testing I have mentioned earlier by infusion of calcium or pentagastrin test is carried out in patients for family screening. Now, the interpretation of this test is simple. High calcitonin is related to medullary thyroid cancer. And pentagastrin test is used in patients who may have cancers which are very small in size or who just harbor C-cell hyperplasia. Most of these patients have no symptoms related to calcitonin, as no bone disturbance or clinical symptom is cited for this. And there are no other specific features for medullary thyroid cancers. The clinical presentation is in two forms, in sporadic form and in the familial form. Symptoms are related to the tumor and not to the hormones. In the sporadic form, which is seen in about 80% of all patients of medullary thyroid cancer, typically you have a unilateral disease, not associated with disease in any other endocrine glands. The peak onset is in between the 40 to 60 years of age, and it is more common in females as compared to males. Commonly, we see a thyroid nodule may have local invasion with metastasis to lymph node and distant metastasis. Rarely, you may actually have intractable diarrhea in these patients, which may be related to secretion of certain hormones, especially VIP. MTC and multiple endocrine neoplasia type 2 or Sippel syndrome, in which case we may observe bilateral medullary carcinoma or C-cell hyperplasia, presence of pheochromocytoma and hyperparathyroidism. Usually males and females are affected equally, and the peak incidence of MTC is seen in younger patients in their 30s. Commonly, it's a multicentric disease in the familial form. In MEN 2B syndrome, we see medullary carcinoma with pheochromocytoma, rarely with hyperparathyroidism. Most of these patients also have an unusual appearance. They may have mucosal ganglioneromas in the mouth. They have a marfanoid habitus, unusually tall people. And the disease occurs in younger people. It is seen as commonly in males as females. Pheochromocytoma in all these settings must be looked for and detected earlier and operated first before any further treatment is offered for the medullary thyroid cancer. In familial inherited medullary carcinoma, it is said that these are least aggressive of all tumors. However, the peak age is seen between the 40s and the 50s. For purposes of diagnostic evaluation, ultrasound has superseded all other investigative modalities, and we generally find a hypoechogenic nodule. And as has already been discussed, the thyroid grading of these tumors on radiology, that those that fall in the grade of 3, 4, and 5 are the ones that are more likely to have a carcinoma. However, I think even before you reach that particular point, and if you have performed a fine needle aspiration cytology, which if it is seen by a good pathologist, who will often find the presence of a myeloid in some of these slides. And on immunohistochemistry, when tested for various stains, you will be able to characterize a medullary carcinoma of thyroid. So FNAC now plays a greater role in diagnostics of MTC. Other methods of evaluation, especially CT and contrast MRI, of liver or bone scintigraphy, they are required only for purposes of staging or in presence of extensive neck nodes or when there are signs and symptoms of regional or distant metastasis. Usually, most patients would have extremely high elevated levels of calcitonin. Functional imaging as FDG PET and others, we are not recommending it as a routine investigation. Now, for all our patients, we form a serum calcitonin levels, and the basal calcitonin is unusually elevated. And this may be present even before the tumor is localized, that we find in patients whom we are screening. Now, we have really not performed a provocative testing in any of our patients. And those families that we have on our follow-up of multiple endocrine neoplasia, we have been able to pick up even before the provocative testing. However, sometimes the CEA is elevated in some patients of MTC, and both calcitonin and CEA will become markers for follow-up in these patients. Now, I have already mentioned pentagrastin provocative testing. However, I must emphasize again in familial screening, almost all new patients should be screened for RET mutation. Now, a word about the histology of these tumors. The tumors are variable in size, and their classical site is that they are located in the middle of the thyroid or in the superior third of the thyroid. And this would correspond with the common location of C cells during embryogenesis and in later life. Lymph node involvement is very frequent, and it represents a prognostic factor as well. Now, neoplastic cells, they are round or polyhedral cells. They are not very different from other neuroendocrine cells, and they have a myeloid substance which is identified. I think the modern pathologist will give you most of the diagnostics through the immunohistochemistry. When you see this in the familial form, bilateral and multifocal disease is more common. C-cell hyperplasia means that the pathologist has to spend a long time to identify this, and it would be present in patients who have undergone screening and prophylactic thyroidectomy. Now, the tumor has found a place in the ATA guidelines, and it has a new chapter devoted only to medullary thyroid carcinoma, and tumor mutation has been included as a prognostic factor. And among the prognostic other factors, we have calcitonin and CEA, which is now identified and a part of the staging process. Definition of regional lymph nodes is also present here. However, the staging of the rest of the tumor is no different than that for the other differentiated tumors. Now, what is the treatment we offer to our patients? Surgery remains the first and the most efficient treatment, and it has been there for the last 40 years. And what we do is a total thyroidectomy with a central compartment lymph node dissection done on both the sides. Many surgeons have advocated a prophylactic ipsilateral lymph node dissection if tumor is more than 1.5 centimeter. But I think nowadays almost all the surgeons would do a bilateral central lymph node dissection. Ipsilateral or bilateral modified neck dissections is performed depending on the status of the central or lateral lymph nodes if they are present. Now, prophylactic total thyroidectomy is performed for those patients in whom RET mutation testing has been done, and it is advised before 6 years in patients with MEN2A and before 1 year in MEN2B patients. Central lymph node dissection in children is avoided because they often need their lymph nodes to face the unusual infections of childhood. Otherwise, they are often RET positive but calcitonin negative. Prophylactic neck dissections are indicated for those with high calcitonin or those who have an ultrasound positive disease. Frequently, it may actually happen that you have performed a hemithyroidectomy in a patient with a thyroid nodule, and you have got a surprising diagnosis of medullary carcinoma thyroid. I hope it is not a usual situation with you, but in this particular setting, imaging studies should be performed to look for residual disease, and if there is a postoperative calcitonin levels are present, then completion thyroidectomy is advised. Now, there are other modalities of treatment, but however, they are by and large remain unsatisfactory. MTC is resistant to chemotherapy as well as radiation. There seems to be no role of suppression by thyroxine. Radioiodine has no influence on these cells. These are not follicular cells. Post-operative radiotherapy may be the only situation, that only mode of treatment that you can employ. In chemotherapy, we have tried almost a lot of drugs. However, the response rates are disappointing, as well as the other modalities like interferon and octreotide. We follow up these patients by serial calcitonin levels as well as CA levels, and this seems to be a better prognostic indicator. Elevated calcitonin levels after lymph node dissection means that there is residual disease which will require your attention at a later time. You may need to do a sternotomy to eradicate this particular disease. Reinterventions, that means repeated operations for lymph node ablation, rarely lead to a complete cure. However, a word of caution, don't try to normalize the calcitonin in patients, which many surgeons try to chase. I have mentioned adjuvant treatment earlier, and external beam radiotherapy is probably the only thing which is indicated in patients who may have microscopic or macroscopic disease, or who have extrathyroidal extensive lymph nodes, or who are at risk for airway obstruction. Now, this is, we have to face up to the fact that our patients, in our country at least, they have persistent or increasing levels of calcitonin in the post-op period. Frequently, the disease gets localized in the neck and mediastinum, in which case it is best to offer surgical removal when it is localized or even in diffuse disease. But however, the calcitonin levels should be high. 50, below 30 to 50 is very low to look for and repeatedly go on doing surgery in these patients. Only rarely would you need to do a selective catheterization to find out the location of the persistent myths. Now, overall, it seems to have an indolent course. It is not as good as what Anand said. The 5-year and 10-year survival rates are only 80% and 60%. The clinical form, the extent of disease, age and sex of patient, local extension, as well as distant metastasis, these factors determine the overall prognosis. Younger patients and women seem to fare better. The older patients do poorly. Prophylactic surgery is indicated in patients with RET oncogene mutation, and prophylactic surgery does improve the survival in all the carriers. Let me end by saying a few things. MTC is a rare thyroid cancer. It needs special attention. There is a strong association for MTC and men. They are not synonymous, but they are strongly related. If there is a preoperative diagnosis, total thyroidectomy with lymph node dissection, that's what we advocate world over. Family screening should be performed for RET mutations in all patients. Treatment of recurrence remains challenging and is really ineffective. So for those students who rarely come across this tumor and rarely read about it, because all of them are interested in differentiated carcinoma, it's a very challenging disease, and MTC, calcitonin producing tumors from C cells. About 4% of all thyroid cancers, that's what it is. It's about 70% is our sporadic tumors, and about 50% are familial. From the beginning of my slide till now, the demographics seem to have changed here. That's because the beginning was made a long time back. MTC is associated with multiple endocrine neoplasia. So you have screening of individuals at risk for RET proto-oncogenes. There is a role of provocative testing, and treatment for MTC remains surgical, and surgical treatment is the most successful. Now, these are the usual references that I will bring to you. However, we have added something of our own experience to this. Now, let me take this opportunity to thank the organizers who have allowed me to be here to present to you our experience as well as our understanding of this. Thank you so much, and I must specifically thank Dr. Professor Atya, who has invited me for this. Thank you, madam.
Thank you, sir. Indeed, it's a pleasure and a great honor to have you with us. We are blessed to have you around. Thank you for all your guidance and support. Because of paucity of time, we'll have to do away with the question and answer session.
Okay, thank you.
More academic interactions in future. With your permission, Professor Ajaz, may I request Professor Abhay Dalvi to take on the...
Yes, sure. Yes, sure.
Can we
Professor Abhay Dalvi from KEM Mumbai to present a talk on surgery of adrenal glands and paraganglionoma.
Yes. We would like to inform the audience that Professor Abhay Dalvi is, of course, the president of the Association of Surgeons of India and a renowned person. We are really honored to have him with us. And he has a lot of work on paragangliomas. So therefore, he'll give a talk on the management of pheochromocytoma and paragangliomas. He'll give an overview. So we welcome you, Professor Abhay Dalvi.
Thank you so much. First and foremost, thank you, Aligarh Muslim University, particularly Professor Atya, having found amongst all for me to be delivering lecture on surgery for adrenal tumors and paraganglioma. I will be a little different from the previous speakers, and I'll keep it absolutely simple from the surgeon's point of view. Let's look at adrenal tumors. They could be functional, where there is hypersecretion of hormones. The medulla secretes noradrenaline and adrenaline, giving rise to pheochromocytomas. The cortex can secrete cortisol, giving rise to Cushing's, either bilateral or unilateral. For bilateral, pituitary is usually the cause. It can secrete aldosterone, giving rise to Conn's disease. There are others also, rarer tumors, which secrete testosterone and excessive female hormones. The second group of adrenal tumors is non-functional with normal hormonal values. These are often termed collectively as incidentalomas, and one of the commonest incidentaloma that comes for surgical interventions is angiomyolipoma. Overtly malignancy or imaging also are the part of tumors that come to a surgeon. Paragangliomas, almost always functional. They are grouped under pheochromocytomas. They can be present anywhere along the neuroendocrine axis, which I will talk about later. And the commonest site is angle of Zucker-Candle, which also I shall deal with a little later. Remember one thing, colleagues and friends, especially the PGs and young surgeons who want to embark on the journey of surgery on any hormone-producing endocrine organ. It is the endocrinologist who is actually the ringmaster. He or she should be investigating all the patient, prepare the patient for surgery, and then give it on platter to the surgeon so that surgeon can do a good job. If the endocrine organ is uncontrolled and the surgeon puts his knife, there can be a complete disaster, whether it is thyroid or it is adrenal gland. Investigations which are of importance to surgeon as far as adrenal is concerned is adrenal protocol CECT scan. What does it mean and how does it differ from a routine scan? You have 4 phases that are taken: the plain phase, early arterial phase, late arterial phase, and a venous phase. These help you differentiate from pheochromocytoma and other tumors, as well as malignancy and other tumors. The other investigation that is often coupled nowadays and used to be the investigation of choice in the past is MRI. Particularly since initial topic given to me was pheochromocytoma. Pheochromocytoma appears like what is known as a light bulb or a very bright spot in the region of the adrenal, suggesting to you that this is a hormone secreting or norepinephrine secreting tumor. Why do you investigate and why do you image such a patient? One should know what is the location and size, its relation to the adjacent structures and fat planes, whether they are destroyed or no, indicating that it may be overtly malignant. Especially on the right side, the adrenal tumors tend to go behind the inferior vena cava and the surgeon will have to plan things. Pheochromocytoma are extremely vascular. There are neoveins, larger veins and engorged arteries, and normal instrumentation that is used like harmonic scalpel actually may not work. Carcinomas, we have to see whether they are infiltrating types or they are just pushed the larger veins on. And Cushing's, remember, there is abundance of periadrenal adipose tissue and can become extremely difficult to identify a normal or normal looking adrenal gland inside this pad of fat. The 10 commandments in adrenal surgery are simple. Number 1, you should have knowledge of anatomy, especially the surrounding organs. Endocrinologist, as I said, is the captain and we are just carpenters. We will be doing things what has been told to us. Reading and imaging and optimization of hormone secreting patients. Position of the patient, port placements and ergonomics are extremely important. Good vision and role of camera person is often underestimated. You should also prepare yourself with optimal energy sources. Dissection for safe surrounding, role of assistant becomes extremely important. The target is usually the adrenal vein. Staying away from the gland, dissect the body away from the tumor rather than dissecting the tumor away from the body. This is a sentence which was said by one of the greatest as far as minimal access surgery is concerned, particularly the endocrine organs, Michel Gagnère, originally from Canada, New York, then Saudi Arabia, Dubai, etc., etc. And retrieval. If you read literature on adrenal tumor retrieval, there is hardly anything that is said. Of course, remember, if you are operating a pheochromocytoma, it has to be intact because it is the invasion of the capsule by the pathologist which determines whether this is going to be malignant or no. Nothing is more important than the camera person and the assistant. Role of camera assistant is extremely vital. The other assistants are also part of the team. And if they work in tandem with the surgeon, it allows the surgeon to focus on crucial elements of an operation. And this provides safety and efficacy of the patient. While surgeon takes the credit, the role of anesthetist, particularly in pheochromocytoma, is underestimated by every surgeon. Adrenals are deep-seated, small in size and surrounded by fat. The right side is surrounded by the liver, kidney, duodenum, hepatic flexure, and the IVC, whereas the left is surrounded by the diaphragm, spleen, pancreas, kidney, left renal vein, and even the aorta. It is important to avoid these structures when you're doing surgery on adrenal gland. For benefit of the PGs who are listening, adrenals, I have a curious arterial supply. It is supplied by multiple small arteries directly arising from the aorta, which should tell you anatomically that if you clear the medial aspect of the gland early in the dissection, you have actually devascularized the adrenal gland and not much bleeding is going to occur. Again, God has been great. The right side as well as the left side has a single adrenal vein. The right side is a short stubby vein which empties into the posterolateral aspect of the IVC, whereas the left one directly drains into the left renal vein. Please see here that there is an inferiorant vein on the left side which joins the adrenal vein and which could be spared if at all dissection is more meticulous. There are three approaches which have been described in literature: transperitoneal approach, the retroperitoneal approach, and transmesocolic approach. I'll finish off transmesocolic straight away because it is limited to the left adrenal gland and was described by one Dr. Lejose. It saves time, that's what he says. But in obese patients, the location can be really, really difficult. Let's talk of transperitoneal adrenalectomy, which we performed routinely since 2001. And we've reached a total figure of 427 till date. We give lateral position to the patient, target the adrenal gland, adrenal vein, and dissect, as I said, the patient away from the tumor rather than trying to handle the tumor. And this is the position which helps keep away all the surrounding organs before and as well as after the dissection. Port placement is extremely important. The telescope comes somewhere in the midclavicular line, just above and to the left of the umbilicus. The right hand working port is almost perpendicular to the adrenal vein, whereas the left hand goes perpendicular to the adrenal vein. Right is in the direction of the adrenal vein, and the last one in the anterior-axillary line is nothing but assistant, who can be extremely important, as you will see. This is the left side, and this is a very short video that I'm going to run through. So the first step after putting in the ports is to separate out the splenopancreatic tissue from the adrenal tumor. Now this is fairly large tumor that you can see here. This was one of the cases that I had demonstrated in the workshop. The dissection goes way up, right up to the upper pole of the spleen, so much so that sometimes you expose. This is a video now which is showing that this is the splenic vein here, which I have identified. This is it. And if you know your anatomy properly, the splenic vein and the renal vein are quite close to each other. So the splenic vein becomes an indicator to where the adrenal vein is likely to be. So that's the splenic artery, that's the splenic vein, and here comes just around the splenic vein, the adrenal vein can be identified. Remember, if at all the tumor is arising from the lower pole of the adrenal gland, it can be really tricky because the renal vein comes too close to the adrenal tumor. Now that's where I'm trying to dissect the vein, and I can see the vein out here. This is the renal vein, and the adrenal vein is now being dissected. What is even more important in this video is not what I am doing, how the camera person is showing, but even this assistant who is holding the suction in his hand is retracting and giving me adequate time. I have to take out. Somebody is disturbing. Anyway, the role of the assistant here also is to dissect the adrenal vein completely. Now that the adrenal vein is done, I am ready to clip it. It's very important to clip the specimen side first rather than go ahead and do the patient side first, for simple reason that if your arterial devascularization is incomplete, the vein is going to get engorged, and that's going to give you a lot of trouble. So 2 clips on the patient side after the specimen side, and the vein is divided. Once the vein is divided, the dissection is almost over. All you got to do is stay in the peri-tumor. You can see here I have identified the lower end of the adrenal normal adrenal gland, and I'm going into the fat and nothing else. Once you go into the fat and start dissecting, this sort of retraction which has been given to me by the assistant is making my life very, very easy. Here we have reached the retroperitoneum. This is the aorta out here, and the dissection proceeds. Sometimes in a pheochromocytoma, you have what is known as a desmoplastic reaction, which swells up the adipose tissue in and around the adrenal gland, and the dissection can become difficult. I'll fast forward a little, and I'm almost through the adrenalectomy. This is the retroperitoneum that is exposed. There's hardly any bleeding that has occurred, and the dissection is almost complete. So once the dissection is over, you retrieve it obviously in the bag, and you have to take an incision. In our center, we make it a point to take a small fan and steel incision to deliver these tumors, because fan and steel incisions are less painful as compared to any other. The right side is similar. The telescopic port now comes to the right of the patient, and left and the right hand. There is additional port that is required to retract the liver, which will be self-explanatory when I show this. This is another tumor, right side, a fairly large tumor.
A large tumor with calcistrate.
There is a voiceover out here.
The dissection starts just lateral, along the lateral border of the IVC.
I think I should keep on talking. The dissection starts around the lateral border of the IVC, and peritoneum is...
As you reach the upper border of the IVC and the inferior border of the liver, the dissection turns around and goes along the peritoneum right up to the
So I'm trying to contact the personnel to remove voiceover.
He may not be able to do it.
Voiceover. And now we reach the right triangle. This is the adrenal gland which is located from which the tumor is arising. The dissection goes further and further to the triangular ligament. Once the triangular ligament is reached, obviously the liver starts to become more supple and can be retracted even further, as you see here. This allows me to retract the tumor inferiorly and go to the upper border of the tumor separately from the liver. Usually only areolar tissue is allowed here, which can be easily taken even with a monopolar cone. There is no problem with that. Now we come to the superior aspect of the dissection, where the vein is being identified. It is surrounded by some loose areolar tissue which is being taken. Once you take that and the vein IVC junction was large, this is a CT scan showing a large, the tumor is seen. Any tissue in the dissection.
I'm sorry for this. I will try and override this voice, but I may not be able to do it. I think this voiceover should be good enough.
IVC junction is seen. It is the left hand which comes handy in dissecting the vein off from the tumor going into the IVC. Many times there is some amount of tissue superior to the vein which can come in the way of clipping, and then the vein can elongate in the vein of death. The medial aspect of the tumor is seen. Any tissue is coagulated. This is the area of lesion vessels which has been identified on the CT scan, which is being dissected. Once I'm satisfied with the dissection, we use clip to take care of the vessel, and harmonic is more than sufficient to separate the vessel from the clipped area. Once that is done, the dissection separates the IVC from the tumor. As we go higher up, there is a IVC extension of the tumor which has to be taken care of, and that's why left-handed retraction and right hand to separate the entire tumor. The trick here is to get to the retroperitoneum as fast as possible and lift the gland away from the IVC to take the tissue which separates or rather binds the tumor along with the retroperitoneum. This is being slowly but surely taken, and now retraction is becoming difficult in the IVC. The vein can get avulsed, so we have clipped the specimen side first and then the patient side The patients had obviously and then for here we have used a harmonic scalpel. This now separates the entire gland. The retro IVC part of the gland is now separated. There is some amount of desmoplastic reaction, thereby making dissection a little difficult. It can be that first there can be a bleeder or artery supply which can come from above. So I have packed it with gospels and the dissection proceeds up to a point where I am in complete control in case bleeding starts. So this that is required to be done is separate the tumor remaining in the periadrenal fat tissue to completely separate the tumor from the rest of the body. As Michel Gagner has said, you separate the body from the tumor rather than separating the tumor from the body, and this is exactly what is being done. Lateral dissection comes almost last so that the thing actually hangs from the lateral border, and it's only the lateral peritoneum that has to be taken to completely free the tumor from the patient's body. That's exactly completion of the tumor. The tumor is wobbling nicely, freely. It is bagged in an indigenous retrieval bag, and this is the size of the specimen, which is 11 centimeter.
So friends, I'm sorry for the voiceover. This was a video which was sent to the sages for this, and that's why there is a voiceover out here. I thought it's one of the best videos. Anyway, doing adrenal surgery has its own problems. Remember, here I think I have already clipped the adrenal vein and I'm going ahead and there is bleeding. Now, this sort of a bleeding that occurs from the IVC is not easy to control unless you got a good team. I've taken suction in the left hand and I have held that bleeder with a harmonic, but I got to change because I got to use a clip applicator. You will see that the camera person is absolutely steady. I've taken now the suction in the right hand. I am partially in control, and that's actually the adrenal vein which requires to be clipping. So a good team effort is good, as I said. Now we have got initially one publication where we said graded approach, where we started off with normal vascular glands, small size glands, and slowly went on to do a pheochromocytoma and larger tumors. Then we published in Indian Journal of Surgery, and lately we also published in Journal of Minimal Access Surgery. More publications are in the offing. Of course, as we became good in transperitoneal approach, retroperitoneal approach was coming in, and we visited Martin Walls, who is a pioneer in retroperitoneal approach. We have at present very limited experience. We know that we are going for smaller tumors first. We feel right is easier than left, but it requires even better team and discipline. We are still struggling, and this is the last one I did last week. We are slow, cautious, but we will never walk backwards because we have to master this technique of retroperitoneal adrenalectomy as well. We have already started with a disaster in one. This is the right side adrenalectomy that I'm trying to do. You can see the vein here, and like a fool, I have not yet clipped it. Now, what has happened is, while trying to dissect further and further, the traction on the vein has started to increase. And here it is almost ready to get evals from the vein. Still, like I do on transperitoneal side, I try to dissect the vein completely in the retroperitoneal side, which is exactly wrong. And now what has happened is, when I'm about to try to clip it, I realize that the whole vein has evulsed out, and this is the IVC which is bleeding. The first thing, luckily, we had learned in Germany was, if at all this happens, raise the pressure to 20 to 25 so that bleeding is minimum. Do not be afraid of carbon dioxide embolism. It really doesn't work. Now I have managed to hold it, and I will go ahead, suck out the blood, and ultimately clip the whole thing successfully. God forbid if this had completely evulsed from the IVC, I don't think there was any other option in front of me but to open up the patient. So you have to be very careful and be prepared for everything that can happen. Paragangliomas are nothing but sympathetic or parasympathetic. The sympathetic ones are the one which we are talking about surgically, which require removal because they again secrete epinephrine and norepinephrine. That's why clubbed under pheochromocytomas. We have done 52 of them. As I said, the commonest site is organ of Zuckerkandl, where it's the junction between the aorta and the common iliac. However, some other define it in different other places. They are in different locations, and planning adequately after seeing CT is important. Again, most of the times these are located in areas where the ureter is the immediate posterior structure which has to be identified and not injured. Port placements will differ according to the situation. No definite vascular pattern, but these are extremely hypervascular and can bleed. All arteries necessarily arise from the aorta. This also video has a voiceover, again presented at SAGES. You can see here, this is the paraganglioma, this is the aorta. So it is almost sitting next to the aorta. And obviously you will also see some part of the intestines, which is very, very near the duodenojejunal junction. So this is again, I'll go.
From the endocrine department in view of paraganglioma, CT was suggested of a paraduodenal paraganglioma. After goes for this procedure.
That's the paraganglioma.
Small bowel loops were retracted away from the tumor to prevent thermal injury to the small bowel. Dissection was begun medially by lifting the peritoneum of the tumor. It needs to be remembered at all times when dissecting this tumor that the tumor should not be handled by itself. Peritumoral peritoneum should be gently lifted up and then dissection continued. Paragangliomas, like pheochromocytomas, are very vascular tissues, and therefore hemostasis is of utmost importance in these procedures. Excessive handling of the tumor or any bleed from its vessels can cause hypertension on table. As dissection is continued, gentle traction on the small bowel and the pneumoperitoneum allow planes to open up for ease of dissection. We slowly dissected the peritumoral tissue using a harmonic for hemostasis.
I would prefer ligashure out here, but we do not have access to ligashure. In Germany, what we saw was extensive use of ligashure, and
throughout the medial dissection, the aorta lies right next to the tumor. Therefore, one needs to be very careful while making planes for dissection.
The aorta is lying here, and I'm between the aortic and the tumor plane.
The tumor was free from the peritoneum. We lifted the inferior mesenteric vein and dissected the lateral edge of the tumor. Hand-eye coordination of the surgeon is essential here to avoid any injury to the inferior mesenteric vein and the small bowel loops around the tumor. An open approach for the surgery would require a larger incision and cause more postoperative pain. A laparoscopic approach, on the other hand, has offered a magnified view, allowing more precise dissection and coagulation of the smaller feeder vessels supplying the tumor, thus limiting blood loss.
I'll quickly go ahead to finish my talking time.
It is important to gently lift the tumor above the aorta and then.
And that's the completion of
the
this.
Tumor must be extracapsular. Any breach in the capsule of a paraganglioma stands the risk of leaving tumor tissue behind, and thus a chance of recurrence. At this point, we could identify the retroperitoneal fat and therefore were sure that our dissection was completely extracapsular. We then proceeded to complete the dissection circumferentially and free the tumor all around.
You'll see here I'm careful. This is the aorta. You can see it pulsating.
A useful trick when dissecting around the aorta is for the surgeon to keep a suction in the left hand, which would work as a retractor and as well as to keep the field clear of any ooze. At this time, an assistant can retract the inferior mesenteric vein away from the field of surgery. A thorough study of the vascular anatomy on the preoperative CT scan will prevent bleeding from any large feeder vessels to the tube. Tension was referred from the endocrine department. To medially to the tumor over here.
You can see the aorta here pulsating, and that completes my dissection of paraganglioma. Now, any pheochromocytoma or paraganglioma surgery, you've got to be very, very careful. At the end of surgery, remember, you've got to see that the BP is normal before you close the patient. Otherwise, this BP will not come up. After some time, the BP will start coming up and you will have bleeding. So minimum BP should be 120 before you actually call it a day and start retrieving. It's a good habit that after retrieval of any adrenal tumor or paraganglioma, you insufflate again and have a look at what is happening. Normally, drains are not required. If at all there is a small ooze that is occurring even with BP which is normal, Surgicel or Fibrillar will do good. Yes, if the tumors are large and are pheochromocytomas, it is helpful to put in a drain so that you can keep a watch. And that's the way we go about it. Let me tell you, it has been a very satisfying experience for me as I superannuate next month from great institutions that I have worked with since 1976. And nothing is more good when you see such a small 11-year-old undergoing bilateral transabdominal adrenalectomy, sitting up on the second day, and even more satisfying when you do bilateral retroperitoneoscopic adrenalectomy on the same evening. This is a boy who is walking around smiling away to glory. Let me take this opportunity to thank again Aligarh Muslim University, who is in its 101st year since its inception, and Professor Atiya for again picking me up and asking me to talk on one of the favorite topics. You must have seen that there was a voiceover. The voiceover only because I see to it that my resident doctors go and present not only at state or national level, but international level. Thank you very much. I'm ready to take any questions if there are. Otherwise, even in the chat box, I will keep on answering. Not an issue if there is paucity of time. Thank you so much, Dr. Atiya.
Sir, we are indeed honored and blessed to have you with us. Words are not enough to thank you. You agreed to be a part of our academic endeavor at such a short notice. The presentation was excellent, but yes, I must acknowledge that I have the brains of an IB officer. So I always look through the CVs of people, find out, and then that is when I found out you had lots of publication, lots of work on this topic, and I said there is no person who would be better than you to talk about it. Thank you
so much.
Well, we have another speaker now, a renowned surgeon, Professor R. Padmakumar, who is a senior consultant laparoscopic and metabolic surgeon from Lakeshore Hospital, Kochi. He is also the visiting professor in Yanipova University in Mangalore. We invite him for delivering his talk on endoscopic parathyroid resection.
You have not connected to the platform. Hello, sir. Sir, I'm Dr. I'm Dr. Atiya. Have you connected to the platform? I've been told that you have not connected. Are you connected? Acha, you're connected now. Okay, thank you so much.
Hello. Am I audible?
Yes, you are.
Okay.
Please go.
We are now having another speaker, Professor R. Padmakumar, who is a senior consultant laparoscopic and metabolic surgeon from Lakeshore Hospital from Kochi. He's also the visiting professor of Yanipova University, Mangalore. We invite him to deliver his talk on endoscopic parathyroid resection. Professor Padmakumar, sir.
Dr. Munir Khan, am I audible?
Yeah, sir, you are very much audible. We can see you. Please share your screen.
Yeah. Good evening, everybody. Thank you, Dr. Atiya and Aligarh Muslim University team for inviting me to talk on the topic of endoscopic parathyroidectomy.
Sorry to interrupt, but your slide is not shared. You shared the folder only.
What did you get, sir?
Sir, your slide is not sharing, sir. Sir, I stopped share because you shared the folder. Now you have to share your slide. Click on share screen button and select your presentation box only.
Now?
Now it's shared, sir. Yes, sir.
Shall I start?
Yes, sir.
Thank you. Yeah, good evening. Once again, thank you for inviting me to share my topic on endoscopic parathyroidectomy, which we are regularly doing both in India as well as in UAE. If you see hyperparathyroidism, it is almost or double or triple in quantity prevalence in females, and the single adenomas actually account for 80 to 90% of all cases, which actually will be very comfortable for us to deal in an endoscopic manner. And parathyroidectomy is the most effective therapy for any of these hyperparathyroidisms, and especially in the primary hyperparathyroidism. One has to conclude the presence of a adenoma by any of these scanning. Usually it is detected or suspected in an ultrasound scan, then confirmed by a system-AB scan. Parathyroid hormone assay and other needed blood tests have to be done. Usually a high calcium, high PTH value will be actually making us suspicious, which is confirmed by our scanning methods. So what actually in an endoscopic parathyroidectomy different from an open surgery is that you don't actually make an incision in the neck, which will be actually forming a scar and which will not be that comfortable for the patient. Plus, we have the additional advantage of having this minimal invasive procedure to show these structures in a larger magnified manner by which easy identification and easy protection of the nerve it will be possible. So if you take the history, it was actually recorded in 1996, and we have many years passed since this endoscopic method was used for treatment of hyperparathyroidism. In fact, 97 only, we had the thyroid surgeries done in the endoscopic manner. There are several approaches like cervical, axillary, and breast approaches. Majority of the times it is an axillo-breast approach which is being carried out. It is called as the ABA approach or BABA approach, all those. And this is the axillary approach. If you see, the anterior axillary line is chosen for many of the trocars, and maybe something to the chest or circumarular area will be used for putting the scopes. You can see the light in the neck. That means I am already in. This is a telescope. And 10 mm trocar in the circumarular area in this area. In a young patient, it is very comfortable to place such way. This is the breast axillary fold, which is least scar forming area. Here also I am using a circumarular incision there. So these three trocars there, we will be able to handle whatever is in the neck, whether it is thyroid or parathyroid. So this is our technique. Just putting one in the just below the shoulder, one in the axillo-breast fold, and one circumarular, which we call it as our institute technique of Garvandine technique of positioning. Then once you are in the neck, the dissections are one sublatissimal dissection, retraction of the sternocleidomastoid, division or retraction of the strap muscles depending on the size or the access difficulty, or lateral view of the gland will be obtained by this method. And once you have the lateral view of the thyroid gland, you will be able to locate the parathyroid if it is on, especially if it's a lower one. And the magnified vision will save the nerves. Normal parathyroid, if you are having a parathyroid on the lower aspect, the other one has to be preserved, especially if it is only an adenoma. And the ultrasonic devices are used for controlling the pedicles of vascularity. And specimen is generally removed in a specimen bag, especially because this parathyroid adenoma, unlike thyroid malignancy, is known to have some kind of tumor deposit and creating a problem. Thyroid, it may not be happen, but so it is better to put it in a cover and removing it. And strap muscle approximation. So this is the kind of picture. This is the sternomastoids here, strap muscles. Maybe very rarely we go on to the opposite side to mobilize if you want to actually have the flap raising. The moment you retract, this is the strap muscle which I have retracted to one side, the sternomastoids on the other side, and you can very well see the purple color of violetish color of this parathyroid adenoma. It is very dramatic scene there. And the moment you just retract, it will be mostly appearing in that area. And the specimen is placed in a bag and removed through this area. Usually that 1 centimeter incision which you have already put for your 10 mm trocar will be more than sufficient to bring out the specimen in a bag. Let me show you a video of this endoscopic parathyroidectomy. After the skin incision, you actually go into the subcutaneous plane, just above the pectoralis major muscle. So I am just above the pectoralis major muscle. After getting some sufficient space, I actually put 2 of my instruments. 2 of my instruments are put, and there is a tunnel made towards the neck. This portion is the neck, and you can see the sternomastoid on one side and strap muscles on the other side. So once you have identified, it is better to go like a lateral approach. You may not take 100% of strap muscles to the medial aspect. You will leave little bit of strap muscle, maybe like a split. You leave little bit of muscles to the sternomastoid so that the ansa is protected. The moment you do that, you can see you can have a little wider dissection so that your retraction will be easier. So you are just making one side, it is strap muscle. You can see even to the opposite strap muscle, I have done a little bit of a dissection of the subplatysmal dissection has been done. And you have started seeing the, you can see the
excuse me, sir, I'm sorry to interrupt. I'm sorry to interrupt. We are not able to see the video.
You're not able to see the video?
We're not able to see the video.
Oh, sorry. 1 second. I'll just close it and just take it once more. I'll just try to... I didn't know that.
Sir, I send a request. Please grant permission. It will share your entire screen, sir.
I didn't get you, sir.
I send a request. Please grant permission on Zoom.
I didn't get you. Yeah, okay. Grant permission. Now shall I try? Is it coming now?
Yes.
It's coming?
Yeah.
Yes, sir.
Yeah, okay. I'll just, I have a little, see, I'll just show you from here. Sorry, I didn't know. See, this is the entry point there. See, I'm just making a small incision in the breast axillary fold. Then I'm just dissecting with a tunnel, the telescope itself to make a tunnel in the subcutaneous plane above the pectoralis major muscle. That's what I have done. I just made a small space there. Once I have a space, I can put additional instruments. 2 more 5 millimeter trocars are placed so that I am dissecting all along the subcutaneous plane above the pectoralis major, just maybe few centimeters below the clavicle. So that this portion is below the clavicular area, and this is the sternomastoid muscle. And here is the strap muscle. The pointer is, the harmonic is on the strap muscles. What I'm doing is just trying to enter from the lateral aspect. Can you see? The moment I just split the strap muscles, I'm just leaving a little bit of tissue to the sternomastoid, because if you take entirely the strap muscles to the center, you may have ansa little damage. So I'm just leaving little bit of strap muscle this side and splitting the area, or majority of it is a retraction and a little bit of splitting is happening so that strap muscles are retracted medially. The moment you retract strap muscles, you can see the thyroid gland, the side of the lateral aspect of the thyroid gland can be seen, and this is the middle thyroid vessel. See, that is nicely done so that the gland gets lifted. This is the first step in any of the thyroid surgeries. Here also, because I want the gland to be actually lifted, I just identified the middle thyroid vessel. Any small vessels which are crossing, whether it is in the muscular plane or anything, it's better you actually handle with an energy source so that there is no bleeding. If you make that area entirely bloody, smudged, then the identification of structures becomes very difficult. So at this point, if you want, you can actually put one more trocar from the opposite side to retract the muscles. Here I'm just trying to reach the lower parathyroid because that has been identified as the culprit, and this is the left lobe, right lobe of the thyroid. Right lower parathyroid I'm trying to locate because that has been reported as the offending parathyroid. So I'm just mobilizing that area, and the thyroid gland is just getting lifted. So it's a very slow, gentle process so that you don't have any bleeding. You have only one structure to be protected, that is the right recurrent laryngeal nerve in this case, because you can see the middle thyroid vessel there, that I'm just keeping it as a pointer. In case needed, I can divide. All the vessels, everything will be just kept intact till the time you see the offending parathyroid gland. See, I'm just dissecting there, and you can start seeing the parathyroid gland in that area. The usually it will be like 1 or 2 centimeter size, and it will be definitely surfacing under the thyroid gland. So slow, gentle dissection. You should not actually cast the thyroid gland, parathyroid gland as such. See that particular color which comes, the violetish color, that is one which actually identified the parathyroid adenoma. You can see that the dissection is carried out, and a glimpse of the nerve is also coming when I am dissecting. Can you see? That is the nerve, the white glistening structure is the nerve. So you have identified the nerve, means then things are easier. You don't want to rupture the gland because carcinomatosis is possible, and that too diagnosis will also be a little difficult for the pathologist to tell us what it is if you actually crush the tissue. So I'm just gently lifting, I'm trying to identifying and seeing the nerve there very clearly. The vessel to the parathyroid is also there. Very gentle retraction, identifying, preserving the nerve, keeping it away from the gland which has to be removed, so that the moment you touch the vessel or something, if it bleeds, then you may have a problem. So I'm just taking one vessel which is coming to the parathyroid. See, in thyroid surgery, the most important thing is to preserve all the vasculature of this parathyroid gland. Here you can say that it's a little more easier because you are anyway taking off all the blood vessels which are coming into the parathyroid area. In very difficult cases, maybe you can take even a small portion of the thyroid gland, especially if it is little intrathyroid. So here you can see I have already identified the parathyroid vessel. I'm just holding on to that area rather than the gland, and identifying and separating all structures around, so that the parathyroid adenoma alone is very well seen, and you can nicely separate it. Very gentle dissection with this energy source should be sufficient for us to dissect all around. So you can see the nerve there. You can just safeguard it, and the thyroid gland is there seen, which is just getting lifted, and all the structures very nicely seen. Then you can take individual small vessels which are coming into the parathyroid tissue without crushing the parathyroid. So you can see that how good a magnification is there, how easy it is to identify the parathyroid once you are using this endoscopic approach. So you can see the vessels properly and take it. In case it's a hyperplasia, naturally then we will have to take multiples of parathyroids on either side, maybe like the classical 3.5 parathyroid. So you can see this vessel there, the parathyroid vessel. This is the kind of beauty when we do even a thyroid surgery. You can see all these parathyroid vessels and preserve it, so that the hypoparathyroidism in a thyroidectomy is reduced or prevented to almost full extent, because you can see these vessels, loop of vessels which are going into the parathyroid can be seen, and it can be protected. In this case, you are identifying all the vessels so that you can divide it without any bleeding, and you can take it out. So the purpose is different here, identifying. In a thyroidectomy, it may be a different purpose. Here you are identifying, just bringing out everything. You can see lower down it is the esophageal area, and I'm just dissecting all around. So almost like uneducated, you can see usually around 30 minutes it should be sufficient to dissect that area and remove. Maybe flap bracing will take a little bit time. Altogether 45 minutes you can complete the parathyroid dissection and removal. Thyroidectomy may take more time because you have to see the nerve, the parathyroid preservation, nerve preservation, all, and especially on both sides. It usually takes more time than an open surgery, but here it takes little lesser time because you don't have to open, you don't have to close that area, and identification because of the magnification and the particular color of visualization which is possible in this is very good. So we are just identifying additional vessels if it are coming, especially when it is an adenoma and it is large enough. So you will have more of vessels and you can see the nerves are in close range. In case of a bleeding, it's better to just keep a small gauze piece there and suck it so that you have all the structures identified. So gauze piece is the best device by which you can have better visualization of that area, especially if there is a small oozing. Having identified the nerve in its full course away from the parathyroid, you can slowly start dividing the blood vessels so that the gland will be free to come to you. So the magnification is helping you to see even small ticks, as well as again making sure that nerve is not damaged. You can see the inferior thyroid artery there pulsating. So the relations, everything is nicely seen. Above it is trachea there, and you can see the sugar candle area is just above there, and that the little bit of rubbing onto the gland is typically inducing the bleeding, which usually we say it's an identification of parathyroid. You just rub it, it just changes the color, and there will be bleeding. This is the thyroid nodule that is sharp, very strikingly different from parathyroid gland, which has a different color. You can see the thyroid color is different, the parathyroid color is different, and nicely you are seeing, and I'm just taking care of the blood vessels there. So once the vessels are fully identified, you have made sure that the nerve is dissected off from the gland very clearly. You can just take with an energy source, like ultrasonic device is sufficient to seal the vessels and take it. Even the thyroid pedicles, we do that way only, and the gland is fully free. And then you can place it in a bag and remove it. This is there, and you can just put in a bag and remove it. Can I go to the presentation again? Is it visible? Is it seen that side? My presentation?
We can see it, sir. We can see it.
Yeah, thank you. So intraoperative parathyroid monitoring will be done to see that there is a sharp fall in parathyroid hormone, and we usually get a frozen section to make sure that what we have removed is parathyroid, though we are sure in laparoscopy, especially in Dubai and all, it's mandatory. They ask for a frozen section. They report in half an hour telling that it is parathyroid tissue and it's adenoma, and then only we proceed to extubate the patient. By the time maybe you would have withdrawn all the trocars, closed the wound, and the advantage of what I would say is typically a superior cosmesis, because there is no scar across the neck and smaller incisions which are hidden inside the inner wear will be sufficient. And instead of a classical coccus incision, these few smaller scars in the anterior axillary fold will be sufficient. And because of the magnified vision, you have better visualization of structures, the vessels. You have seen that how much of clarity is there. Nerve damage can be reduced because you can see the nerve, parathyroid, everything in a very nice way. And other parathyroids also is preserved because you have very good magnification and very good vision. And patient will be highly satisfied because there is no neck incision. Disadvantage, if you ask me, it may be a steep learning curve, because initially to identify the plane may be a little difficult, but once we are into the thyroid surgery so frequently, so the once in a while parathyroid also can be done in a very fast and very comfortable manner. Once you have laparoscopy experience and good exposure to neck surgeries, I think it should not be a problem. Complications, if you ask me, anything carbon dioxide embolism is a very remote possibility, but that's possible if you are not careful especially while you are dissecting the flaps, because small vessels can actually suck in carbon dioxide if you keep the pressure more than 8, and if you are not controlling the smaller bleeders in time. So that you can very well avoid. Hypoparathyroidism is something temporary, is something which is really expected and which is a desirable one. Whether it's a complication, we should not take it that way. Permanent hypoparathyroidism, if you actually take more than sufficient parathyroids, that may be a possibility, but that all are very, very rare with the parathyroid surgery. Nerve injury is very, very unlikely. Seroma formation, because you are dissecting, is a possibility, but it may require some aspiration. Skin tethering, if you are having more of a heat injury done, is a possibility, but that also is rare. So to conclude, I can say endoscopic parathyroidectomy has the potential to transform parathyroid surgery in a pattern which is similar to laparoscopic cholecystectomy, and it will be becoming the gold standard. It has to be considered as an initial step itself whenever you have a suspicion, and it's a safe surgical approach. We actually perform other surgeries also endoscopically, like thyroidectomies, neck dissections, thyroglossal cyst, submandibular gland, and branchial cyst removal also. We had a case of polycythemia vera, which was associated with parathyroid adenoma. So we have actually done that removal, and it was published in the Journal of Applied Hematology as management of polycythemia vera by endoscopic parathyroidectomy. Because of the stimulus, it was actually going for a polycythemia. We did the parathyroid removal endoscopically, and the patient got rid of the polycythemia problem as well. So thank you very much. Thank you, Dr. Athiya and team, once again for asking me to deliver a talk on the parathyroid surgeries by endoscopic means. Thank you.
Thank you very much, sir. We would like to have the last speaker of this session, Professor Chintamani, sir. He's the head of the Department of Safdarjung Hospital. And we request him to have his talk, 10 Commandments of Safe and Optimum Thyroid Surgery.
I think Professor Chintamani is not with us. He is head of Department of Safdarjung Medical College, and an emergency meeting. And he had to rush off for that. And that is why he said he has promised me that he'll be delivering his talk tomorrow. He's a wonderful teacher, a teacher of teachers. He's alumni from a college. And so, sir, the next section, please, aapko lena hoga, kyunki
Fine. Thank you very much, Professor Athiya. I think we conclude this session. And next session is the urology session now. Thank you.
Good evening, everyone. I am Dr. Manzoor Ahmed. On behalf of the organizing committee, I welcome you all to the urology section of this AMU surgery update. Now, my co-moderator is Professor Munir Khan from the Kidney Hospital, Srinagar. And we have got 3 lectures. One is on the urolithiasis, one is on radical nephrectomy, and the last one on the robotic radical prostatectomy. Professor Munir Khan, sir, would you like to introduce the speaker, please?
Good evening. Welcome to the session, urology session. We have 3 papers, as already said, and I think without wasting, we are lagging behind in time. And we start with the first paper, Dr. Rajesh Kumar Tiwari from Patna, Indira Gandhi Institute of Medical Sciences. He'll be talking about the current concepts in the management of urolithiasis. He'll tell you about all the latest laser, Thalmion laser, which is added on the latest scopes which are available for RIRS, because RIRS is taken urolithiasis in a great way. So to Dr. Rajesh Tiwari, sir, please.
Very good evening to all of you, respected chairpersons, moderators, teachers, consultants, and students. I am Dr. Rajesh Tiwari from Patna. Greetings from Patna, capital of Bihar. First, I am very thankful to Professor Atiya and his team for the grant this academic feast organized by Aligarh Muslim University. Now, stone disease is very common in the practice of urology. About 50% of our workload is related to stone work. So urolithiasis is a global disease. Incidence is increasing worldwide and so in India. But the pattern of urolithiasis is changing. In our student days, we used to encounter bladder stone more often than the kidney stones. But now the incidence of upper tract stone is increasing, and it is probably because of the adoption of Western lifestyle and dietary habits. And the other factor important is that more and more asymptomatic kidney stones are being diagnosed because of routine use of ultrasound and CT scan in health checkup programs and for evaluation of non-specific symptoms of abdomen. Low water intake, diet rich in animal proteins, and high sodium intakes are established risk factors for urolithiasis. This renal stone is common in diabetics, patients of metabolic syndrome, and in obese patients. Incidence is high. We all know that it is a recurrent disease. Until death, exact etiopathogenesis of calcium stones is not known. Calcium oxalate is still the commonest renal stone. Monohydrate is the hardest one, followed by calcium phosphate, uric acid, and cystine stone, which are all formed in acidic urine. Triple phosphate is the infective stone formed by the infection of urease producing bacteria. They form in alkaline urine, and the rare stones are the matrix stone, xanthine stone produced because of the use of allopurinol to treat uric acid stones, and drug stones, trantorin and indinavir used to treat AIDS patients. Till 1980, open surgery was the only option for renal stone or ureteric stone management. And the procedures we used to perform were pyelorrhizectomy, nephrolithectomy, extended pyelorrhizectomy, anatrophic nephrolithectomy for staghorn stones, nephrectomy or polar nephrectomy for poorly functioning kidneys, erythrolithectomy and cystolithectomy. But in the last 3 decades, open surgery has been replaced by endourological procedures such as ESWL, PCNL, erythroscopy, semi-rigid and flexi-1, robots, and laparoscopy. In well-equipped dedicated stone centers, incidence of open surgery is less than 5%. And even in where it is indicated, majority of times it has been replaced by laparoscopy. Indications is still where open surgery is done. Number 1 is patient choice, failure of endourological procedures, or to manage the complications of endourology, renal stone with PUC obstruction, non-functioning or pyonephritic kidney or xanthogramulus pyelonephritis for nephrectomy purpose, in anomalous kidney, or if there is a large stone burden in chronic kidney disease patient. Along with the improvement in the technology to treat the renal stones, even imaging have also changed from the yesteryears. Previously, we had only X-ray, KUB, and intravenous urography, which used to miss a small and radiolucent stones. Then came ultrasound, which is quick, there is no risk of radiation, safe in pregnancy, detects even smaller stones, and so much so, it is so useful for urologists, so that it has become an extension of clinical examination, and you can call it as urologist stethoscope. Limitation of ultrasound that it misses mid-heart ureteric stones because of the overlying gas or fat. It is subjective. It gives no idea of the kidney function, and it overestimates the stone size. In the recent practice, NCCT has become investigation of choice for acute abdominal colic evaluation in emergency. Advantages are it detects the smallest stones and ureter in all locations. It tells about the density of a stone and skin to stone distance, which is useful information to be obtained before ESWL. It rules out adjacent pathologies. Limitation is that it misses Indiana with stones and of its availability in emergency. CT urography has replaced IVU because it gives three-dimensional picture of pelvic calyx system and stone location. It also tells about the relation of kidney with colon, which is needed in PCNL. So essentially required before PCNL or ESWL, or when going for repeat surgery, or when operating on anomalous kidneys. Renogram is very important if on CT or IVU there is poor or no contrast accretion. So I will say that one should not adventure any procedure on kidney without knowing its function, because it has got its medical legal values. MRI is not a preferred imaging for stone diseases, but those where contrast cannot be used, such as CKD or in pregnancy, MRI is still done. So imaging not only helps in diagnosis, but it also helps in treatment decision making, whether to go for medical or surgical, and the type of endourological procedures which is suitable for that stone or that patient. Urine analysis is still the most important test in the evaluation of urolithiasis. And the color, such as if you get red urine or if there is presence of RBC urine, then you are very much sure in emergency that you are dealing with a case of renal colic. pH is again important, whether it is acidic or alkaline. By that you can separate what type of stone you are dealing with probably. And the presence of crystals, if you can detect under the microscope, that will tell about the chemical nature of the stone which you are dealing with. Chemical analysis of a stone obtained by surgery or passed spontaneously must be analyzed. It helps in post-operative dietary advice and gives lead to metabolic workup to prevent for future recurrence. So for management, beside history and clinical examination, blood investigation, urine examination, and imaging is very important for complete anatomical and functional information to decide about the procedure which one has to perform on that patient. Patient counseling and education is very important, because nowadays there are different endourological procedures competing for the same type of indications. So patients' participation in decision making is very important, and it is also important for follow-up and to prevent the chance of recurrence. The first endourological procedure, which came in 1984 with the use of Dornier HM3 machine for the treatment of renal stones. It was the first revolutionary evolution in the management in the surgical field, which gives a lot of hope for minimal invasive treatment. Indication is now at present the indication for ESWL is for stones up to 2 centimeter in kidney and 1 centimeter in lower calyx. For 1 centimeter stone in upper or mid ureter, it can be also used. Contraindications is coagulopathies or bleeding disorders, pregnancy, it is not safe, but you must rule out any distal obstruction to a stone before venturing for ESWL, because fragments have to pass and urine must be sterile before ESWL. A stone fragmentation has been found to be best for the stones whose density is around 700 to 900 ounce-fold unit, and skin to stone distance is less than 10 centimeters. It is less effective in too hard stones such as oxalate monohydrate, cystine stone, and too soft stones such as matrix stone. In lower calyx stone is a peculiar situation because it is the most dependent part of the kidney. So drainage has to be considered, and it is found to be best if there is favorable anatomy, that is less acute infundibulopelvic angle. The infundibulum should be wide but not too long. The complications are renal hematoma, pain, hematuria. They are of milder degree and they resolve spontaneously on their own. But Steen-Strauss is a situation which may need intervention at times. It is because of some bigger fragment coming down the ureter and blocking the smaller fragments to pass distally, and they give the appearance of a stone street on extracavity. If there is no symptom, they may be observed or may be given alpha blockers. But if there is progressive obstruction or patient is symptomatic, then the lead stone may be again further fragmented by ESWL, or if not successful, then ureteroscopy and stenting is the treatment. Stenting is always done before ESWL in solitary kidneys or bilateral stone diseases. And alpha blockers are given post-procedure to promote clearance, beside advice to drink adequate amount of water daily. The machine has got 3 components. The electromagnetic source is the most common type of machine to be used as present. It is the most effective. For imaging, ultrasound or CR fluoroscopy is used to localize the stone on the machine. Fragmentation has been found to be effective if power is gradually increased, that is, ramping is done. Shock waves are delivered at slow rate, around 60 waves, shock pulses per minute. Appropriate coupling with no air bubbles in between, and frequent imaging in 2 planes to confirm the stone is in focus. Fragments up to 4 mm are regarded insignificant and expected to pass in 3 months. Beyond that, they need treatment. Repeat sessions may be required, and literature has proved that there is no long-term increased incidence of diabetes or hypertension post-ESWL. And appropriate patient selection is, again, I will say, is key to success with ESWL. The next endourological procedure is PCNL. It is at present the most versatile procedure for removal of renal stones of any size, including a stag heart. Any composition, any location, or even upper ureteric stones can be pushed back in kidney for PCNL. It is done under general anesthesia, mostly in prone position, but can be done in supine. Advantage is that it gives clearance in 1 session, and as per AU guideline, renal stones more than 2 cm size and more than 1 cm lower calyceal stones qualify for PCNL. Contraindication is again coagulopathy or presence of infection, sepsis. Complication: being invasive, it carries a high morbidity compared to ureteroscopy and ESWL. Hemorrhage is the most common complication. Mostly it is mild, clears in 24 to 48 hours. But if it persists more, leading to instability in the vitals, drop in hemoglobin level, demanding repeated blood transfusions, then or if it presents late after 2 or 3 weeks, then it is most probably because of the pseudoaneurysm or AV fistula formation. And such patients need angioembolization of the offending vessels. CT angio followed by angioembolization. Second important common injury is pleural injury leading to hydro or pneumothorax. It is mostly seen in supracostal punctures. Adjacent organ injuries such as colon, liver, spleen are very rare, and sepsis is also seen in 10% of the cases. So we started with a standard PCN of tract size 28 to 30 French. But now with miniaturization of nephroscopes and availability of intracorporeal lithotripters such as lasers, we have shifted to now trend is towards mini PCNL when the tract size is less than 20 French. If it is less than 14, it is ultra mini PCNL, and if it is less than 10, it is micro PCNL. Reduction of tract size and nephroscope leads to less renal and vascular injury and less bleeding because kidney is a very vascular organ. It receives 1/5 of cardiac output every minute. It causes less pain, no tube is required post-op, and hospital stays short after mini PCN. But there is problem of vision. If there is slightest bleeding, the vision gets unclear. There is reduced size of working channels, and moreover, the raised intrarenal pressure, because the irrigated fluid is not coming out, it can increases the chances of sepsis. These are the list of PCNL instruments, but the most important component which I am going to discuss is the intracorporeal lithotripsy instruments. We have pneumolithotripsy, laser, holmium YAG, thulium laser fiber, ultrasound, and electrohydraulic. At present, pneumo, the ballistic one, is cheap, being cheap, safe, and have low maintenance requirement. So it is most commonly used. Combination of pneumatic and ultrasonic lithotripsy with suction facility has been developed. In mini PCNL, both pneumatic or laser can be used to fragment stones. And the fragment in PCNL, they come out by whirlpool effect created by irrigation through ureteric catheters. Flexible nephroscope can be passed through sheath of mini to check the pelvic calyceal system at the end of procedure. The success of PCNL depends on the quality of renal access. The tract must be straight, shortest, and transpapillary in desired calyx. In India, the whole procedure is done by urologists, but in USA, puncture is done by radiologists and the rest of the procedure is completed by urologists. This is mostly done under the guidance of biplanar fluoroscopy, but because of the radiation concern, now urologists are shifting to ultrasound guided puncture followed by dilatation under CR. Now ureteroscopy. It is the ureteroscopy is at present the commonest endourological procedure done in the management of urolithiasis. Worldwide, as incidence of ureteric stone is rising, and patients of ureteric stone, they present early for treatment because of polyp. Ureteroscopy started with semi-rigid ones. For ureteric stones, fragmentation was done by pneumolithotripsy, lithoclast, and a spontaneous passage was allowed to the fragments. In some cases, a stent may be required. With pneumo, all stones of all combinations cannot be fragmented, and there is problem of retropulsion. With a smaller scopes, 8 French or less, there is no need of dilatation of intramural ureter. Guide wire must be introduced to facilitate introduction of scope. A standby fluoroscopy must be there to detect complications or to check for fragments migrating up. Complication incidence is very low in ureteroscopy. There may be mild mucosal injury or bleeding, but the perforation needs stenting, and stricture incidence is very low in long term with the improvement in the instruments. Avulsion of ureter is the most serious injury, and immediate treatment for that is PCN, percutaneous nephrostomy, and reconstruction is taken up later on after 3 to 6 months. Flexible ureteroscopy brought paradigm shift in the management of ureteric and renal stones up to 2 centimeter size. This procedure is competing with ESWL or mini PCNL for similar indications. Advantage of being less invasive than mini PCNL and giving one-time clearance as compared to ESWL. Current nephroscopes with multiple axis tip deflection can approach whole pelvic calcium system, including lower pole. Laser can effectively fragment or dust the stones of all compositions depending on settings. Dusting is done with low pulse energy and high frequency using dancing, chipping, and painting strategies. Fragmentation needs high pulse energy and low frequency to break into extractable fragments. There is another technique of non-contact laser lithotripsy, that is a pop-pot technique, in which the calyceal stones are pulverized with high frequency, keeping fiber in close proximity. And now the holmium YAG laser has come up with MOSES technology, which delivers energy over 2 pulses to increase fragmentation and decrease retropulse. But the limitation of flexible ureteroscopy in a developing country like India is the cost factor. The instruments are very delicate. After a certain number of procedures, they get damaged. There is long procedural time, so for larger stones, it is not possible. There is problem of vision. If there is slightest bleeding, your vision gets lost. And again, there is problem of raised intrarenal pressure. There may be ureteral seat associated injury to ureter, and there may be laser-induced thermal injury as well. Because as the temperature rises, the mucosal gets damaged. And the new additions in this field are digital ureteroscope with chip on end. There is now available single-use ureteroscope, flexible ureteroscope to decrease the incidence of sepsis. There is ureteral access sheath has been developed with suction capability to reduce intrapelvic pressure, improve vision, reduce temperature, and suction of stone debris as well to clear the vision. Now, after holmium, thulium fiber laser has come. This is an emerging technology. It is the advantage is that it is faster than holmium. The delivery fiber is thin, giving a space for irrigated fluid to come out. But there is concern of thermal strictures in ureter. So I will summarize as per guideline the management of renal stones. If there is asymptomatic non-obstructive calcial stone, they can be kept under observation. Symptomatic non-obstructive calcial stone treatment is ESWL or RIRS. Less than equal to 10 mm, ESWL is the first choice. RIRS is competing with that. More than 10 mm up to 2 centimeter. If it is the lower pole, ECNL is the first choice, followed by RIRS. If it is anywhere in the kidney other than lower pole, ESWL is the first choice, followed by RIRS. If the stone size is more than 2 centimeter, PCNL is the best. The second choice is RIRS or ESWL. For staghorn stones, PCNL is the treatment of choice. It may be 1 or 2 stages, and you may need ESWL treatment post-PCNL to clear the residual stones. For urethral stones up to 4 to 5 millimeter, there's 90% chances of spontaneous passage. As size increases, there is less chance of passage. Over 1 centimeter, only 10% pass. To aid passage, medical expulsive therapy is tried. Tamsulosin, the alpha blocker, is the most commonly used drug to aid in the passage. Trial of 4 to 6 weeks is given if there is no progressive obstruction leading to renal deterioration or infection, or if there is persistent colic, then earlier intervention can be done. For mid and distal urethral stone, the choice is ureteroscopy, and then second choice is ESWL. For upper ureteric stone, URS and ESWL both can be done, but patient must be informed that ESWL is least morbid, but URS has greater stone-free rate in a single session. For impacted stone in the ureter, URS is better, but patient who fail shockwave and or URS PCNL, then laparoscopic open or robotic assisted stone removal may be done. For bladder stones, we have practiced hysterectomy for years, but now for smaller stones, endoscopic removal by forceps is possible. For big stones, transurethral lithotripsy or percutaneous cystolithotripsy with the help of PCNL instruments can be done. So take-home message is that it was prepared for PG students that surgical treatment is going towards minimally invasive, least morbidity, decreased hospitalization, less pain, and no scar are the aims. Each technology is being refined further to reduce cost, radiation, morbidity, and single session procedure. A stone fragmentation device and energy is being improved. Low radiation CT or ultrasound has to play greater role in localization. Practice is becoming more evidence-based. But the basic surgical principle remains the same. Full workup before treatment, including functional study, is important. Patient must be informed about success and complications of each option. In case of infected system, first drain kidney by PCN or a stent, and then treat a stone after urine becomes sterile. Kidney stone is a recurrent disease, so metabolic workup is necessary wherever indicated, such as renal tubular acidosis, hyperparathyroidism, cystinuria. Patient must be imaged before discharge to ensure a stone-free status, and it is our duty to educate people about stone disease and its complications, as still in our practice, 50% nephrectomy is for stone-related non-functioning kidney. Thank you to the team led by Professor Atia for giving me this opportunity. Thank you.
Thank you, Professor Tiwari, for this very vivid lecture. You have summed up in such a short time because there have been a lot of advances. Just a few points. Lithotripsy, ESWL is virtually given up in most of the centers because they are 2 centimeter stone. The clearance after a sitting or 2 sittings will be only out to the tune of 40%. And the fragments are large and invariably some are left in the kidney. And the other point regarding PCNL, well, that is a standard procedure all over the world, but it has its limitations. If you have the facilities, do you have facilities of angioembolism in your center?
Yes, sir. Yes,
okay.
Sir.
Then you are blessed with that. Otherwise, many centers do not have this facility, and then if it's a bleed, it's very alarming. And the other thing is, a shock pulse, which you already mentioned, combination of both ultrasound and pneumatic lithotripsy. Yes. It's very good. It sucks out and you makes the procedure very fast, PCNL procedure. Then the last you said was the RARS or flexible ureteroscopy. Well, the digital scopes, the vision is very good. And I think with time, all these PCNL will, even today, even the stones as big as 3 centimeters are being done by this RARS using the thorium laser. And the laser is also, this is much faster than the holmium laser. That's what I have to say.
Sir, in Corona period, practice of ESW has gone up.
Oh, not with us, but we have the ESWS machine. We got it way back in '94. but then we left it after a decade or two. Thereafter, we not use RARS has taken over. Even in the coronary fluid, even RARS can be done in the spinal. Even when earlier we did not have the RT-PCR freely available, we would go by the spinal or the regional anesthesia in these cases.
Thank you.
Then, sir, what is your indication today of a laparoscopy pyelolithotomy?
Only when we are going for PUG obstruction associated stone, sir.
Yeah.
Otherwise, we are going for or in ectopic kidneys.
Right.
Ectopic kidneys.
Right. I'm very fond of this laparoscopy pyelolithotomy. So all the large stones in the ureter, upper ureter, and the pelvic stones, which are maybe staghorn, are removed by laparoscopy.
Yes.
Thank you, sir. It was a very nice presentation.
Thank you. Thank you.
Thank you.
Thank you, Professor Tiwari. It was indeed a pleasure to have you amongst us. I'm really indebted and grateful to you for accepting an invite at a very short notice. It is great of you to agree to be there with us and support our academic endeavor. Thank you. It was a wonderful presentation. Thank you so much.
Thank you. Before we go to the next paper, Dr. Wahid Zaman from Max Super Specialty Hospital, Delhi, is going to tell us of lap radical nephrectomies. Dr. Zaman, please.
Good evening. Namaskar. Assalamu alaikum. Can you hear me?
Yeah, very well. Vivid. We can hear you very well.
We can hear you. Okay, sir. I'm going to.
Yes.
Sure. Good evening. This evening, I want to thanks. First of all, I want to thank Professor Athiya. Hello. Can you hear me, sir?
Yes, sir. Please continue, sir.
Is it clear? So I want to thank Professor Athiya and our energetic team and Department of Surgery, AMU, for inviting me in this session. And it's a really whole day. People are having wonderful sessions. So it's my privilege to attend this evening. So I'm going to discuss about renal cell carcinoma in brief. And of course, my topic is on lap radical nephrectomy, but definitely I will discuss about lap partial nephrectomy as well, because now gradually partial nephrectomy is taking over in many as a main indication in many select group of patients. So I would like to touch that part as well. And I think it will be useful for our postgraduates. So in this renal cell carcinoma, I will straightway, I'll mainly discuss about, I'll have a brief overview about RCC, and then few slides on partial and radical nephrectomy indications, and then videos and few interesting cases we will discuss this evening. So renal cell carcinoma is a type of kidney cancer that starts in the lining of very small tubules in the kidney. And renal cell carcinoma, as you all know, is known as also known as hypernephroma or renal adenocarcinoma, renal or kidney cancer. And this is the most common kind of kidney cancer found in adults. The kidneys are organs in our body, all of us know, that is used to get rid of the waste products. And there are tiny tubules in the kidney, and that is responsible for this. And this RCC arises from these tiny tubules. It's a fast-growing cancer to some extent and often spreads to the lung, surrounding organs, and to some unusual sites as well. RCC represents 2% of overall cancer incidence and mortality, and 50,000 cases diagnosed as per US data per year, and about more than 13,000 people die annually. There is a significant increase in incidence over the years and all stage increase, but greatest increase has been seen for the localized disease. There is male predominance for RCC. The highest incidence is seen between 60 to 80 years of age group, and median age of death is around 70 years. So it is the most common type of kidney cancer in adults, and it occurs most often in men between 50 to 70 years of age group. In addition to obesity and hypertension, known risk factor for RCC includes cigarette smoking, diet, diabetes, male predominance is there definitely, and occupational exposure to petroleum products, heavy metals, then asbestos, etc. So incidence also correlates with the age, and highest incidence is found in the 6th and 7th decade. And the toxic substances, if you see the etiology, cigarette smoking has been shown to be the significant risk factor for the development of RCC. Risk of renal cancer increased by almost 54% in men and 22% in women due to smoking. And obesity and nutritional factors are also the etiological factors among this. Other than this, coffee consumption is also said to be there is increased incidence. So its origin is from proximal renal tubular epithelium, and it occurs in sporadic as well as in the hereditary form, and both forms are associated with the structural alteration of the short arm of chromosome 3. So various genetic studies have been done for this, and if you see few hereditary syndromes are associated with renal cell carcinoma. These are von Hippel-Lindau disease, hereditary papillary renal carcinoma, familial renal oncocytoma, and hereditary renal carcinoma. So majority of RCC occurs sporadically, and occupational exposure, then tobacco smoking, and these are the main factors, risk factors. If you see the histopathology, most common is the clear cell carcinoma, and followed by papillary and collecting duct, various varieties of RCC. Other cancerous kidney tumors with less common cancers of the kidney include transitional cell carcinoma, Wilms tumor, more in children, and renal sarcoma. As far as genetic factor is concerned, 2 to 4% of RCC is associated with inherited disorder, and all of us know von Hippel-Lindau disease is one of the commonest example of this. I'm not going into the details of this. So variety of symptoms maybe they are mainly, many times it is most asymptomatic as well. And nowadays with the advancement of the imaging techniques, during routine checkup, we pick up around 25 to 30% of the renal tumors, incidentoma, that is called. So this asymptomatic renal tumors incidence have increased significantly with the advent of this modern imaging techniques. Hematuria presents almost in 40% of patients. The classical triad we used to read in our old textbook, that is flank pain, hematuria, and palpable abdominal mass, occurs in 9% of patients. 45% patient present usually with the localized disease, and 25% with locally advanced, and 30% at presentation, they may have metastatic disease. The various paraneoplastic syndromes are associated with RCC are anemia, almost in the tune of 30 to 80%, hepatic dysfunction, hypercalcemia, cachexia, erythrocytosis, and secondary amyloidosis. As such, there is no screening for general population is required. Ultrasound is a useful tool to distinguish between solid and cystic renal mass. Contrast CT is the investigation of choice to evaluate tumor size, location, and lymph node involvement, and MRI to evaluate collecting system and IVC involvement, especially to differentiate from TCC, Then if IVC thrombus or renal vein thrombus is there, then MRI is a good tool. And most important, if a patient is having renal dysfunction, again we go for MRI instead of CT, contrast CT. Tissue diagnosis is either obtained by nephrectomy or biopsy, and surgery indicated for solid renal mass if it is more than 1 or 1.5 centimeter, and less than this, periodic follow-up is required. Differential diagnosis of renal masses, cystic or tumors or inflammatory masses. Cyst may be simple or complex or multiple. Tumors are most common is renal cell carcinoma, lymphomas, sarcomas. Then benign masses are there like adenoma, angiomyolipoma, oncocytoma. And inflammatory lesions may be there in form of infection, infarction, and trauma. If you see the histology of RCC, clear cell variety is around almost 75 to 80% of RCC are clear cell. Chromophilic is 10 to 15 and chromophobic is 5 to 10%. The TNM staging system is there and that is stage 1 to 3 is localized disease. Stage 4 is advanced metastatic disease. I'm not going to the details of the TNM classification. I think our postgraduates and they're all aware of this. It's a very interesting and we should know and we should label all our tumors. Staging and prognosis wise, if you see stage 1, if tumor is less than 7 centimeter in greatest dimension limited to the kidney, almost 5-year survival is 95%. While in the stage 2, when it is more than 7 centimeter, survival is around 80 to 85%. Stage 3 disease, it is around 50 to 59%. And stage 4, in present era, it is 5-year survival is around 20%. For the postgraduates, I would like to describe this algorithm, especially patient presenting with the microscopic hematuria, then what to do. Simple microscopic hematuria, then less than 3 red blood cells per high power field. Repeated analysis should be done, 6 weeks interval. If negative, no additional workup. If positive, 3 or more red blood cells, then we should rule out urinary tract infection, vigorous exercise, menstruation, recent urological procedures, etc. If it remains on the repeat, it is negative, no additional workup is required. While the additional risk factor for malignancies are if there contrast media allergies and renal insufficiency, in that case, low risk of malignancy if there is renal insufficiency, radiation sensitivity or contrast media allergy, then less optimal imaging like MRI is sufficient for this. For high risk malignancy and with good renal function and no contrast media allergy, then CECT is the investigation of choice. Followed by cystoscopy. If it is negative, then again urine analysis to be done annually. If positive, treat accordingly. So in this way, that is the microscopic hematuria. This algorithm should be followed and it's very useful for our general practice. Patient presenting with incidentally detected renal mass, if it contains fat, then on CT, then or calcification, then no calcification, then angiomyolipoma. If calcification is there, then it has to be investigated by CT MRI. And if too small to characterize, then we can again go for the CT and MRI. If cystic mass is there, then we know the Bosniak classification accordingly. We have to deal that. If solid mass less than 1 centimeter, again annual checkup is required. If 1 to 4 centimeter, then small renal neoplasm in the category, and more than that is classical of renal neoplasm, and further urology management is required. For Bosniak classification, I'm not going to the details. If 1 and 2F is there, observation is indicated. If 3 and 4, then it has to be explored and to rule out RCC. So localized RCC treatment, if you see, surgery is the only curative therapy for stage 1 to 3. Radical nephrectomy is the gold standard. Partial nephrectomy can be done in select group of patients. There is no role for adjuvant therapy except under investigational protocol. 20 to 30% of patients relapse within 2 to 3 years. and metastatic to lung is the most common metastatic site, and local recurrences in the tumor around 2 to 3%. If advanced RCC is there, then definitely systemic therapy is required or targeted therapy is required. Surgery is always the palliative to sort of cytoreduction, or if there is bulky tumor is there, that can be removed for the indication of pain and GI obstruction. Targeted therapy, not going into the details again, it is there, it has got limited role, and it gives the life expansion of around 6 to 12 months. And sunitinib, all of you know, is one of the popular targeted therapy with a median survival of 16.4 months. Chemotherapy has got minimal response in RCC. Various trials have taken place, but it has got very limited role in advanced RCC. Radiation therapy, again, it is relatively radioresistant. So indications for radiotherapy is very limited. Only for metastatic disease, if there is painful bone, then that site can be irradiated. And recurrent abdominal metastasis and for brain metastasis, radiotherapy is indicated. What may be the complications? Possible complications of RCC may be in form of hypertension, constipation, abdominal bloating, and intestinal obstruction. Various paraneoplastic syndromes can be there. Hypercalcemia, non-metastatic liver involvement like Stauffer syndrome, and these are mainly thrombocytosis, etc., are the paraneoplastic syndromes. So RCC is relatively rare, but is increasing incidence and more incidentally detected tumors. So localized tumors are more diagnosed nowadays in the tumor around 25 to 30%. Tobacco is the main, I think, association in the RCC. So surgery is the only curative modality for stage 1, 2, and 3. Stage 4 disease holds poor prognosis despite advancement in the molecular understanding. So now I'll come over to the my second part, that is partial nephrectomy. And very quickly I would like to cover, and then we'll go for the videos. So partial nephrectomy is the treatment of choice for certain benign conditions and localized pathology of the kidney. But it has got definite role for malignancy, and it is emerging now when there is bilateral tumor, when there is solitary kidney, and when there is poorly functioning kidney with contralateral renal unit is poorly functioning, then there is absolute indication for nephron sparing surgery. Then in the cases of even unilateral renal cell carcinoma nowadays, less than 7 centimeter in size, we should go for nephron sparing surgery, that is partial nephrectomy, because chances of pyelonephritis and chronic arterial disease due to systemic disease, diabetes, in later life, they are going to suffer. So we should try to preserve the nephrons. So nephron is the solitary, nephron sparing surgery in the solitary kidney is a really challenging procedure, but a good clinical outcome can be achieved. Recently, the indication for NSS, that is nephron sparing surgery, has expanded significantly. All of you know the anatomy, and there is some difference between right and left kidney. Definitely with the gonadal veins, if you see, opens directly into the IVC on the right side, while in the left side, it opens directly into the renal vein. And right side venous complex vein is long, but it has got lumbar connections as well as the gonadal complex many a times with the adrenal. While on the left side, dissection, I will say, is more easier as compared to the left. So partial nephrectomy can be of open type or laparoscopic. First of all, it emerged as and it was the gold standard initially as open partial nephrectomy that can be performed by various incisions, but gradually now laparoscopy is taking over this. So various incisions for this, like subcostal flank incision, then 11th and 12th rib incision, and subcostal abdominal incision, that is one of our favorite, that is chevron for the open surgery. Similarly, for the radical nephrectomy, we also use this subcostal abdominal incision. Similarly, vertical abdominal incisions, many practice this, but as a urologist, I prefer chevron incision. So for partial nephrectomy, the basic principle is we have to spare the nephrons of the kidney, and part of the tumor can be removed. That is called partial nephrectomy. Many times it can be very easily enucleated because RCC is said to be well encapsulated tumor. This is one of our horseshoe kidney patient. You can see that tumor has been enucleated and repaired. So laparoscopic is now coming up. Laparoscopic parts, and we can duplicate exactly mirror imaging can be done right as open surgery in partial nephrectomy. So partial nephrectomy offers equivalent oncological outcome as that of radical nephrectomy. It has greater preservation of renal function, so less risk for chronic kidney disease and cardiovascular disease. So laparoscopic partial nephrectomy remains underutilized. So for the postgraduates, I'd like to describe this partial nephrectomy so that they will develop interest in this partial nephrectomy, and it's really useful. What nowadays happening, we are doing almost 50-50. If you see the cases, last week we did 4 cases, out of this 3 were partial nephrectomy and 1 radical nephrectomy. So partial nephrectomy is really coming up. So recent advancement will likely allow greater utilization of partial nephrectomy and expand its usage to increasingly more complex tumors, because it gives beautiful magnification. All laparoscopic surgeons are there, and they all know the advantages of laparoscopy. So it's a treatment of choice whenever feasible for enhancing renal masses. So nephron sparing surgery to avoid dialysis in case of solitary kidney, bilateral synchronous masses, hereditary syndromes. It is very useful. Preferable procedure for patient with renal masses less than 7 centimeter, even with a normal contralateral kidney. So what is the rationale? So partial nephrectomy provides equivalent oncological outcome to radical nephrectomy. For renal tumors less than 4 and tumor less than 7, it has got almost equal result. No difference between partial nephrectomy and radical nephrectomy with regard to cancer-specific survival and rate to distant metastasis. General renal function preservation with partial nephrectomy is really appreciable. So partial nephrectomy with better overall survival compared to radical nephrectomy, because those who are undergoing partial nephrectomy, less chances of developing CKD. So less chances of cerebrovascular disease as well. So the advantages of partial nephrectomy, of course, it is recurrence is very low. Local recurrence after partial nephrectomy are rare and typically occur in presence of grossly positive surgical margin. Risk for multiple tumor foci is less than 6% for T1 tumor. With improved accuracy of both preoperative and intraoperative imaging techniques, even missing satellite tumors can be taken care of. Nowadays, intraop ultrasound probe we are inserting, and we are looking at various satellite lesions. So lifetime risk of new tumor developing in ipsilateral kidney is less than 5%. That is similar to risk for tumor in contralateral kidney. So benefit of partial nephrectomy with regard to improved long-term renal and cardiovascular function. Various studies are available now. So arguments supporting radical nephrectomy having minimal impact on renal function have largely been extrapolated from literature on donor nephrectomy patients who are carefully screened and selected. They are selected group of patients, donor nephrectomies, but not in as compared to other general population patients suffering from cardiovascular disease, means diabetes, hypertension, and other comorbidities. So much of this evidence is not generalizable to RCC population. Roughly 26% of patients presenting with renal masses less than 4 centimeter already have a baseline estimated GFR less than 60. So therefore, radical nephrectomy is a risk factor for development or worsening of CKD. So link between CKD and cardiovascular disease is well established. There is a decrease in GFR, there will be more risk of cerebrovascular diseases. So risk of both death and hospitalization also increases with a drop in GFR. So radical nephrectomy is a recognized risk factor for development and progression to CKD. Preservation of nephrons from partial nephrectomy can mitigate this effect very well. So studies comparing to partial nephrectomy and radical nephrectomy showed a reduction in CVD-related morbidities. There is sufficient renal function is required for patient to receive many of the systemic medical therapies available in event of recurrences. So that choice remains if we go for partial nephrectomy because of preservation of renal function. With continued advancement in medical therapies, nephron sparing with partial nephrectomy may have an even greater advantage over radical nephrectomy. So laparoscopic partial nephrectomy is an acceptable alternative now to open partial nephrectomy. An advancement in the surgical techniques and the use of hemostatic agents has really expanded the indications for laparoscopic partial nephrectomy to more complex and renal masses. Laparoscopic partial nephrectomy has equivalent oncological outcome as compared to radical nephrectomy. So what are indications? Mainly benign and malignant renal conditions are there. The situation when radical nephrectomy would leave the patient anephric due to bilateral renal tumors or unilateral tumor and compromised other side. Elective partial nephrectomy in patients with unilateral renal tumor and normal contralateral kidney to reduce the risk of developing CKD. Even nowadays, less than 4 centimeter tumor with normal contralateral kidney, we go for partial nephrectomy. So laparoscopic partial nephrectomy was initially reserved for select group of patients, but now gradually with our experience, it is for all group of patients we are doing. So indications and contraindications of partial nephrectomy: if very large tumor, then endophytic tumors near the hilum, bilateral tumors, multiple ipsilateral tumors, stage T1 tumors presenting in the select patient over the age of 70, high-risk group, go for radical rather than partial nephrectomy. So while in the younger age group, definitely with the help of ultrasound probe, etc., we can even see the endophytic tumors. What are the general contraindications? If bleeding diathesis is there, renal vein thrombus, advanced, aggressively locally advanced disease, it is contraindicated. Then morbid obesity is another contraindication. And decision to proceed with lap partial nephrectomy should be based on tumor characteristic and surgeon's skill. That is very important, and experience with such an approach. So advantages of laparoscopic partial nephrectomy is definitely it is shorter length of hospitalization, quicker recovery, lower narcotic requirement, lower pain score, improved cosmesis is there, and early return to work and all. So definitely it has got the advantage with the shorter hospital stay. Disadvantage, it is really technically challenging. A higher rate of intraoperative complications are also there with longer warm ischemia time. There is increased rate of bleeding and urinary leak is also reported. Longer ischemia time of laparoscopic partial nephrectomy likely reflects the difficulty of renography with laparoscopy. So with the refinement of surgical technique and technology advances, these are gradually reducing. Simply, this is pictorial representation when this pedicle is clamped and partial nephrectomy is done. So laparoscopic partial nephrectomy, all patients undergo cystoscopic placement of ureteric catheter, and we usually keep indigo calamine methylene blue to see we inject through the ureteral catheter while doing the procedure to see the opening of PCS. So transperitoneal is better because of more space as compared to retroperitoneal approach. And I'm not going into the details. I will prefer to go for some videos if time permits. I think I've got some time. Professor Munir. Hello.
Sir, we have positive time. Please rush through the videos if possible.
Yeah, another 5 minutes for the video, sir.
Okay.
Very interesting videos.
Okay. So operative techniques, I will go for videos now.
Yeah, please.
I'm just skipping. You just say, even in many centers, they are using argon laser. we should not be hesitant to cut up to the PCS. It can be repaired easily. And then various hemostatic techniques. This is the clamping. Then definitely transperitoneal approach will be more easier, but definitely it depends on the surgeon's experience. Various hemostats are there, flow seal, etc. Pelvic calysae. So nowadays robot-assisted partial nephrectomy is also coming up, and it is really handy for the partial nephrectomy or nephron span surgery. And similarly, single site, less surgery is also done. So I'll go with this video quickly because we have to cover. So you can see this is the reflection. And the torts line, we really try to reflect the left-sided procedure. Partial nephrectomy, then inflection. I'm using harmonic
music. Can the music go down? Yes, sir.
Yeah, sure. So this is the so steps are reflection of right from the splenic flexure. Colon is dropped down, then we try to open the Girota's fascia. Some problem with the video. Dropping of the colon and then opening up the Girota's fascia, and we are just reflecting the mesentery now, medially. Colon is reflected, going upper polar dissection.
Okay, zero ischemia. Okay.
It's the upper polar dissection. Dissection at the splenic flexure. And now in the lower pole we are dissecting, you can see the ureter. Now dissection at the pedicle. This is the renal vein and this is the gonadal. We have lifted up. We usually use 3 to 4 ports for this. We can make the dissection with the harmonics at this level. The steps of radical nephrectomy and partial nephrectomy are almost similar up to this point, because we have to dissect the pedicle and then we see the tumor. And once tumor is seen, then we start dissecting, enucleating it, taking around 5 millimeter to 1 centimeter margin from the healthy part, and then start cutting it sharply. Don't use any cautery or this. Sharp cutting is the best, and try to go deeper and try to enucleate it along with the healthy tissue. I'll come back to this point again and subsequently in the next slide. So radical nephrectomy is the gold standard for the treatment of large renal cell carcinoma. Partial nephrectomy is not feasible. So contraindications for radical nephrectomy when there is single kidney renal insufficiency is there, bilateral renal cell cancer, and for hereditary renal cell cancer where there is multiple tumors, it is better to go for partial rather than radical. So preoperative patient preparation, right from antibiotics, then put in indwelling catheter, gastric tube for and we usually prefer the transperitoneal approach, more space to this. And for open flank approach as well as chevron, as I already described, these are the methods. If there is a tumor thrombosis there, I usually prefer the open technique, but now with the expertise, people are even doing robotic and laparoscopic nephrectomy, even in infrahepatic tumor thrombi, removal of thrombus and the repair of IVC. So management of intrahepatic and suprahepatic, so teamwork is required, and we take the help of cardiac surgeon and we control it. And even this type of suprahepatic tumor thrombus in RCC can be managed nowadays. Regional lymphadenectomy is concerned, it is not necessary for T1 and T2 tumors because this is commonly asked questions, and I think it will be beneficial for our postgraduates. It is not necessary for T1 and T2 tumors, but some authors advocate on the basis of retrospective studies. Lymphadenectomy is recommended from the crust to diaphragm to the aortic bifurcation, and especially for the visible all hilar lymph nodes are resected, along with the in advanced tumors with regional lymph nodes. And then drainage and other things and postoperative care, all is common in this case. These are the complications of radical nephrectomy. Almost similar to the partial nephrectomy, it is comparable. Mortality 2% radical, 1.6% in partial. In various series, if you say, hemorrhage is almost equivalent. Urinoma incidence is more with the partial nephrectomy. And more chances of reintervention, that is around 4.4% in partial nephrectomy. So risk of significant blood loss during radical nephrectomy is also there, and that is around 5%. The risk increases up to 35% if tumor thrombus is present. Then the injury to the neighboring organs, etc., it is very common. But with the advent of this laparoscopy, it has gone down significantly. And mortality is in the tune of 2%. I will share now a few experiences. This is one of the our case in the large 7-centimeter tumor in the lower pole. And in this case, we opted for partial, but patient many a times say no, they want complete removal of the tumor. This is one of the example of that, and we did the lap radical nephrectomy in this case. This is another case. The open surgery is still stood test of the time. This is a huge tumor with IVC thrombus. You can say there is IVC thrombus, and we did open radical nephrectomy with IVC thrombectomy with the extended chevron incision. This is the huge tumor, and you can see the tumor thrombus in this. Similarly, recently last week we have operated one of the case with the CKD patient with creatinine of 3. So in opposite side and right side was upper pole mass was there, and we did partial nephrectomy in this case. And patient is doing well, and we are supposed to remove stent tomorrow. So this is one of the case, even in CKD case, we can spare the kidney. This is another interesting case we did last week. That is right lower pole renal mass, you can see, you can appreciate in this CT scan with the pelvic calculus. So we did simultaneous left PCNL and right partial nephrectomy in this case in the same sitting. Is an international patient and is doing very well. We removed this tumor, around 5.5 by 6 centimeter tumor from the lower pole along with the PCNL. First we did PCNL, everything was okay. Then we went ahead with the partial nephrectomy. We took this consent that if everything goes off well after PCNL, then only we'll go for opposite kidney partial nephrectomy. This is one of the video of the partial nephrectomy. If time permits, very quickly I will go through this. again, we are doing the reflection very quickly, 1 minute video. It is interesting video. Reflection of the column will mobilize from the upper pole and lower pole. Then control the pedicle. That is very important. Control the pedicle. You can see we are approaching the pedicle now because we have to control the bleeding for partial nephrectomy. So take the control of pedicle. This is, you can see the artery. Then clamp it with laparoscopic Satinsky is available nowadays. There are various ways to do this. No need for hypothermia. After clamping, in 30 to 40 minutes, we can do the partial nephrectomy procedure. This is you can see the segmental arterial clamp was put. That is supplying mainly the tumor, and then we put this lap Satinsky in this case and started cutting this tumor. Go deeply to the normal margin and then cut it. Even we have opened the PCS, but you should not be scared of doing this. And by the simple, any bleeders can be taken control by few sutures. And then rhinography can be done very quickly. And within 30 to 40 minutes, we can finish this rhinography. I am using 2O vicryl in this case, and for the inner sutures, 3 or 4O vicryls. And after declamping, there is no bleeding. You can see. So we saved this kidney. It was almost 5 by 6 centimeter mass. And then again, reapproximate the girota around it to retroperitonize this. So this is very important, and then tumor is bagging is done, drain is put. So this is the way of partial nephrectomy. And if you go ahead at any point, this is the most important. If you are not happy at any point, we can go for partial to radical nephrectomy. If tumor is moved, if local advancement is there, then definitely we can go for that. Munir sir, is there any time available?
Well, I think you already overshot. We won't have time for a few questions.
We can take question along with this video. There is no problem.
Okay, problem. Okay, sir. This is
laparoscopic partial nephrectomy and radical nephrectomy are now gold standard in management of RCC. Any questions, sir?
Yes, sir. Very recent talk
in both partial and radical nephrectomy.
You have stressed the conversion. Nowadays, most of the cases which we are also doing are all partial. I think the ratio has gone is 1 in 10 now.
Yes, sir.
In 9 we do partial and 1 only, because I think that's also because of the earlier diagnosis. We are by ultrasound. We are picking up smaller tumors and they're coming to the surgeon very promptly. More awareness. So I just wanted to know from you, what suture you use in partial nephrectomy for closure?
I am using simple vicryl with larger needle, and we make it more straightened, 2O vicryl for rhinography, and for inner bed suture control is with the 3O vicryl.
Okay, you don't use V-lock. I found some advantage with that.
No, I'm not using V-lock for this. Really? V-lock is very, we are very happy with V-lock in this lap prostatectomy, radical prostatectomy, but not in case of partial
another point. Well, why do you control your bleeding by the Satinsky? Why not the bulldogs? Because I prefer the bulldogs.
Yeah. There are various ways. You must have seen for segmental artery, I have put bulldog. The segmental artery. And in one of this particular case, we use lap Satinsky is available. We use this lap Satinsky. Otherwise, there are various ways.
What do you do for the anterior tumors, sir? What do you do for the anterior tumors?
Anterior tumor?
Yeah.
Rather posterior
on the anterior
is difficult.
Surface of the kidney.
Easily we can manage with the partial.
Yeah, you can. What do you do? Just for
the posterior tumor, we have to mobilize whole of the kidney in that case. Another point, sir, for controlling the pedicle is very important. It can be done in various ways. Correctly told that simple bulldog can be used, and of course it should be marked. And then Satinsky, and third way is they put the vessel loop and then tighten it and put hemolock over it. It will work as a clamp. So all three ways are there to control the pedicle.
Do you find these bolsters or flow seal helpful? Or
bolster is not helpful.
What is your experience?
Yeah.
Sorry?
But flow seal for, I think for some satisfaction, psychological satisfaction, we can use.
We haven't used it, so we have seen people using it. Have you done any zero ischemia partial refractives?
Yeah, we have done. For the exophytic, peripheral tumors, we have done zero ischemia, just without clamping.
Clamped the vessels.
We kept everything ready for clamping. And then we started dissecting the exophytic peripheral tumor, and it came out we could enucleated it very well without any bleeding. Just few rhinorrhaphy sutures, that is okay.
Right.
So all
do you have any experience?
Said that limit of worm ischemia should be around 30 to 40 minutes, but we should not keep our eyes on our clock. Also,
very right.
That will, we can create more complications with that. We should be fast, and our mind clock should run very fast in that way.
Right.
And we should not lose a single minute on this.
Sir, do you have any experience with a retroperitoneal partial nephrectomy?
Retroperitoneal, I have not done much. Only one or two retro, and it's very easily we can reach to the pedicle. But space is one of the limitation. Those who are accustomed to the retroperitoneal surgery, I think it's a very good option because minimal dissection is there, and we are not going through the transperitoneal. So post-op ileus and all these things are very rare. So
Dr. Manzoor Saab, you have questions?
Yeah.
Yes, sir. Do you put just one question, sir? Do you put stents after partial nephrectomy to prevent urinoma formation or anything, any indication?
In majority of times we are doing with the just putting uretic catheter. That is very useful. During PCS closure also we check by flushing with the methylene blue from down. And simple 2-3 sutures are enough. And if you have any doubt that PCS is open, quite significant area is open, then we put stent. I have regretted once or twice by not putting the DJ stent. We kept uretic catheter and it came out after 2-3 days, and then patient developed urinoma, and subsequently we went in and we put double J stent.
Okay, thank you, sir. Can we move?
Thank you with this. Dr. Manzoor Saab, kindly call the final speaker.
Thank you so much, sir.
Thank you, sir. So the next speaker, Professor R. Manikanandan from Jipmar, Pondicherry, and his talk will be on the robotic radical cystoprostatectomy. Professor Manikanandan, sir?
Yeah.
Yes, sir. Please. Welcome, sir.
Thank you, Vishnu.
Good evening, one and all. Our chairperson, delegates, it's a great pleasure in accepting your invitation to participate in this program. I straight away, because of lack of time, I'll straight away go to the presentation. So I will talk about robotic radical prostatectomy. So the learning objectives in this lecture will be on the principles of robotic surgery for bladder cancer, the surgical anatomy, patient positioning and trocar placements, surgical steps, complications, oncological outcomes, and most importantly, the comparison of robotic radical prostatectomy with open radical cystectomy. Is the outcomes comparable? So for the postgraduates, so what constitutes radical cystectomy? Radical cystectomy is removal of the diseased urinary bladder, which is involved with the transcell carcinoma of the bladder, or squamous cell carcinoma, which is very uncommon, along with the prostate. Then as a part of the cystectomy, we have to do pelvic lymphadenectomy bilaterally, and then the urinary diversion. Urinary diversion can be either ileal conduit, contained cutaneous reservoir, or a orthotopic near bladder. So the principles of surgery depends upon most important and foremost principle is maintenance of the oncological safety. That is to avoid urothelial cell seeding, because when there is a breach in the specimen, and there is seeding of the urothelial cells, malignant urothelial cells, can lead to local recurrences as well as in port site recurrences as well. Can lead to peritoneal carcinomatosis. So in order to avoid this, that's very important to maintain the integrity of the bladder and the prostate while doing a robotic cystectomy. Second, we need to do a meticulous lymph node dissection, not to leave a micrometastatic disease, which can lead to local recurrence. The most important thing in minimally access surgery for bladder is to keep the bladder suspended to the anterior abdominal wall as long as possible, to avoid the bladder falling onto the camera and preventing a dissection on the lateral pedicles. It's very important to handle the ureter delicately to avoid thermal energy near the ureters and to maintain the advantage of the ureter, so that there is to avoid the ureteral ischemia, which can later lead to ureteral strictures, and adoption of nerve sparing procedures when appropriate in appropriate patients. So coming to surgical anatomy, it's when you look at the bladder, particularly in the male patients, the superior aspect is covered by the peritoneum, and over this lies the small bowel as well as the sigmoid colon. Infralaterally, there's the levator muscles and the obturator internal muscles. Posteriorly, it is related to the upper part of the peritoneum, and then it is the rectovesical space. And anteriorly, the space of Ritzius and the pubic bone. So when you introduce a laparoscope or a robotic telescope, this is what the anatomy looks like. So these are the important landmarks you will see when you introduce a telescope before starting a cystectomy. So this is the bladder, this is the urachus, this is the obliterated umbilical artery or the medial umbilical ligament on both sides. This is the vas deferens, and after you do a lymphadenectomy, you have a clear exposure of the vessels, the common iliac artery, external iliac artery, internal iliac arteries, the psoas tendon, genitofemoral nerve, and the gonadal vessels. This forms the lateral boundary for the lymph node dissection in case of cystectomy. And immediately there's the sigmoid colon. So identification of all these landmarks are critically important when we are doing a robotic cystectomy. So the patient, when chosen for robotic cystectomy or the laparoscopic cystectomy, is placed in a steep Trendelenburg position supported with the Allen stirrups. So typically 4 robotic arms are used, the robotic camera and the 3 robotic arms for the instruments. Basically scissors, fenestrated forceps, and a probe grasp for retracting the tissues. And then 2 Aston ports are employed. Either it can be a 10 mm or a 12 mm, depending upon whether you want to use a stapler for intracorporeal diversion. The port placements are of 2 types, either in the triangular format as an SI system of robot, that's the previous version, and the newer XI or the X system, the ports are placed in a straight line. And typically the camera port is placed about 4 to 5 centimeters above the umbilicals to help in the thorough dissection of the urachus and to bring the bladder down, as we will see in the later part of the presentation. So steps of radical cystectomy. It is the cystectomy starts with dissection of the right and left ureters. Then we go on to the posterior dissection. Then develop the posterior plane near the level of the rectovesical pouch. Then we divide the postlateral pedicles both on the right and left side. Then the bladder drop is performed. Then we divide the dorsal venous complex, and then we do the prostatic apical dissection to delineate the urethra. So once the cystectomy is performed, then we do the lymphadenectomy, which is performed bilaterally. That we remove typically an extended lymph node dissection is performed. The removal of the lymph nodes along the common iliac, external iliac, internal iliac, obturator, and the presacral group of lymph nodes. Lymphadenectomy is very important in order to prevent local recurrences as well as to eliminate the micrometastatic disease. The lymphadenectomy is known to directly correlate with the overall survival of the patient. So I'll show a video of a robotic cystectomy which we have performed. The cystectomy starts with the mobilization of sigmoid colon. Then we identify the left ureter, and then it is mobilized along with the adventitial tissues close to the left vesicoureteric junction. And then the ureter is clipped with a hemolog clip of the attached thread. So this attached thread helps in the intracorporeal urinary diversion part doing the ureteroenteric anastomosis, which we will see in the second part of the video. So once the ureter is detached on the right side, on the left side, the dissection continues on the right side the same manner till the uretrovesical junction. So the right ureter is identified, it is lifted, it is cleared of the surrounding tissues, and the right ureter is clipped at the vesicoureteric junction, and then the ureter is disconnected. So in high risk cases, we send the proximal ureteral margins for frozen section. Next step is the creation of development of the posterior plane, where incisions made in the rectovesical or the pouch of Douglas. And then the dissection is carried forward anterior to the denominal fascia up to the mid-prostate level. Then the right and left postrovesical pedicles are developed by swimming technique, where we go up to the pubic bone and separate all the tissues medially, which are going to be dissected along with the bladder. Then once the pedicles are defined, then we use either staplers or vessel sealing devices to eliminate the pedicles, divide the pedicles. So similarly, once they're done on the right side, then we go on the left side, and then we divide the left postlateral pedicles as well. Advantage with the robot is the three-dimensional vision as well as the magnification, which is of great help for the surgeon compared to pure laparoscopy. So once this the posterior dissection, lateral dissection is done, then the bladder is dropped by dividing the urethra from the anterior down wall. So the dissection continues up to the pubic bone to eliminate the space of red sears. This red sears space is developed, then we ligate the dorsal venous complex, which is an Achilles heel when you are doing a cystectomy, where you have a torrential bleeding can happen from this space. But during robotic surgery and laparoscopic surgery, because of the pneumoperitoneum, the bleeding from this space is generally
sparing होती है ना,
so
उसमें vessels dorsal venous complex कैसे ligate करते हैं?
So the dorsal vein is ligated by a grinding knot, and then they are stitched in down. So this is very important to have a good hemostasis at the level of the apex of the prostate, and then to identify the prostate, and then you develop to divide the apex of the prostate. So similar technique is being practiced in robotic radical prostatectomy as well. So here now you can see that the urethra is prepared, and then the bladder is being prostate is attached to the urethra. Now we see the catheter is being clamped and is going attached on the urethra.
उसको बोलना ना, उसको पूछना दोनों बताने.
So now we divide the posterior wall of the urethra, and the specimen is packed in the specimen bag. So next we come to lymphadenectomy. So the lymphadenectomy starts along the axillary artery, and we meticulously remove all the fiber particles by the standard written road technique.
Kindly mute your mic.
Sorry, somebody is keep on talking. So the limits of dissection include laterally up to the genitofemoral nerve on the psoas tendon, and posteriorly up to the obsteter nerve. So these will be the limits of the dissection. As you can see, we can the obsteter nerve is coming into view. So we need to be spend time to remove all this fibrofatty lymphatic tissue, because if you compromise on this, that's a chance for local recurrence of the disease. So this is the lymphadenectomy on the left side. Now we come to the lymphadenectomy on the right side. Similar technique is followed. First we dissect along the axillary artery. The technique is that both the great vessels have to be skeletized, and all the lymphatic tissue has to be removed in toto. The robotic vision helps the surgeon in completing this task in a very comfortable manner. So once the cystectomy is performed, now comes the second stage of surgery, that is the urinary diversion. Both the ureters have to be implanted into a bowel segment, which the diversion can happen either intracorporeally or extracorporeally, whether it is done within the using a robot or do an open surgery. So I'll just show an overview of doing an orthotopic neobladder, which we have done intracorporeally robotically, which we have performed. So the first step involves isolation of the small bowel. A segment of about 54 centimeters is isolated on a vascular pedicle, as shown on the picture, by using the staplers. So once this bowel is isolated, we the dependent part of the bowel is anastomosed to the neourethra by a continuous suturing technique. The third step, we detubularize the bowel. So now we want to make a pouch. This pouch is made by detubularizing the small bowel, and then making using intracorporeal suturing, we make it in a hemispherical shape to act as a urinary reservoir and to reduce the bladder contractions of the inherent to the small bowel. So they will replicate the native bladder with as much as possible by this technique. And after the new bladder is created, the ureters are implanted into the apex of the new bladder, which is typically called as the chimney. this is about 14 centimeters of chimney, and the pouch is about 40 centimeters of the small bowel. So this can be done either intracorporally using the robot, or can be done as an open technique. So the next video, I'll show how we performed an intracorporeal orthotopic neobladder. So first we isolate the small bowel segment, where we select about a segment of the ileum, distal ileum, about 15 to 20 centimeters from the ileocecal junction. And we divide the small bowel using a prefixed markers. Then the bowel continuity is restored by using the staplers. Once the bowel continuity is restored, then we bring the dependent part of the small bowel to the urethra, which we have already dissected out, and then the uretrovesical anastomosis is performed robotically. This is the most difficult part of the surgery, where you need to bring the bowel down to the pelvis to anastomose to the urethra. So doing this surgery in the deeper male pelvis is facilitated by the robotic surgery with the 3-dimensional vision and the magnification. So this is similar like a robotic radical prostatectomy, where the bladder is anastomosed to the membranous urethra, apex of the membranous urethra. Here, instead of the bladder, we are using the pouch neobladder. So using a continuous technique, using a special sutures called as V-lock sutures 30, we suture the urethra to the small bowel. The assistant from the perineum, he guides the surgeon by inserting the catheter to help the surgeon to identify the lumen and take the mucosal bites. So as you can see that we need to identify the lumen continuously during each and every suturing, so that we can do a meticulous mucosal anastomosis and to prevent urinary leakage in the postoperative period. So once the new urethra is anastomosed, then we detubulate the small bowel segment to make the hemispherical pouch. So this 40 centimeter of the small bowel will be opened along the antimesenteric border. So once the small bowel is open, initially the posterior plate is formed by suturing the two walls of the urinary bladder. Once that is done, then we close the anterior wall over it to create a pouch. This is done by continuous technique using the V-lock sutures. The advantage of this suture is that it has got barbs on the suture, which helps in maintaining the traction and continue the suturing. Next, we anastomose the ureters to the small bowel, apex of small bowel, which is called the chimney, by using a 40 vital. So we spatulate the ureter and then we anastomose the ureters to the small bowel. Once the anterior wall is done, then we stent the anastomosis by using an ureteric catheter or a stents. This helps in stenting the anastomosis and helps in healing and reduces the urinary leakage as well. So once the right ureter is done, now we are doing the left ureter. So as you can see, this robotic cystectomy with the intracorporeal neobladder involves multiple surgical steps, and you need to follow a standardized technique in order to avoid complications as well as to reduce the operation room time. sometimes initially we take about 6 to 7 hours to complete the procedure. But as we keep on doing it, now we do it within about 4 to 4.5 hours. Sometimes when we have difficulty, we have two teams. One team does the cystectomy part, and the second surgeon comes and does the urinary reconstruction part. This will reduce the fatigue and this will speed up the operation time. So we are placing the guide wire into the ureteric anastomosis and then closing the anterior wall over the anastomosis. These two ureteric catheters will be ultimately brought outside through the anterior abdominal wall, and it will be connected to the urostomy appliance. So the initial couple of days, the pouch is free of urine, and it helps in healing of the newly made neobladder and also reduces the chance of urinary leakage. So we come to the complications. So since it's a complex procedure, we expect that it has a higher complications. Complications can be due to bleeding from injury to the iliac vessels, can be due to bleeding from the bladder pedicles. One of the most important bladder complication is the rectal injury. In an advanced bladder cancer, like a T3B or T4 cancer, when the brain is lost with the rectum, during the learning curve, there are increased possibilities for rectal injury. So one has to be very, very critical in assessing anatomy, in choosing these cases and preventing a rectal injury. Then urinary leakage can happen from ureteric anastomotic site or from the newly created neobladders. Bowel leakage can come from the small bowel resection anastomosis. One of the most common complications we see after cystectomy is the paralytic ileus. About 50 to 60% of patients after either open surgery or robotic surgery end up in paralytic ileus because it's a very morbid surgery, and the bowel handling as well as due to the increased lymphatic leakage, most of these patients land up in paralytic ileus, and age is also an important factor for this. And complication due to pneumoperitoneum as well as positioning of the patient in the extreme Dunderberg position. This can also cause effects on the cardiopulmonary function of the patient and can lead to severe morbidities. So now the concerns is the robotic cystectomy is some authors have reported there's increased chance of local recurrence, the port site recurrence, as well as peritoneal carcinomatosis after robotic surgery due to the effect of the pneumoperitoneum, as well as high-grade complications and costs. So when you look at the literature regarding the oncological outcomes of long-term oncological outcomes of robotic assisted radical cystectomy from the largest group, that is the International Robotic Consortium group from the US, which is being pioneered by Kushik Guru, you will see that the outcomes, the local recurrence, as well as the overall survival, the progression to the survival rate depends upon the T stage of disease. The higher the T stage, that's greater than 3 or above, that's has a higher incidence of local recurrence as well as the progression to survival rate is lesser. When there's lymph node positive versus negative, the patient with lymph node positive disease has a higher chance of local recurrence as well as the margin positivity rate. If a surgeon has leaves a gross disease behind, then obviously the local recurrence is going to be higher. But if oncological principles are followed, then the consortium group reports that the outcomes of robotic cystectomy is comparable to open radical cystectomy. So this is a randomized trial published in Lancet, which is called a RAZOR trial from multi-institutional trial from the United States, which was pioneered by Professor Deepan Parekh from the University of Miami, where they looked at the outcomes of robotic cystectomy with open cystectomy, a randomized trial, mainly looking at the non-inferiority of robotic surgery over open surgery. So at the end of the study, they found that the progression-free survival rate at 2 years is comparable between the robotic arm and the open arm, and an acceptable equal complication rate between the two groups. They hence concluded that robotic cystectomy was non-inferior to open surgery with respect to 2-year progression-free survival rates. There was a recent systematic review published in Cochrane group where they looked at the similar outcomes of robotic surgery with open surgery, analyzing the literature published in the last 10 years. So they also reported the same outcomes with respect to time to local recurrence, major complication rates, quality of life, and positive surgical margins, where robotic cystectomy is comparable to open cystectomy, with the slight advantage of robotic group having a lower transmission rates and shorter hospital stay, probably due to the effect of the pneumoperitoneum, better vision, three-dimensional vision, as well as the use of staplers, which has contributed to the lower blood transfusion rates. So, in conclusion, I'd like to conclude that robotic radical cystectomy is a very complex surgical procedure. As you have seen that it involves multiple surgical steps. There is a need for standardization of the steps, need to be repeated again and again to avoid complication as well as to speed up the surgical technique. Oncologically challenging, not to avoid positive surgical margins, both the removal of the primary disease as well as doing lymphadenectomy. And functional outcomes are most important for patient satisfaction. That is the lower blood loss, the sexual functional outcomes, the continence outcomes. These are all very important from the patient's perspective, rather than looking at an open or a minimal invasive surgical procedure. At present, the technique is expensive, particularly in countries like India, but as technology advances, there may be a reduction in the cost as time goes on. We have to wait for the time where the robotic instrumentation as well as comes down, as well as newer robotic instruments will come into the market. You have to be very cautious that the reported outcomes are from the fewer high volume centers worldwide from Europe and the United States. So when young surgeon starts robotic cystectomy, they need to be very cautious in adopting those outcomes to their institutions, particularly when they have a low volume. Low volume, they say it's less than 20 cystectomies per year. So initially, there is bound to have complications because this is a procedure which involves multiple steps and with surgery on the urinary system as well as surgery on the bowel segments as well. Hence, there is a need for a dedicated team for optimal outcomes. Probably more than one surgeon should participate in the early surgeries to get accustomed to the surgical technique, and we need a dedicated operation room team to have a better outcomes. Thank you.
A very limiting talk. Doctor, which robot you have the XI available with you?
We have an XI system, sir, in our institution.
Okay. And you have any experience with the Cambridge one? Because that's cheaper. Maybe more of the centers can be using that. Any experience with the Cambridge one in your city?
No, sir. Nobody has. Probably people are saying that they are similar to the first generation SI robot. There are still some teething problems. People are saying.
Okay. Now, do you prefer making the orthotropic bladder intercorporal or by open?
So the preference is to do
robotic or open.
The preference is to do open surgery because not all patients insist on an intracorporeal diversion, and it reduces the OR time significantly and reduces the cost. At least in our scenario, we have not found a great difference in open surgery or robotically. But some people, when they insist doing intracorporeal diversion, then definitely we offer this technique.
Yeah, what is the difference in the time?
The time difference is extremely different. In the first initial 15-20 cases, we were operating for about 7 to 8 hours. Then as we standardized the surgical steps, the time came down drastically. So now we do about 4.5 hours, 5 hours.
With the cystectomy part, and then including the open orthotomy bladder?
Diversion parts. Cystectomy parts usually goes very fast. In an hour or so, we finish the cystectomy part. The diversion part takes time.
Okay. And what are those cases where you had a rectal injury? What do you do in those cases? You cover it by ileostomy or colostomy, or
Two cases we had a rectal rent about 2.5 centimeters were there. So we took the help of our gastro colleagues. So they closed the rectal defect and then placed momentum over it. And we avoided neobladder in those patients. We converted into intracorporeal ileal conduit straight away in those patients. So that was the technique we followed. We didn't have a compulsion to do a covering ileostomy in those patients because the closure was very very meticulous because of the three-dimensional vision in the pelvis. So that was a great help using the robot.
Manzoor sir.
Thank you, sir, for this informative lecture. Interesting and informative. Sir, one question, sir. What are the preparations for a successful pre-operative preparations for a successful radical cystectomy in general for the postgraduates? How do you prepare this?
That's very important. Yeah, that's now we have come to the point that there's a lot of push for what is called as the ERAS protocol is there, where you need to motivate the patients that the patients have to quit smoking, has to they be preload the patient with carbohydrate loads till up to 4 hours before surgery. No ball preparation is undertaken. Those kind of mechanical preparation or peg-leg ball preparation have been, antibiotics have been stopped. They are compulsorily put on prophylactic enoxaparin for thromboprophylaxis. And then the most important thing is that you need to encourage the patients for breathing exercises. The pulmonary function need to be optimized, and patients need to have physically fit. They are advised to walk for at least 2 kilometers every day. And then the next post-operative day, they are ambulanced from the bed. So these are the very important parameters for good outcomes, post-operative outcomes in cystectomy patients. We start fluids next day. So to avoid the paralytic ileus, we give anti-emetic agents, prokinetic agents. We don't insert nasogastric tubes into these patients. So there is a set of about 20-25 parameters, pre-operative, intraoperative, post-operative parameters, which we practice to achieve better functional outcomes in these patients.
Okay. And how do you manage the post-operative pain? Anything special in the robotic surgery for the post-operative pain? Or
patients, most of our anesthetists prefer to put an epidural catheter, continuous epidural infusion we give, bupivacaine infusion we give. We avoid morphine. That's a very important thing to reduce the paralytic ileus as well. So either we give injection, infusion, paracetamol infusion, and along with the epidural anesthesia. That is the standard in our institution.
Thank you, sir. Any comments from the chairpersons? Is anyone available? They can unmute their mic.
I think we must profusely thank Dr. Manika Nandan, who has prepared to share his academic work. The talk was excellent. The video was excellent. And the way you made it sound so simple was commendable. Kudos to you, sir.
Thank you, ma'am. Thanks for the invitation, and it's a great pleasure to be part of this academic program and among the luminaries of your institute. Thank you.
It's great to have you with us, sir. Thank you so much.
Thank you.
Thank you.
Sorry, you missed Maghrib.
Yes.
Now Isha is the time.
Yeah.
Bye-bye.